to the fourth. I'd like to welcome you all for the fourth Midwest Women in Cardiology Virtual Symposium. This was started by Tanya and Ms. Rory about 3 years ago. This is the fourth year we are having it. Since then, we have had Kentucky and Nebraska host it, and we are honored to be hosting it this year. It's a great occasion for us to celebrate our achievements while we also discuss how we can keep going forward and get better together as a group. At this moment, I'd like to acknowledge not just the people who are here, but also all the physicians before us over the last few hundred of years, the female physicians who kind of laid the road for us and made it possible for us to think of achieving this dream and made it a possibility for us. I would like to also acknowledge all the women who went a step further, women cardiologists who went a step further into leadership roles and made it possible for paving the way for more of the younger generation to imagine themselves, see themselves, and role model themselves as leaders. At this time, without talking about the COVID pandemic, I think it'll be incomplete. So the pandemic changed life for a lot of people, for almost everybody, but the section which was most affected, as shown by multiple studies, was really working women and balancing everything in life. It really affected this part of the group of population the most. And without saying anything, it goes to say that you guys, what you're doing, taking care of your patients, taking care of your families, taking care and supporting everybody else around you, have shown tremendous resilience and tremendous energy during all this. So a big shout out to everybody for doing everything that you're all doing. So again, this is a day that we will celebrate and to our own achievements as well as the achievements of the people around us. And at this time, I'd like to just remind everybody to please keep your microphones muted unless you're the speaker. And please feel free to use the chat. The chat is open. You can just introduce yourself, tell us about yourself, pass your comments, pass your questions, whatever else you want to do. So the chat is open. We will have a good discussion. We have kept enough time after each session so that we can have a moderated panel discussion. So please feel free to put your comments, your questions, your thoughts, whatever else you want in the chat box. And for the first session, we have the keynote speakers discussing about leadership and women cardiologists. And I'm going to let Aruj. Aruj is our second-year cardiology fellow and our fifth week chair for the Iowa chapter. She's going to be introducing the speakers and taking over from here. Over to you, Aruj.
Thank you, Dr. Ashwath. Good morning and welcome, everyone. Thank you for joining us today. It's with a lot of excitement that I introduce our first keynote speaker, Dr. Vera Rigelin. She's a professor of medicine at the Northwestern University Feinberg School of Medicine in Chicago, Illinois, and she's also the medical director of the echocardiography lab at Northwestern Memorial Hospital. She has served as president of the American Society of Echocardiography from 2017 to 2018. Dr. Rigelin is active in professional societies, including the American Society of Echocardiography, the American Heart Association, and the American College of Cardiology. Thank you very much for joining us today, Dr. Rigelin. I'm going to hand it over to you from here.
Thank you very much. I really appreciate the opportunity to speak to you. And I want to especially thank Dr. Mahi Ashwath for inviting me, as well as the rest of the committee. And I am trying to share my screen. And it looks like there is. Huh. My slides are not showing up on.
Is it not letting you share? Vera?
Yeah. It's not allowing me to share. Hold on. It says to open my preferences. I'm sorry.
Autumn, she is kind of a co-host, right?
There we go. If you want to try again, it should let you.
Yeah, it's not.
Yes, no?
It is not. I may need to change some of the preferences on my computer to allow sharing. Suba, do you want to go ahead and go while I work on this? And I apologize for this glitch. Maybe if Suba wants to go ahead while I try to figure out what's going on here. Is that okay?
Autumn, can you make sure Dr. Raman is also co-host? Or?
I'll try and
Yep, I can do that.
share my screen.
Okay.
Can you see that?
Yeah.
Okay.
Yes.
Well, thank you, Dr. Ashworth, the program committee, and I hope everyone is safe on this somewhat somber day, perhaps a day to rejoice renewal, and those who have gone before us and sacrificed so much so that we can be here. I'll talk a little bit about my journey and who helped me along the way, speak to leadership and my present role at IU Health and IU School of Medicine, trying to reduce cardiovascular disease and enable better health, and then consider critical skills and opportunities for each of us to develop as a leader, and importantly, inspire the next generation, pay forward on those who believed in us. And really, for me, it was so much about timely guidance. I always wanted to be a doctor, but what do I do after high school? Someone had spoken to my parents that, there's this field called engineering that combines students' interest in math and physics. There was a summer program that I got into prior to my senior year in high school, which really was very cool. And so I was in the honors program at Ohio State and was able to combine pre-med with a thesis in electrical engineering. And my advisor really encouraged me, said, graduate school is something you should consider. Was able to secure a National Science Foundation fellowship and deferred my med school acceptance to attend graduate school. And then came back to med school. Here too, great opportunities that were inspired by people that said, get some external experiences. So I went to Mayo in Rochester. The field of informatics was very nascent at that time. Worked on, this will date me a little bit, but the then new chickenpox vaccine, and then went to Kalamazoo, Michigan State, and also in the informatics realm. But really more than the specific content, I got to see program building, front row seat, and how that was done. And then as went through rotations, thought about different areas, maybe pediatrics, radiology, surgery, and then really had the tremendous privilege of learning from a true exemplar. Earl Metz was a hematologist, and I said, wow, that's the kind of doctor I want to be, just in terms of, someone who embodies that statement from Francis Peabody, that the secret of the care of the patient is in caring for the patient. And I said, well, I don't know exactly what to do, but internal medicine sounds like it would be a good next step. And I had, again, great mentors, leaders by example, Dr. Allen in pulmonary critical care. And then I had a really inspiring female mentor that Dr. Fontana, one of the very early women in cardiology at Ohio State, and really I think anywhere across the country. She was one of the pioneers of treating individuals with congenital heart disease, and someone who just kind of knocked it out of the park in everything that she did. Her actions just spoke so much louder than any words that she conveyed. The other amazing woman that I was able to cross paths with was Dr. Bernadine Healy. So Dr. Healy, as I'm sure hopefully all of you know, had an illustrious track record directing the Women's Health Initiative at the National Institutes of Health, has served as president of the American Heart Association, American Red Cross. Dr. Healy was the dean of OSU's College of Medicine and handed me my diploma, as I was walking across the stage, and importantly, recruited someone who was really influential, in my development as a cardiovascular physician scientist. Pascal Goldschmidt came from Hopkins to be the head of the Davis Heart and Lung Research Institute at OSU, as well as the chief of cardiology. And he said, we're going to build a cardiac MR program, and I'm going to, go out and find the top person from around the world. But I want you to, be ready if this is an area that you want to help with, and I'll send you, a way to get some training. So he said, okay, I'll go to Wake Forest University, met Dr. Greg Hundley, who's now at Virginia Commonwealth. And Greg remains a great mentor and friend to this day. After, some time after finishing fellowship, thought, okay, Pascal's recruiting some rock star, to be the head of CMR at OSU. None of the people that they were trying to recruit came. So I raised my hand. I said, I need a job. I've got some skills, and I'd be happy to work with anything, any opportunity to build something new. And so they said, okay, we'll give you a shot. And then 2002, when I joined the faculty, conversations were starting about, what should go in this new Richard M. Ross Heart Hospital that was being built at the time. And so I was very fortunate to have a seat at the table talking about how having advanced imaging technologies embedded in this facility, accessible to patients and clinicians, research scientists, trainees, would be so important. Had a tremendous tenure at OSU, 17 years on faculty, got to work across many different disciplines. And we built a very robust set of clinical services, research enterprise, training programs. And it's really fun to come back to meetings like SCMR, where I can see former trainees who themselves are now leaders around the country and in other parts of the world. So then in about middle of 2019, I'm doing my thing, pretty happy at OSU. I get an email from IU School of Medicine. And it looked kind of generic. I wasn't sure, if it was something they just sent out to everybody, if they were actually looking for me, saying, we're recruiting for a leadership position in CV. Here's the link to the job advertisement. And I thought, even if this is sort of a broad call for applications, wouldn't this be a tremendous opportunity personally to keep growing, building on what I had done, and truly being able to pay it forward. So I joined IU, was very fortunate to secure the position, and started kind of the beginning of 2020. You could say, wow, good timing, Suba. Pandemic sort of kicked off at the same time that I did. Nonetheless, the institution's been incredibly supportive to say, keep going, use this as a great opportunity to think about change management, disruption, as all of us have seen, the ability to question things that we assume are the way that things have to be, don't necessarily need to be so. And so the Institute has given me an opportunity to bring the relevant CV disciplines together as one team that in an academic health enterprise is a place where people come to get the highest quality heart and vascular care in their community, while also enabling relentless innovation. And I think one of the neatest parts about this is the distributed nature of the IU health system, the IU School of Medicine with 9 campuses across the state, truly serving urban, suburban, rural populations, and recognizing that, we have people who come through different doors. It shouldn't matter which door you come through. You should have access to the same high caliber care specialists when you need them to have a good outcome. #1IUCE. So, one thing as you consider your leadership opportunities, think about those you serve. So I started in putting our strategic plan together, thinking about what affects Hoosiers, what are the leading causes of death and disability in Indiana. Number one, as is too often the case around our country and around the world, is heart disease. And with interactions across other entities like diabetes and cancer. So how can we really drive towards more personalized and predictive prevention of things like ischemic heart and vascular disease events, arrhythmias, heart failure, and set up some foundational excellence in family-based care, cardiometabolic science, and informatics and imaging. Oops, sorry. I would say the other thing that I've learned and continue to learn is that it really serves you well in achieving your vision to empower your teams. Bringing diverse voices around a table, making sure that those quieter voices have a place to say something, because without those perspectives, your ultimate outcome is not going to be as good as it can be. And so one thing that I've been able to do with our quality and clinical effectiveness teams is really restructure how we serve patients as multidisciplinary teams. So, for instance, our coronary and ischemic heart disease council is led by an interventionalist and cardiac surgeon, with imagers, with system pharmacy, supply chain, nursing, and so on. And each of these groups has a seat for a trainee, so a fellow resident that really aspires to make an impact. We have to really be intentional about creating trainee opportunities, because they're the future, they're the pipeline. And I hope there's some fellows on today. The other thing that helps, I think, is facility with data, and more facility with big data. So here's one example that we're working on in terms of how do we enable embedding novel algorithms into our clinical workflow, and being able to ask the right questions, figure out who are the people that can help you, make sure that for the individual patient, the wisdom of what we learn from thousands, hundreds of thousands of patients or more is synthesized at the point of care. And this is a concept I'm sure many of you may be familiar with, which is the learning health system, that we continuously improve by learning from what we do every day. And then financial acumen, cannot be overemphasized. We have such meaningful missions in our work, taking care of patients, teaching, doing research. How do we maintain the necessary margin to achieve those missions? And it's a team effort, across what we generate through clinical revenue, extramural support, philanthropic funding, and putting all of this together means really aligning those supporters, those resources, in ways that there's much stronger impact than anything that we could be doing separately. And so I'll conclude, and I'm really looking forward to the discussion portion of this morning's session by suggesting you can develop, I try to continue to develop as a clinical leader, taking initiative, planning ahead, volunteering for opportunities. In research leadership, it really is tremendous time, effort, and broad mentorship. What is really exciting is we think about the innovation that occurs increasingly at the interface of disciplines. So for instance, cardiologists, cancer specialists, at that intersection of cardio-oncology, making an impact where neither one of us would be able to do that in our individual silos. How do you develop administrative leadership? By working with organizations like the ACC, your state chapters, locally, regionally, and nationally. And then at every step of the way, lending a hand to those who follow. One, it's incredibly helpful to people, who are fellows, residents, students across the spectrum. But I always learn something, from them. The questions that people ask keep me on my toes and help me become better at everything that I do. So some take-home points. I think leaders do their best by recognizing where we can do better and then rolling up their sleeves to actually do something about it. We definitely need more diverse leaders. The ultimate solution is going to be much better with a variety of perspectives than without. And develop yourself as a leader in various spheres of life. You know, this is not just something in your day job, so to speak, but looking for opportunities where you can share your ideas, energy, and support builds muscle, you know, builds your strength as a leader. And gratitude is truly, I think, such an essential attitude. I'm here really this morning to thank all of you and those that helped me along the way. And I look forward to the discussion. Thank you.
Thank you very much, Shubha. That was very informative. I'll let Aruj go ahead and take over.
Thank you. Thank you very much, Dr. Shubharaman. I guess as a fellow in training, for me, what stood out the most was that your journey took you through multiple different paths, and yet you got to the position where you are today with, like you said, a lot of support, and I'm sure a lot of challenges as well. So any advice for someone who's starting their career, I guess for all the fellows who are listening in today, what in terms of challenges that we face every day in training or questioning ourselves or facing hurdles or difficulties, what advice would you have?
Thank you so much for that question, Dr. Khan. I think the nature of life is that challenges are inevitable, but challenges help us grow. And coming to each day as viewing it as an opportunity for growth helps you view challenges as you know, sort of it stretches you. It makes you more than what you were the day before. Keeping that balance, you know, where things can definitely get you down. Having experienced that, find that optimism, you know, to tilt the scale a bit, you know, in a positive direction. Those would be some thoughts.
Thank you. Thank you.
I think we'll go ahead and let Dr. Regolin speak at this time. Aruj, do you want to introduce her?
Yes. Thank you, Dr. Regolin, for joining us. I'm just going to go ahead and introduce you once again. So Dr. Regolin is joining us today. She's professor of medicine at the Northwestern University Feinberg School of Medicine. She's also the medical director of the echocardiography lab at the Northwestern Memorial Hospital. She has served as president of the American Society of Echocardiography from 2017 to 2018, and she's active in multiple professional societies. She's a part of the American Society of Echocardiography, the American Heart Association, and the American College of Cardiology. Thank you again for joining us, Dr. Regolin. I'm going to hand over to you.
Thank you so much, and I apologize for the little glitch that I had with my slides. I recently upgraded my computer, and as usual, sometimes upgrades are downgrades, and I had to readjust the settings to allow sharing. So I apologize for the delay, but I look forward to presenting to you, and I again want to thank Dr. Ashwath and the organizing committee for this conference for asking me to share my journey with you. And I have no disclosures that pertain to this presentation. So just a little bit about where I started out. I grew up in Chicago, and I went to the University of Michigan for college, and then went to med school at Northwestern University, and also did my residency and internship residency at Northwestern as well. And then I went to Duke University for my cardiology fellowship. I do have to give a shout out to Annabelle Vogelman, who I know is on this call, who I met when I was at Northwestern. And I can't remember, Annabelle, if I was a student or resident or what I was.
You were a student, Vera.
Was I a student?
Yes.
And Annabelle was a fellow. And Annabelle was my hero when I met her, because I knew I became inspired to be a cardiologist when I was a med student. And it was when I attended an educational series that was started by 2 attending cardiologists who, believe it or not, took time out of their Saturday mornings to do a seminar for med students where they took patients and actually brought patients and talked about their diseases, and we all got to listen to their hearts. And I thought it was just the most fascinating thing in the entire world. And that opened up my eyes to cardiology and realized I wanted to be a cardiologist, but I had no idea how. And then I met Annabelle. I'm like, wow, Annabelle's so cool. And she's a woman, and maybe I can do this too. So thank you, Annabelle, for starting my journey. So then I went to Duke for my cardiology fellowship, and I finished my fellowship in 1995, which means I'm kind of an old lady by now. And here is a picture of the group that I really became close to at Duke. Here are my 2 mentors, Tom Bayshore and Kevin Harrison. And I was the only female in my class. There were 12 fellows, and I was the only woman. And here are some of my buddies. This is Kitty Kislow, who was a research sonographer who worked for Tom. And this group was very influential in my growth as a fellow, my early development as a cardiologist. And even though I was the only woman in the group, I was treated like an equal, and I really had a really terrific time as a fellow. And I'm very, very grateful for the opportunity that I had at Duke. And a couple things that I learned, and just also to set you the stage of what life was like when I finished my fellowship. So the first ACC Professional Life Survey was published in 1998. And these are some of the statistics that I borrowed from that publication that pertain to the time frame of when I was finishing my fellowship. So again, I finished in 1995, and these are statistics from 1996. So at that time, 46% of internal medicine residents entered subspecialty training. About 12% of them entered cardiology training, and only 5% of practicing cardiologists and 10% of adult cardiology fellowship trainees were women. So this is the environment that I was in at the time of my training and when I left my fellowship to start my job search. And this is in comparison to about 1/3 of internal medicine residents being women, and 22.5% of them were entering subspecialty training. So very, very few women at the time were entering cardiology training. And we are still suffering from low numbers today. So we've made some headway. We're not there yet, but certainly we're better than the statistics that I show you here back in the mid-1990s. So what were some of my early lessons from my fellowship and then the environment that I was living in? So one is pursue your passion, even if you're in the minority. So even though that there were only 5% of practicing cardiologists and 10% of women that were cardiology fellows, that was my passion. This is what I wanted to do. I didn't care if I was the only woman out of these 12 fellows in my class. I was going to do this. So pursue your passion no matter what. And the other is that men can be great mentors and role models. So when I was a fellow, we had very few female faculty. And if I were to choose only women to be my mentors, I would have no mentors. And the 2 men that were very influential as mentors to me, Drs. Bayshore and Harrison, really helped form my early career. And so I'm very appreciative to them. And it shows that, you know, it's great to have female mentors, but there's very few of us. So men can be great mentors too. And so take advantage of that. So back in the 1990s, even though there were very few of us, as you can see from this slide, there were a lot of women that were really being very influential. Suba had already mentioned Bernadine Healy. And then there's a nice list of other individuals that were pioneers at that time. The American Heart Association was also noticing that women were on the verge of becoming very important leaders and needed extra support. So the AHA Women Cardiology Committee was established. And as mentioned earlier, the Women in Cardiology Section Professional Life Survey was published in JACC in 1998. So we were, you know, even though there are a few of us, there were still a pretty powerful group. Although I was pretty young at this time, so looking at these very influential women, I really didn't have, I didn't really think that I could ever be in that kind of category. But I decided to start my life anyway, and my husband and I made the decision at the time that we were going to establish ourselves in Chicago because of personal family reasons. Both our families are here. We have the same core group of friends, and our personal relationships were our priority. And we decided that no matter what, that this is where we were going to settle. And that has really persevered throughout my career, and that I have focused my career in the Chicago area. And I am happy to say that I've had a lot of opportunities here, but it did limit some of other opportunities that came along that I did turn down. But that's a decision that I made, which is very important to me, and I have no regrets about that. And that's another lesson is, you know what you want and be happy with that, and set your priorities and know what makes you happy. And my personal life is extremely important to me, and having my family nearby, especially now that both my husband and I are experiencing helping care for aging parents, being close to family is even more important. Now, when I moved back, again, it was in 1995, I thought I really wanted to do an academic career, and initially started my search only in academic medical centers, and found that there really were no jobs available at the time for the skill set that I had obtained during my training as a fellow. And so then I started shifting my search to private practice, because again, I really limited my search to the Chicago area. And that's when kind of reality hit for me. And the job search at that time, I was actually very disheartened by it. At the time, again, thinking about the few women that were in cardiology at the time. So almost every single group that I interviewed with had no women. And the topic of conversation always seemed to fall back on how many children I wanted to have, how much time I was going to need to take off for maternity leave, and how was I going to find coverage for the time that I wanted to take off. And I thought that was very unfair, because none of my male colleagues were being asked those questions. And after all the hard years of training that I had gone through, many of these groups didn't even bother to ask what my qualifications were for the job. They were more concerned about how much time they would have to take to cover for me if I chose to take time off. So I was very, very disheartened. But being a person who's the glass is half full instead of half empty, I became happy that those attitudes came out during the interview process, because it allowed me to see what these groups were like, and that I didn't want to join them. And I was happy that I found out the truth about some of these groups during the interview process to help me in choosing the right group. Fortunately, and this all happened actually while I was sitting waiting for an interview with one of the groups, the interviewer was running late. So he's like, okay, while you wait, here's the latest journal of JACC for you just to read while you're waiting for the interview. So I was flipping through the Journal of American College of Cardiology. And at that time, all job postings were in print. And I found the advertisement for another job in Chicago. So I kind of made a mental note of it. And then when I got home, I actually called the recruiter and interviewed for another private practice. And this group actually had a woman in the group. And she kind of took me under her wing, actually invited me to her house for dinner, and I got to meet her family and talk to her at more length, and eventually went and worked with that particular group. And I would have to say that that particular woman was the influence for me to take that particular job. So I ended up spending a year in that job and found that I experienced a great deal of personal growth in terms of gaining confidence and taking care of patients on my own, not having an attending looking over my back, and really realizing that the training I had during my fellowship really did prepare me for helping to take care of patients. But I really found that I was not completely satisfied with the job, and that an academic career was more to my passion. When I decided to take the private practice job, I called the chief of cardiology at Northwestern, who at the time was Bob Bono, and explained to him that I was taking this private practice job because there were no academic jobs available. But I had this inkling that academic life was still in my cards. And in the future, if there was an opportunity that arose that fit my qualifications, if he could please keep me in mind. And approximately a year later, as I was driving home from work one night, a phone call came from Bob Bono, and he said, "Vera, a job just opened up. Are you still interested?" So I actually went, interviewed for the job. And after about a year, I went back to Northwestern and became full-time faculty there. And that's where I've been ever since. So what were my lessons during this job search? Is one, that people tend to gravitate to groups that are like them. So it's really important for us women to make ourselves visible and make sure that other women realize that these careers are possible, and that we need to be out there to attract more women to be in this great field. And people like Annabelle and this other woman who I interviewed with at that job were clearly influential in my choices of my career and where I was going to work. Know what you want. So I got a great deal out of that year in private practice. Again, I really refined my clinical skills. I really gained confidence as a clinical cardiologist, but realized that my passion wasn't being filled. And then I chose to, look for other opportunities. So don't stay in the same job if you're not happy. There are lots of jobs out there. There's lots of opportunities out there. So make sure that you're happy with what you're doing. And if you're not, find something else to do. And network, network, network. I think that the fact that I had called Bob Bono on the phone when I took the other job and said, "Hey, keep me in mind for future opportunities," that once something came up, he really remembered that conversation and called me, and had changed my career forever. So I then moved to Northwestern and became a non-invasive cardiologist with a subspecialization in echocardiography, and became one of the principal readers in the echo lab. And I developed a general cardiology practice with a focus on valve disease, which is what I really had subspecialized in when I was a fellow. And I also focused on clinical research, attained several grants that allowed me some protected time to help me develop my academic career. So what were my early career lessons? One, find your niche. Especially if you're an academician, it's really important to find something that you're really good at, that makes you stand out and that you can focus on. And mine was in cardiovascular imaging and in valvular heart disease. Make a name for yourself. So by really becoming an expert in your field and making yourself known, you start making yourself known, and people start to know you, and your opportunities will come from there. And have a 5-year plan. Okay, know where you want to go, and then figure out the best strategy on how to get there. Seek out mentors who will help you reach your goals. And again, sometimes they're women, and sometimes they're men, and there's no reason why you just have to have one mentor. You may have a mentor that's going to help you with writing your grants, another mentor that may be helping you navigate professional societies, or whatever it is that you're passionate about. Seek a mentor early to help you make that 5-year plan and figure out how to achieve it. So then I moved on to the transitioning to mid-career, and I tried to figure out my next 5-year plan. So my first 5-year plan was to get into the academic world, start finding my niche, getting good at my niche, making a name for myself, and moving up that ladder. So I kind of achieved that, and then I tried to figure out, okay, what's next? So I made an appointment to speak to my chief, and Bob Bono was still my chief at that time. And I took the initiative to make an appointment with him. He did not say, hey, Vera, what's your 5-year plan? Come talk to me. So that's the other thing, is we have to be proactive for ourselves. So I came to him and I said, Bob, I'm trying to figure out what my next step is here. I have this feeling in me that I can do more for this division, that I have a lot of energy, I have a lot of passion, and I'm really happy with what I'm doing. I'm happy to be here, and I want to give more to the institution. And I'm really looking for moving up the ladder in leadership, and want to be one of the, I can help this division be a top tier division. And I just want your advice and your help on how to get there. And he said, Vera, that's really great. However, right now, I don't have anything for you. I said, it's okay. I'm patient. I'm here. I just want you to know that I am interested and that I want to do this. And I want you to be aware of my intentions. So when opportunities arise, you'll think of me. And about a year later, he came to me and said, yeah, Vera, remember that conversation that we had? The current cardiology fellowship director is moving. Would you like to take over that position? And I said, yes, I definitely want to take over that position. So as a result of that conversation that I had a year earlier, he thought of me when the cardiology fellowship director position came open, and I took over and then became the fellowship director for Northwestern. So I did that for about 5 years. And then the Echo Lab director at Northwestern left. And he took several people with him. And that left our Echo Lab in a lurch. We were short on readers. We had no leadership. Everything was in shambles. And at the time, everything seemed really dire. We were like, my God, what are we going to do? Blah, blah, blah. So it seemed like a crisis. So I sat down with Dave Melman, who is another echocardiographer from Northwestern, and said, David, we have to figure out what to do here. It's up to us. We are now the 2 most senior people here, and it is up to us to decide what to do. So we made an appointment with Bob Bono again and said, Bob, we need your help, and we're going to strategize and figure out how to get us out of this. We're going to start recruiting new people. We're going to rebuild the program. And Bob said, okay, go for it. I'll support you in whatever you want to do. So David and I really set out to rebuild the Echo Lab. We recruited new faculty. We worked with the organization to change our whole sonographer organization and pretty much rebuilt the Echo Lab. So David and I, for about 2 years, were co-directors, interim co-directors of the Echo Lab. And then he stepped aside and I became the medical director of the Echo Lab myself and continued the building process. And I'm happy to say that we've built one of the best Echo Labs in the country. And here is the picture of my Echo Lab that was taken a couple of years ago. And throughout this time, it has really been a building process and a huge growth time for me. As I said in the beginning, when I took over, we really had to rebuild from scratch. And I'm proud to say that we've really built an outstanding group of people who are academically gifted, clinically gifted, and really a wonderful group to work with. But we've definitely had our challenges. And I would say COVID is an example of a huge challenge that we had. And as you all know, Echo became a very instrumental tool for COVID patients. So our sonographers were called to scan almost all the Echo patients. So we had to come up with protocols and safety measures and all sorts of different techniques and strategies that we had to do in order to take care of these very sick patients, yet keep all our staff safe. And then also, how are we going to train our fellows? We had to reduce people in reading rooms and do things remotely. And it just was a huge undertaking. But we got through it, and I'm happy to say that none of our staff contracted COVID in the workplace. If any of them contracted COVID, it was out in the community. But because of the safety measures we put in place, nobody got sick as a result of a patient in the hospital. So what were my early to mid-career lessons? Be proactive of what you want. Don't wait for your chief to ask you for a meeting. Set up the meeting yourself. Know what you want and go after it. Don't be shy about promoting yourself for positions that you feel you're qualified for. Pay attention to your appearance, posture, and voice when you go in for that discussion with your chief. Go in there with confidence. Practice in front of a mirror before you go in there to make sure that the way you're presenting yourself, that you look confident, you look strong, and that you look capable of doing whatever it is that you're asking for. And here's just a cartoon of Superwoman doing the power pose. So I'm not saying that we're all going to go in there doing the power pose, but this is how you should feel. When you walk into that office, you should feel powerful, you should feel confident, because if you do, that's going to reflect on the person that you're talking to and increases your chances that you're going to get whatever the position is that you're rooting for. So shifting over, that was kind of my journey through my home institution. And I've now been the Echo Lab director for about 11 years. And I'm in the process of negotiating what my next step is. So I have a new 5-year plan. And I can't share that with you right now because it's under negotiation. But I have to say that I took the initiative for this again because I feel like I need to think about what my next step is. And I'm in the process of negotiating what that is. So just shifting quickly over to involvement in professional societies. So I think it's important if you are in academic medicine, not just to achieve and strive and succeed in your own institution, but it's important to expand your horizons to opportunities outside your institution as well. And that's where professional societies come in and can be really helpful. I personally am a fellow at the American College of Cardiology, the American Heart Association, and the American Society of Echo, and have been an active member in committees of each of the societies. And what are the lessons that I've learned? One is start your journey in your professional society by getting involved at the local and national level. And this is how you start, make a name for yourself, and then more opportunities will come. Volunteer for committees and projects that you're passionate about, because that will give you more pleasure, more satisfaction, and more motivation to do well. And if you do well in these committees and projects, that's how you actually move up the ladder within the societies. Deliver on your promises. Don't sign up for things that you don't think that you can do, and only sign up for things that you know you're going to enjoy and that you're going to be able to deliver. Because if you sign up for something or volunteer for something and you don't fulfill those obligations, you're not going to look very good, and it's not going to help you in the end. Seek mentorship. These are great opportunities for mentors, and we cannot find all the mentors that we need in our own institutions. When you're in a professional society, it opens up your opportunities to meet people from all over the world that have a whole different skill set, and then that really helps you in your own personal growth. I do have to give a shout out to Linda Gillum, who I met through the American Society of Echo, who has been a wonderful mentor to me in my professional growth. Understand the process to leadership. You're not going to know how to grow within a space without knowing what that process is. So understand that process and then, seek it. And then be strategic. And once you know the process, you know how to grow within that society, then be strategic in how you go about choosing what you're going to be involved with. And then support and promote other women. Here's a picture of me with several other female cardiologists. I think this was at the Euro Echo meeting. And this is a group of cardiologists, and we made a point to have dinner together at every single conference. And we would sit around at dinner, first chit-chatting about how each other was doing, and then strategizing on how we were going to help each other grow and promote ourselves within our professions. And I do have to say that within that, myself, Patty Pellica, Susan Wiggers, and Judy Hung, we actually all became presidents of the American Society of Echo with the help of each other. And Rosa is an Italian cardiologist who's very prominent in her country as well. So if we stick together and we help together, stay together and help each other, we can all be successful. So the other thing is build relationships. It's really important to attend social and networking events because it's going to help you in your professional relationships. And when they say it's who you know, it's really true. Because once people know who you are and see all the great things that you're doing, then when opportunities arise, they're going to think of you and give these opportunities to you. And these are just some pictures of different social events that I went to based on the different conferences that I've attended, and all people who I feel have been instrumental in helping my professional growth. Now in ACC, ACC has terrific opportunities for professional growth for cardiologists at all phases of their careers. This is just a list of the different things that I have done through the ACC that has really, I have found a great deal of pleasure and really has helped me in my professional growth as well. So lots of opportunities in the ACC to get involved. In terms of my strategy for the ASC and how I became president, I actually started out as an active committee member and then moved on as an active committee chair, then became chair of the scientific sessions, then applied and became onto the board of directors and then the ASC executive committee. That allowed then me to become president. And now I'm the chair of the ASC Foundation, a charitable arm of ASC. I'm the board chair and the associate director of the ASC Leadership Academy. So this is just an example of the strategy that one uses to climb the leadership ladder within a society. And this template is very similar at the ACC, AHA, and other societies. But wherever it is that you want to grow, understand what that strategy is so you know how to strategize your own career.
Vera, this is very helpful. I just wanted to mention that I think we'll probably have to close pretty soon.
Yes, thank you. I apologize for carrying on. My last final words for everybody is to have fun, okay? This is, you spend a lot of time at your job. You spend a lot of time doing what we're doing. So you have to enjoy yourself. So don't do something that you're not passionate about, that you're not enjoying yourself. Have fun and enjoy the ride. So with that, I thank you for your attention.
Thank you both very much. Thank you, Vera and Shubha. That was very informative. Just seeing your journey and how you come to being where you are, I think has kind of opened the minds of a lot of people. I just want to pose one question out to both of you is, as you take on more responsibilities at work, whether it's through the societies or your own job, for instance, becoming the chief at IU or becoming the Echo Lab director and the program director and the president, how do you balance out? I mean, do you give up something, or I mean, how full does your plate get before you say, I need to back off? How do you deal with like burnout and issues?
I think that's a great question. And I do think that you have to look at all what your responsibilities are and remove things from your plate that aren't essential or that are not helpful to you in achieving your goals. And that's where I think you really need to be mindful of what your goals are and what your 5-year plan is or whatever your plan is and where it is that you want to go, and be strategic about how to get there, because you can't do everything. So you really have to take a very careful look at everything that you're doing and make sure that those things that you're spending a lot of time doing are things that are going to be helpful to you in the end. So be strategic.
Shubha, you want to add something?
Sure, thank you, Mahi. Well said, Vera. I would only add that family, is tremendous to keep you centered and, really say, what the heck are you doing, and scale it back. That's been, I think, a good lodestone, if you will, to keep your plate from getting too full.
Awesome. Aruj, did you have any questions from a fellow's perspective? Or
Dr. Regelin, I had a question that I wanted to direct towards you. You mentioned that you started off with private practice, but you felt that it wasn't the right fit for you, and you came back to academic medicine. I was wondering what it was that drew you back towards academic medicine in particular, what you felt was lacking in private practice?
Oh, that's a great question. And and I am not here to bash private practice at all. Private practice is obviously extremely important. It's just knowing what you want. I wanted a role in research. I wanted a role in education. I wanted a role where I could be involved with, actively involved with professional societies. And that wasn't the priority in the private practice that I was in. Not to say that that's not possible at other places. There are private practices that are more hybrid. And remember, this is back in 1995, 1996. Private practice was very different back then than it is now. So the opportunities available to me at that time did not allow me to pursue the passions that I wanted in terms of education, research, and involvement outside in the professional world. So those opportunities just were not available. And so I needed to seek something that allowed me to do that. And remember, as I said in the beginning, one of my priorities when I started my career is that I was going to be in the Chicago area. So I really had to look for what were my options there. And private practice at that time in the city of Chicago did not offer those opportunities for me. And that does by no means does it mean that for other people today, which is many years from when I finished my fellowship, and in different cities and in different formats, that those possibilities may exist now, but for me, they didn't at that time.
I think Poonam has a question.
Great talk, Dr. Regelin. I'm Poonam Valgapudi, one of the early career members and chair of the early career section. So I just had one quick question, and there's a lot of senior leaders here who've been in cardiology for a long time and may be able to answer. So you said when you took a job for a year, you called your chief and said, hey, if there's opportunities to call you back. How is it, what do you think about from the practice side? The people who are actually hiring you. If you're joining with an intention of leaving, is that something that, I think it's concerning, right? Because every time we hire new people, there's a lot of things that goes on behind the scenes. So I just want to hear from you on that side, along those lines, since now you're probably hiring more people. If you had someone who was going to join you and on the same day calls somebody else and says, hey, please give me a call if there's an opportunity.
Yeah, no, thank you for that question. And, I think when I joined the practice, I did not join with the intention of leaving. I did when I signed, I still had some reservations because my plan in the beginning was to go into an academic job, which is why I called my chief. But I went in there with the attitude of, you know what, maybe this is my destiny. And I'm kind of the sort of person like things happen for a reason. And maybe there was a reason why my path was moving in the way that it did. And maybe that my role was in private practice. And by no means did I go there with the intention just of working for a year and then leaving. And I looked at it as, maybe this is what I was meant to do. And I'm going to discover something new that I didn't plan for before and be happy with it. There were a lot of things that happened in that practice that nobody in the practice was happy. Let's put it that way. There was a lot of things that happened there aside from my own desire for an academic career that played into my decision to leave. So I think your point's well taken, and I hope I didn't misrepresent myself, that I was being false when I applied for that job, because when I took it, I did not have the intention that I was going to leave. I was going to give it my full attention, and if it was going to turn into something that I was passionate about, that I would continue to stay there. But it turns out that I wasn't happy, and really many people in that group weren't either.
I think it's interesting that we always discover a lot more about a group once we join it than we knew at the interview point. So it's not uncommon that I think people change their mind after they start work at any place. Usually people say that it takes about 1.5 to 2.5 jobs to find your perfect place that you want to stay in. I think, I'd like to thank both Shubha and Veera for their input and information this year. Just for the younger generation, I think they both highlight the importance of having multiple mentors. I mean, multiple mentors give you information and direction about multiple things, and also seek out the mentors and the sponsors who are going to support you in your journey, in your whatever you want to achieve, right? I mean, I think it's really up to you as to what you choose to. So thank you both very much. And I really appreciate all the advice and information you shared with us today.
Thank you very much.
Moving on to the next session, we're going to be discussing about addressing barriers in the cardiology workplace. The moderators for this are Jared Bunch. Jared is a professor in cardiology at the University of Utah. He's also the president of the Utah chapter of the ACC, and he's very actively involved with the Heart Rhythm Society. Then Lakshmi Mehta. Lakshmi, I'm sure, is very familiar to most of you all. She's very active. She's the first female president of the Ohio ACC. She's very actively involved with the ACC, AHA, multiple committees, papers, and so on. And Nagalakshmi Nagarajan is our second-year cardiology fellow, and she's going to bring in the FIT perspective for this session. So I let Jared, Lakshmi, and Lakshmi take over.
Hi, Dr. Ashwaz. Thank you very much, and thank you for this excellent conference and the invitation. I was asked on behalf of the other moderators to introduce our session, which is a great pleasure for me. We have some outstanding speakers to address barriers in cardiology. Some I know personally. Dr. Susie, as she's known on her Twitter handle, Dr. Figoski, is an outstanding member of the electrophysiology community and really is one of the influencers that help us to distill information and understand information. And Dr. Hayes is actually a mentor of mine who was kind enough to look after me and help me in my training at Mayo Clinic. So seeing familiar names is a pleasure, but I think this will be an outstanding session really to help us understand the process of career development, opportunities for improvement, which are clear, and really how to navigate, which at times can be a difficult environment that's foundational a little bit, but hopefully evolving in a better way for everybody involved. So it's a pleasure to generally introduce the session, and then I'll turn it over to the other moderators to specifically introduce each speaker. Hi. I have to introduce the first Dr. Susie Figoski is at Iowa Health, and she's going to speak about imposter syndrome. And again, she's somebody that actually embodies the opposite of this in the EP community and is an outstanding speaker. And so I'm looking forward to this talk. Dr. Figoski.
Thank you, Dr. Bunch, and the moderators, and Dr. Ashwath and Dr. Khan for inviting me to be amongst giants. Let me try and share my screen here. Okay. Everybody see that okay? There we go. I'm going to speak on imposter syndrome. I am an electrophysiologist at the Iowa Heart Center. I don't know why it's listening to me. So I apologize. These are my disclosures. Only one is relevant to this presentation. Does anyone know how to get rid of that? But anyway, so what we're going to talk about today is what is imposter syndrome? How do you know if you're affected by imposter syndrome? How does it affect our performance in our job and our promotion and development in our careers? And then what can we do about it? It's estimated that at least 70% of people will experience imposter phenomenon throughout their careers and in their lives. And most of that is during transition periods. So it is normal to feel like an imposter during periods of growth when you're going from a medical student to a fellow or a resident. It is natural to feel as though you don't know what you're doing for a period of time. What we're going to talk about is when it persists and when does it become a problem. I actually had the opportunity to meet Dr. Chance at a Women in Medicine Summit in Chicago in 2019. And she and her partner, Dr. Imes, were both psychologists, introduced the term of imposter syndrome or imposter phenomenon in 1978. What they noticed in their clinical practice was that very accomplished women were feeling as though they were imposters and were frauds and were eventually going to be found out by their peers to not be qualified in their professions. They believe that your success is due to an external source rather than your own internal merits. And so this is a picture of me at Venice Arrhythmias, which would be the place where I experienced imposter phenomena the most intense. And I have to admit was one of the worst lectures that I've ever given in my whole life because I was so intimidated to be there among such great people. These are sentences that I am embarrassed to say that I have said out loud. When I was in undergrad, I went to the University of Florida and was accepted into the medical honors program, which was an accelerated program, and thought that they needed a Latina to fill out their 12 spots. For Venice Arrhythmias, I became very close with Dr. Olshansky, who has been an excellent mentor to me, who is not in my institution, who I did meet at a meeting. And so again, to reinforce finding mentors that are men and not necessarily your institution. I am a member of the American Board of Internal Medicine Cardiovascular Governing Board. I nominated myself. And when I got the position, I asked if I was the only one that interviewed. I mean, these are things that I'm embarrassed to admit, but these are things that I feel. And so there are a lot of imposter phenomenon questionnaires or scales. The most referenced is the Clance Imposter Survey. And I'm hoping that I can link to it here, and probably because it was the first one that was developed. Oh, the link is there it is. So it's 20 questions that really talk about how you view success, how do you view being reviewed, how do you receive accomplishments. And I think it's really powerful to reflect on who you are. And then the score is graded. So if you score less than 40, you probably are doing fine. I'm embarrassed to say that my score was very close to 80 on this survey, and realized when preparing for this talk that I might have a little bit of work to do. So the higher you score on this survey, the more that it's affecting your life and your clinical practice, and really important to then use that information to improve and see how you can do better. So what do you feel when you're suffering from imposter phenomenon? One is a dread of evaluation, because what you're internalizing is that someone's coming to talk to you to tell you that they understand that you don't know what you're doing. You're afraid that you're going to be viewed as incompetent, and you're really terrified of failing. When you do succeed, you don't really internalize that success as a merit of accomplishment and something to feel proud of, but you feel ashamed because you don't feel that you deserve it. Generally, people who suffer from imposter phenomenon are very anxious, very perfectionistic, and also overestimate the intelligence of others, so that you view your colleagues and your peers as having additional knowledge that you yourself don't have. I found this to be incredibly helpful. This was a paper in CHEST that really broke down subtypes of imposter phenomenon, really based on personality characteristics. So the perfectionistic subtype is that anything less than perfection is considered failure. So if you give a talk and you stumble over your words, you failed. If you give a presentation and you forget an important slide, then you're a failure. Then there's the subtype who really grew up doing very well in school, where achievements became very easy. So the person who didn't have to study for tests, who really aced through school. And then as you get further in your career, when you realize that things are difficult, you feel as though you are not understanding what you're doing, you don't deserve to be there. The superwoman, which again ties into the last lecture, where you need to do everything and do everything well. And I think women in particular, where we have responsibilities at home and raising children and trying to juggle all of that and be good at all of that all of the time, and to have that expectation that everything needs to be great all of the time is really unrealistic. The expert, where you need to know everything about every subject, and that if you don't know the answer to every question, you're a failure. And I would say that I fear being asked a question that I don't know the answer to and panic a lot about that. And then the soloist, who thinks that you can do everything yourself. So if you have to rely on a team, that somehow you are a failure. Oops, excuse me. They did do, trying to find surveys about imposter syndrome in medicine is difficult, and I couldn't find anything specific to cardiology. Imposter syndrome is not a DSM-4 diagnosis. And also these surveys are, there's no gold standard. And so the surveys really aren't utilized and can't be compared necessarily to each other. So they did do a survey of medical students and found that nearly half of female medical students suffered from imposter syndrome. And if you remember that Dr. Clance and her colleagues thought that it was mostly in women, but what these surveys are finding is actually it's just as common in men. What I did find interesting, and I suspect if we did this survey in cardiology, that it would be very similar to surgery, where there is a preponderance of male physicians with high intensity of needing perfectionism in accuracy in diagnosis and management, where it's high stakes, high mortality, that the imposter syndrome was significant or severe in a much higher proportion. And I suspect that that would be very similar in cardiology. So what is the professional impact of imposter syndrome? So what you might think is that the imposters are the ones who really aren't putting themselves out there. But because medicine self-selects for type A, high achievers, the imposters are actually the ones that are working the hardest because they're so afraid of being found out. And so these are the physicians that are working long hours, spending extra time, putting in the extra effort to give presentations because they want it perfect. What they do is they won't volunteer themselves if they don't feel as they're an expert in that area. So it can lead to reduced self-growth, self-satisfaction, and really not feeling as though you're fulfilling your opportunities. Because of this, these physicians are more prone to burnout. So those physicians who suffer from imposter phenomenon are more likely to be burned out. They're also not taking care of themselves, and they're really not internalizing any positive feedback. Also, anxiety and depression are very common in these individuals. As an electrophysiologist, this reminds me of reentry, and it's a very self-perpetuating cycle. So what happens is you're given a project to do, a lecture to give, a talk to give. You spend a lot of time feeling anxious about it. Oh my gosh, why am I given this? Am I qualified? And then you do one of two things. You spend forever critiquing it, nuancing it, or you wait until the last second to do it, because that way you don't have to worry about being a perfectionist. Then you give this talk, you do a great job, you get positive feedback, but you don't internalize it. Then you think, oh my goodness, I fooled them again. And then the cycle perpetuates. And most people suffer this in silence, because if you feel like you're a fraud, you're never going to admit to anyone that you're a fraud, because then you're revealing yourself. And so it's a very isolating and lonely experience. So what can you do to help break the reentrant circuit? What do you ablate is the way I like to look at it. And so the first thing is to really acknowledge your feelings. find someone that you trust, find a mentor or a colleague that you can experience when you're recognizing those feelings of self-doubt. Set reasonable goals. So set goals. We talked about 5-year plans, set achievable tasks, find a mentor. One of the things I'm struggling with, I'm in private practice, and I think a lot of that contributes to my imposter syndrome. Now we have fellows and teaching fellows. I can tell you that right now I'm running away from the fellows because I feel like I have nothing to teach, but I'm forcing myself to recognize that I am an expert and I have a lot to offer. Seek counseling to help you work through anxiety if that's what you experience, if you're experiencing burnout. And then one of the greatest things to do is look at your resume. When I submit my resumes to give a talk, I look at it, I'm like, oh my goodness, look at all of the things I've done. Like, is that me? Did I do all of these things? It's a reminder of all of your accomplishments. And I encourage you to keep looking at it and keep updating your resume regularly. And what can we do to help our trainees and our, if we're in academics or our younger colleagues? One of the things is to really create a supportive learning environment. I'm also dating myself. I did medical school in the early 90s and fellowship in the early 2000s. And it was a very competitive, a lot of pimping, a lot of humiliation on rounds. And I really think that we need to get away from that to create an environment that we accept humanistic qualities, that it is okay to make a mistake and that's how you learn and grow. When you have your fellows and trainees, really focus and give credit to things that they did themselves. You have excellent skills in doing this angiogram, or you were able to read this echo and see a unique finding. You're very smart, you're an excellent leader, you're efficient at doing your tasks. And then promote a growth mindset, that failure is part of growth. Failure is not a marker of inadequacy. And I think that we really need to work on that and continue to focus on setting goals. And then create an environment that, again, is promoting learning within oneself rather than continually comparing yourself to your peers. So in conclusion, I think that imposter syndrome and imposter phenomenon is important to talk about because I think it's much more prevalent than we realize. And I think that we have a lot of colleagues who are probably suffering in silence. I think that we believe that this is a phenomenon that affects mostly women, but as I've showed you, it's actually very prevalent in men as well. These colleagues are more prone to burnout and reduced professional satisfaction. Perfectionistic traits and qualities that make us successful in medicine also make us more prone to imposter phenomenon and burnout. And I think if we can create an environment where we're aware of this, that we promote self-doubt, vulnerability in medicine, it will bring us closer together and help us to achieve greater success. So thank you very much. I do appreciate your time, and it was really an honor to be here. Thank you.
Thank you, Dr. Figowski. That was an excellent, excellent presentation. And I think we really appreciate your candid nature because truly, I would agree that many of us, most of us, if not all of us, have suffered some degree of imposter syndrome in our lifetime, and how to keep it in check and balance is essential. That was an excellent presentation, so thank you.
Thank you.
Our next speaker is Dr. Sharon Hayes, who really needs no introduction. I'm an idol of hers since fellowship, but she is the founder of Mayo Clinic's Women's Heart Program, as well as she's the first director of diversity and inclusion at Mayo Clinic, and has really been a leading voice for the ACC in terms of our diversity and inclusion initiatives. So Dr. Hayes will be speaking about sexual harassment in the cardiology workspace. Dr. Hayes?
Yeah, thank you so much, Lakshmi and Jared. Does my screen look okay? Is it looking proper with the presentation mode? This is obviously a huge topic for which I'm going to say more than once, since most of the participants today in this meeting are women, it is not our job as women to fix sexual harassment. So in the brief time that I have today, I'm going to help put a definition around it, so we're all talking about the same thing, talk a little bit about prevalence, talk about what type of environment perpetuate sexual harassment, and then talk about what is the role of individuals, because even as women, we do have individual roles, but more importantly, the role of leaders, of organizations, and of the American College of Cardiology. I have no disclosures, so I'm going to start with the case. Dr. Betty Hernandez, she works in the cath lab. She is one of 2 women in the division, junior faculty. She's the only woman. The cath lab director and her primary mentor is Dr. James. The guys, and that's the other cath lab and fellows, they socialize and work out together at the gym. Projects are often discussed when they're together, and sometimes her colleagues fill her in, but usually she has to ask. And off-color and sexually themed jokes and emails are commonly shared. She's regularly introduced by Dr. Dillon, her boss, as Betty, but not Dr. Hernandez, and the men are all introduced by doctor. She's often assumed to be a member of the custodial or secretarial staff, and no one really corrects that. She's less often introduced as a co-author on manuscripts, and she doesn't have the same opportunities to lead and learn. So thinking about our prior speakers who had many opportunities or asserted themselves to lead and learn, she's feeling trapped. Further, in terms of mentorship, a faculty member has told her that he feels uncomfortable meeting with her as a woman in his office, and he won't mentor her, but he meets with the other fellows and junior faculty males there. But Dr. James, the lab director, he's a bit different. He insists that they meet off campus, sometimes over wine or a meal, and this makes her very uncomfortable. He's implied, if she doesn't, that he'll need to take her off a project that she created and needs for future career opportunities. And at an out-of-town ACC meeting, he insisted she join him for a drink in his hotel room. She got sick in order to avoid it. So she feels trapped, frightened. She's afraid to report her concerns for some obvious reasons, in that she's an only and that he's her boss. She is not sure how to navigate the situation, become a better cardiologist, and honestly is uncertain if she has chosen the right career path. So we'll put that on hold a little bit and then talk about definitions. So when we talk about sexual harassment, what people think about sexual harassment perhaps is a bit more what's happening to Dr. Hernandez. The sexual coercion, sort of threats to her career if demands are not met, offers of professional rewards for sexual favors, retaliation, and unwanted sexual attention. This is what we think about a lot, but what is far more prevalent is what's below the waterline. And that's more along what is the undercurrent or the underpinnings of sexual harassment, and that's gender harassment. So that's the sexually explicit jokes, images, sexist insults and remarks, obscene gestures, sometimes vulgar name calling, offensive comments, particularly about women's bodies or apparel or being moms. And all of that is on the setting of gender discrimination, which is not what we're going to talk about, but I think what you hear that I'm getting at, that it is a climate and a culture that sets us up for this. So in the National Academy of Sciences, Engineering, and Medicine put a seminal report published in 2018 about sexual harassment. It's a long report. I don't encourage you to read all of it, but there are some nuggets that really helped crystallize, I think, and activate the American College of Cardiology to tackle this. But some of the organizational risk factors for sexual harassment: few women in management, toxic leadership, identity-based or perhaps gender harassment and bullying, supervisors who are unsupportive of family concerns, sexist climate, and low psychological safety. And I think that some of us would argue that perhaps cardiology fits some of those as a profession, and certainly having traditionally been a male-dominated profession. That doesn't mean that all cardiologists are harassers or even that it's necessary, but you can see that some of the qualities that exist in our profession may set us up for this being more common. And I think the other point is sexual harassment does not stand alone. In environments like I just described that allow or support harassment, there generally is very little equity, because that system that supports harassment also supports inequities in compensation, promotion, opportunity, and leadership. So these are the reasons that we have to fix it. So that's what it is and how it can affect us and why cardiology might be at risk. What's the data that maybe we are? Well, Garima Sharma and colleagues, and I was honored to be a part of this writing group, had surveyed over 6,000 cardiologists, men and women across the world. About 23% of surveyed individuals were women, and 12% of them experienced sexual harassment versus only 1.3% of men, and this was 10 times more than men. The types of sexual harassment reported were primarily, half of the experiences were inappropriate remarks or touching, but there was also subtle bribery and less commonly threats and forced sexual behavior. I think importantly, among those experiencing any harassment, almost half reported more than one type of harassment. Very few sought help. And I think among those affected, there was a substantial effect on their relationships with their colleagues and with their patients. So there's impacts at every touch point. So another field, surgery, that's not unlike cardiology during training. This is a study, and there have been several sub-studies, where they did a sort of an in-service training. At the end of that online training, they had a questionnaire about mainly mistreatment, not just sexual harassment. So I'm going to present just a little bit. I will say that 70% of women surgical residents reported mistreatment during training, and that did include sexual harassment. But I wanted to break it down because this is another important part that we often don't think about. We think about colleague to colleague as workplace sexual harassment, but within these trainees, 20% of women and 4% of men reported sexual harassment. 31% of it, so equal with attending surgeons, came from patients and families. And among gender discrimination, almost 50% reported it came from patients and families. So this is an important part when we're talking about our climate that we work in, that we have to, and takes a very different approach, obviously, than Dr. Dillon. So another case or a scenario, so a female patient, this is anonymized, but a real story. A female fellow's male inpatient became more sexually provocative each day on pre-rounds when she was alone with him in the room. She didn't mention the behavior to the team because she wanted to handle it herself, and she was a little embarrassed by it, honestly. To ensure she wasn't giving off the vibes to her patient that she wasn't at blame, she told him that, with a very formal demeanor, that his behavior made her uncomfortable and to please stop it. He didn't really say anything. But at team round, so when the whole team was together with the attending, the patient demanded to be reassigned to a different trainee. The attending agreed, didn't ask any questions, and assigned a male fellow to the patient. And then they left the room with no discussion within the room or outside the room. She felt humiliated, unsupported, and ashamed, as we all probably would. And I think the reason we're talking about this and the reason we're taking a leadership stand and we all have to be a part of the solution is because consider this as an unsafe working environment. Sexual harassment is a severe occupational hazard, and it's analogous to other workforce dangers, whether it comes from superiors, peers, or from our patients, because we are physically, emotionally harmed, and we may not be our best, whether it's as a leader, as a learner, or as a patient care provider. So the other thing that the NASM report made sexual harassment as analogous to research misconduct. And actually the AHA, the NIH, and others are looking for how they can reframe misconduct, particularly by leaders and PIs, in terms of saying, this is just like falsifying data, because the outcome is that the science is not as good. And we have to remember that withdrawing from patient care or being not at your best or burnt out may impact patient outcomes. So as I said at the beginning, stop fixing women, because women disproportionately, but not solely, are the victims or the targets. And men can be, and individuals in the LGBTQ community also can be, but women by far in every study are disproportionately affected. So let's talk about upstander and bystander. So a patient asks you to join him in his bed. The attending says, that's not in our job description, ha, ha, ha. And so you hear, let's just get over it, take care of the patient. But if the attending were to say, or the leader, or if you are the attending, we aren't going to continue to take care of you unless you can respect our trainees. You hear, I'm supported, it won't be tolerated, my organization has my back. So as folks in you, because even if you are a fellow in training, you are a leader. There is somebody on the team who is looking to you, whether it's the medical student or the resident. So I think owning your leadership role at whatever level you are is super important. Leaders serve a critical role as trusted and familiar first responders. And how we as leaders respond to behavior like this, whether it comes from a patient or comes from a senior leader, speaks to us how this will be perceived and whether people will be willing to report or feel safe. So employees and trainees often don't speak out because they don't want to be singled out or blamed, like she's the troublemaker or the unconscious bias that she may have brought it on herself. And this is not an unreasonable fear in the sense that we know that for sexual assault, there's a lot of conversation about was she wearing, what was she doing? She shouldn't have been out that time of night. And I think refocusing this on the target, who is the victim, and I do use the term target because not all individuals want to be considered a victim of this. I think the other thing is teaching people how to intervene. I can tell you that I personally have been in situations where I was, even with my own knowledge and some practice in this, where I was caught flat-footed. Like somebody did or said something so egregious around harassment or discrimination that in the moment, I didn't have the words that were appropriate. That's why I have to practice. I have some script words that some of them you saw on the slides that you can step in and they come out of your mouth a little bit easier. So teaching and learning how to intervene in these situations rather than being a silent bystander is one of the most effective ways of stopping harassment and empowering people to take action. And this is an individual thing. This doesn't mean that leaders or organizations don't have it, but in the moment, we set a tone for the climate. Support is really critical for that target, and the target should have some agency and be the one that decides, am I going to continue to care for that patient or not? It is human nature to try to ease pain, and often it would say to that, perhaps that sexist patient, that we have now, if you think about it, she is already feeling powerless, and we further take away her power by saying you can't even care for that patient. Now, she may not want to walk in the room again, but let that decision be the individual and keep her safe. So to summarize, because I know we want to have some time for discussion, this is a complex problem that is linked to many other problems in the climate of medicine and in particularly in cardiology. And as such, while there is a role for individual action, it requires system solutions. And one of them is acknowledging that there is a problem, and data helps. This is grossly underreported, but having systems at your practice, at your organization, in your fellowship, where you know where to report, how to report, and knowledge that the organization is tracking this. Leadership clearly must drive these changes. And what we need to continue to do as a group, as cardiologists, is to address both the external, the divisive, icky language and environment, and the organizational structures that perpetuate gender inequity broadly, like hostile climate, perceptions of our field, cardiology, lack of diversity, parental bias. So addressing all of these because they support an environment with sexual harassment. And then our organizations need to take an aggressive stance and a consistent, transparent process for addressing not just sexual harassment, but racism and discrimination. And remember that is patient initiated. And then finally, providing training, but there is training and ways that you can teach yourself if your organization does not do that. So I look forward to the discussion. This is a big topic. It's one of those gnarly topics that there's it sometimes feels overwhelming on how we're going to do this. But I think leveraging each other and leveraging our organizations to lead is the way, and changing the climate of cardiology is really going to be the way that we are going to get through this. So thank you very much.
Thank you so much, Dr. Hayes. I know that's not the easiest topic to discuss, so I appreciate you taking the time to discuss that. I have no doubt all the females here have been mistaken more than once as, are you a nurse, or, you know, have been sexually harassed. And so in the interest of time, we have 2 more sessions. So I'm going to introduce Dr. Robinson. Dr. Robinson is going to be presenting practical tips for academic advancement. She is a professor here at the Department of Epidemiology and Medicine and the Director of Preventative Intervention Center. Thank you, Dr. Robinson. Thank you, Dr. Hayes.
Jennifer, we cannot hear you. I think you're muted. Jennifer, I think you're still muted. We cannot hear you. You're probably unmuted now. Do you want to give it a try?
How about now? Is this good?
Yes, this is good.
All right, sorry about that. I
No
have a
worries.
bad internet connection.
No worries, go ahead. Thank you.
Elon Musk Starlink, so I thought I'd call in, but that didn't work. So I thought I would just talk about, you know, why am I giving this talk? Who am I? And then things that work for me in the pre-social media age. And I would say they're probably still, it's still good advice. Let's see. So you can do your math, but I'm pretty old. I went to medical school a long time ago at the University of Minnesota, did my internal medicine residency there, was a clinical instructor while I got my MPH there at Minnesota. And I started writing papers then, and then this was a bad time for the NIH. And so we ended up in a private cardiology group in Des Moines. I ran the did lipids and did clinical trials for a number of years. And during that time, and I had little kids, and I was an adjunct professor at both Iowa State University and the University of Iowa. And just for those of you who maybe aren't in academia right now, you know, it took me a while to get to the University of Iowa with a faculty appointment in 2003. As an associate professor, this was in the Department of Epidemiology, which is where the clinical trials were housed because of strange institutional reasons. But the head of cardiology at the time was kind enough to give me a secondary appointment in cardiology, and I did the lipid clinic then too. And so I got busy writing papers and doing clinical trials, and was promoted to professor in 2010. So I've published over 300 publications, including you know, the top medical journals, multiple invited editorials in top journals. My H index is 83, so that means I've had 83 publications with at least 83 citations. I did innumerable lectures, I didn't even count them, AHA and ACC and NLA and other places. And I just got an email the other day that I was in the top 0.1% of scholars writing about hyperlipidemias over the past 10 years. And I now have a little button that says world expert. So kind of exciting. So how did I get there? Well, you know, I got that MPH, and I have to say that was probably the foundational training that I got to be a clinician scientist. And so I'd recommend that you, if you are serious about this, look into it. There's a Master's of Science in Clinical Investigation here at IO with the ICTS. And actually it was a lot easier during COVID because you could do a lot of things remotely. But if there's institutions in your area, give some thought to getting it, or even a certificate, because what this lets you do is get your data. Many of you have access to data, maybe with electronic medical records or other sources. You can do your own analyses. It's impossible to get a statistician to help you. They actually only work about 9 to 4 as far as I can tell. So they do better work-life balance than we do. But anyway, you can do simple analyses. You can start writing abstracts. What you need to do is start turning those abstracts into publications and submitting them. Always work with senior clinical scientists in your field. Ask for, if you do know somebody, say, can you connect me with people who are interested? And I've had many students come through, in cardiology or interested in cardiology who we've, forwarded to those in the cardiology to do, a lot of interesting work and publication. So I think that's really, really probably a key thing. So, I thought Dr. Riggelen gave a fantastic talk, and I would just reemphasize everything she said. You find your focus of expertise. That doesn't mean you might not know what that is right away. I do, when I mentor people, recommend, maybe try 3 or 4 different ideas that you have, things that you are interested in, because only one might stick to the wall in terms of what other people are interested in, who's going to accept things at the journals and, what's going to be reviewed. And in terms of academia, to get a tenure track faculty position, you have to publish. And I often recommend, if you do have an area of expertise that you're carving out, this should be a new area, right, that doesn't have a lot of research in it. Start with the systematic review and meta-analyses. There are formal methodology for those that you can find. And then, work on those with the senior authors, and be strategic in terms of what's cutting edge, what's new. I will say I often have contrary ideas, and it becomes quite hard to publish them. The thing that got me started way back was people kept thinking there were pleiotropic effects of statins, and it didn't matter how much you lowered LDL, there are all these magical other effects. And I thought, well, that doesn't sound right, because I know that ileal bypass surgery reduces events, and that doesn't have pleiotropic effects. So, anyway, and so I took eight submissions, but it finally got published and sort of changed the field. So, you have to persist if you think you're right, but it may be a little bit more of a struggle. I find I wouldn't submit to New England Journal first, but I would, if you have a paper that you think is good, I'd submit to the better quality journals, and at least you'll get, if you're reviewed, you get a very good, useful critique. Although it took me forever to finally get something in JAMA. I was like toward the end of my career till that happened. But you have to kind of build a track record to be accepted. But again, persist. Find other journals to submit to, and then finally carve out time on your schedule to write, and make sure you're timely in responses to the journals. So another little tip in terms of carving out your expertise, I subscribe to the electronic tables of contents from the journals, the top medical journals where, kind of the clinical trials and things or seminal research is published, but also your specialty journals, and do keep up with those and reading the abstracts. You need to be the cutting edge. You never know when somebody's going to call you up from the media and say, can you comment on this? And you hate to turn that down. And you need to kind of know what's going on. If you don't have EndNote, as you read these electronic tables of contents, and then you need to download them and keep your bibliography. I also have an electronic library where I save PDFs of pertinent articles, and it's my mind palace when I can't remember anything anymore, but I know where to look, and so I can at the touch of a finger pull up a paper. the latest paper in a field and talk about it in a meeting. And that's kind of the nice thing about Zoom, because nobody knows what you're really doing. And you always sound like the smartest person in the world in the room. And frankly, in terms of our previous speaker, you probably are the smartest person in the room. So go for it. Again, it's building your brand. Networking, as that's so key. It's people know you, and I just, even in grant reviews, and if people know who you are, you've already overcome the activation barrier. You've already gotten in, even if your paper is not any better than somebody else's, at least people will give you the benefit of the doubt. So I would continue to network. You'll find sponsors, you'll find mentors, you'll find collaborators. Again, hey, we should ask her because she really knows her stuff and gets things done. And again, it overcomes barriers in terms of getting papers published as well. Professional societies are absolutely key. Introducing yourself to people at meetings or presentations. And I would also suggest, if you have a key person that you want to develop an association with, invite them to come and give grand rounds or to speak. My example of that is we had a small pharma grant to put on a conference, and I invited Neil Stone to come and give a talk here, and got to know him, and he was impressed with my presentation and my thought process, and we collaborated on some papers. And then of course I was invited to be on the 2013 ACC/AHA cholesterol guidelines with him, and played a key role in that. So again, cultivate your relationships. Now this next one, keep it in mind, it depends on where you want to go with your career. I would talk to those annoying pharmaceutical representatives that want to talk to you, the medical scientists, they're often pharmacologists, but I would have relationships, because I do drug research, so it makes sense for me to talk with them. I kind of tell them what I think. They're there to tell you what you should think from their perspective, but I try to capitalize and tell them what I think about things. But they're really great introducers and connectors. A lot of times they would introduce me to very senior people, or make sure I was sitting at the table with people at dinners, at meetings, and things like that with key senior people to get to know them. So there are often opportunities to write papers, participate in clinical trials, which I encourage you to do if you're interested. You can speak for them. You just don't ever sign up for a speakers bureau, because you have to use their script. So that's really not acceptable. But there are other ways that they can kind of grease the wheels to get you out building your brand. There are scientific advisory committees that you can participate on, where again, you're at the table with other and senior experts, and you get to know people. The caveat to this is, if you get pharma money, you can't be on a guideline committee. So if that's one of your career aspirations, I would not communicate with pharma. And again, just persist, speak up, support other women. And I will tell you, the discrimination got worse the higher up I got with things. It was really quite awful, and made me often want to quit. So because you're just, you're in competing very vigorously for the same pie, and it can get ugly. In terms of, you have to have time to do this. I was able to do this because I had my salary offset from clinical trial work. And so I actually didn't have to do anything for these because I have a staff. And so I had, effort put aside that I could write all these papers and do my analyses. But be sure you negotiate that if you're on a research trajectory as part of your package. Schedule time on your calendar to write, and to block off that time and spend time doing it. You don't need all day or all weekend, but you also need time to focus on your families and friends. And I'll be honest, if you have little kids, I'm not sure how you can do all this stuff, but as they get to school and kind of settle down, I think it becomes more manageable. Keep what you like, find time for yourself. One of my best ideas was, I decided I got to get outside. It's a beautiful spring day. I'm going to take a walk. And the problem solved itself on my walk and really helped, just because my mind was not was off kind of being happy, and my subconscious was working. Outsource everything you possibly can. And I have to say, COVID and, all this food delivery has been really improved our diet. So, or actually our diet's worse, but the meals are much better. So, try to do as much as you can to have time to focus on these things for career advancement. And again, anybody can do it. You have to be smart, and you have to be persistent, and you have to not take a no for an answer. You have to network, but you can become the go-to expert in your field. And it's really fun. I've traveled all over the world and given talks, and it's really been a lot of fun. So thank you very much.
I'd like to thank Dr. Robinson. That was outstanding. It reminded me a little bit of my first paper. I think that my mentor told me to send it to a journal with Cell in it, and I actually sent the paper to Cell back when you mailed it in. And I think the mailman, when I handed my paper to him, actually gave me my rejection letter. So it's been a long climb since that beginning, but I think your statement on how things got worse as you climbed the ladder, I think is really enlightening for me particularly. And yeah, that surprises me. And I think it's a great opportunity to improve. So thank you for that. That's amazing from somebody whose impact factor is about twice of mine. So thank you. I have the pleasure to introduce our last speaker in this session. And Dr. Kanda Panini is going to talk about microaggression in the workplace. And I think this is an evolving area where there was an underlying problem that was very significant. I think awareness has been one of the first key elements of this. And now that there's awareness of the significant prevalence, the opportunity to begin to improve. So Dr. Kanda Panini.
All right. Give me 1 second.
We were able to see your screen fine, Nita.
Oh,
Share it here.
Let me just share again. Somehow I accidentally. Okay. All right.
Perfect. Yes.
Oh, all right. Great. Thanks, Dr. Ashworth. Thank you for the committee to give me this opportunity to speak alongside some of the most inspiring advocates for women in cardiology. I have no disclosures, and given the time, hopefully in the next 8 minutes or so, I would like to cover microaggression and try and identify how it occurs and what exactly can be defined as microaggression, discuss the impact on recipients of microaggression, and discuss some of the strategies and how to confidently interrupt microaggressions at the workplace. So I'm sure we're all familiar with some of these. These are pictures from a photographer student, Kiyun, at Fordham University when she asked her friends to write down day-to-day microaggressions they have encountered. Some of them seem very benign, but truly the impact that they have on the recipients sometimes could be very immense. And naturally in healthcare setting, we have a lot that we can relate to. So what exactly is microaggression? Dr. Chester Ampeers at Harvard Institute, he was a pioneer in addressing health disparities. He coined the term microaggression back in the 1970s to facilitate dialogue around harm caused to non-dominant groups. According to that, microaggression is a commonplace behavioral indignities, whether intentional or unintentional, communicating hostile, derogatory, or negative attitudes toward marginalized groups. After a few decades, as the world around us changed for better or worse and workplaces evolved, Dr. Sue modified this definition further. And in her definition, she took into account not just the verbal abuse, but also general disrespect or devaluation, sometimes even dismissive body language or tone of voice and exclusion. According to this new definition, subtle snubs, slights, or insults directed towards minorities as well as to women or other historically stigmatized groups that implicitly communicate or at least engender hostility. So what exactly do we perceive these as? Microassaults are one kind where these are often conscious and usually considered as old-fashioned statements. For example, I came across a social media post last year by a male cardiologist, which referred to how it's easy to get a cardiology fellowship as a female applicant. We hear that often. So that's an example of microassault. Micro insults often are unconscious snubs or humiliations that most of us may just dismiss it as rudeness or insensitivity on the part of the perpetrator. A classic example being you walking in with a team of male residents and or medical students, and the patient addresses you as a nurse. Or in some instances where the perpetrator may think it's a compliment and say, hey, you don't seem to have an accent, or you look pretty for having a brown or a black skin. Or back in my internship, I remember an incident where I was asked which tanning spa I go to. So again, these are not intentional and meant as compliments, but in reality, the impact on the recipient could be entirely different based on their cultural background. And the others could be termed as micro invalidations, which again may not be directly intentional, but aimed at dismissing recipients' experiences, thoughts, and feelings as oversensitive or overthinking it. We see this often in meetings at workplace, like a female member voices an opinion and gets ignored, and a male colleague later takes up the same point and he receives acknowledgement. So that's clearly the female member is feeling the sense of exclusion there. And another common thing we hear in a day-to-day discussion about race is, I see no color. The intention is to say, I do not discriminate, but the impact from the recipient standpoint, again, can be dismissal. So together, combined, all of these will reflect in the workplace, and those can be called a macro level or environmental microaggressions. So a classic example of these is the hallways are filled with white male departments of chairs, which reflect the reality, but the impact on some of the diverse people who are walking those hallways could be anybody's guess. Other examples being these individual implicit biases seep into decisions on promotions in academia and leadership positions where a female faculty member or an underrepresented minority faculty member is treated differently in terms of the criteria for promotion. Again, we do sense all of these, and ultimately these biases kind of affect somebody's growth in their careers and can lead to a lot of dissatisfaction. So the impact of these microaggressions can be at multiple levels. At a personal level, the recipients may feel lower self-esteem, especially seen in educational settings and workplaces. It can create self-doubt and can lead to isolation and alienation. Sometimes even can lead to depression or anxiety and even thoughts of self-harm. And we have seen examples of trainees around our country, even in the cardiology field in the last couple of years. Studies also reveal that perceived discrimination has been associated with physical health, like hypertension in Blacks and Native American individuals. Providers or medical students and trainees, especially in perioperative or procedural settings, face microaggression, and studies have shown that these can lead to low quality of life and depression and even medical errors. Ultimately, what we all care about is the health of patients as well as our own personal job satisfaction or in terms of wellness. These can have a profound impact without, even though it's called micro, the word micro takes away the impact. that is faced by everyone. Again, coming back to the patient communities, healthcare disparities has been, has been discussed everywhere, and our own implicit biases overall can lead to these disparities in the care we offer our patients. And provider community, where we feel that what we are trained to do, we are not able to achieve that, and that can lead to burnout, easy burnout, and job dissatisfaction. Lack of value and respect can oftentimes leads to less productivity. Finally, there is a huge societal price, including skewed pipelines in workforce, where fewer women and minority members or practitioners are seen in cardiology and even in academia, as many of the papers are now suggesting. It has a huge impact on how, as a healthcare field, we are not doing justice. So how do we interrupt these microaggressions? It starts with me, whether I'm a recipient or a bystander or the aggressor. Yes, there is an organizational there has to be an organizational attempt, but as a society, the society starts with me. So we all have a role in changing the culture of how we address these microaggressions. More often than not, whether we are recipients or bystanders or aggressors, even when we recognize there has been a microaggression, based on our upbringing, cultural sensitivities, or even a prevailing work environment, we may shy away from doing anything about it. It can be because we don't know how to respond or deny that it happened. Sometimes we even rationalize that maybe I'm making a big deal out of nothing, or maybe my words won't have the impact I intend them to. And finally, sometimes the pure fear of negative consequences if I say something, which can be, I'm afraid of being labeled as oversensitive, or thoughts of, is it even worth the trouble? Maybe it would affect my growth within the organization. So all of these can be the barriers in being proactive and interrupting these microaggressions. So that leads us to what some of the skills or behaviors that we can inculcate and practice to facilitate self-awareness and education for perpetrators, and at the same time be supportive to recipients. This is even more significant in learning environments, and as mentors, we need to make a conscious effort to be an upstander for our trainees. And Dr. Hayes already has very beautifully elaborated what it means to be a bystander versus an upstander. So having these skills to respond to these microaggressions in the moment, or if not appropriate, closer to the moment, may lead to positive outcomes both for the perpetrators as well as for the recipients. Having said the responsibility should not be entirely on the recipient. It actually, the role of the bystanders is very crucial if we want to change the entire culture to upstand and be counted upon as a supporter, as an ally to those who receive these microaggressions. So the skills that we are discussing will apply to both recipients as well as bystanders. So when it's time for acting, we should start with asking clarifying questions that should come from curiosity, but not as a judgment. Like in the instance of the women member that we discussed earlier that felt being ignored in the meeting, rather than saying you ignored me, the woman herself can say, actually, I was trying to say something very similar earlier. Or as an ally in the meeting, you can upstand and basically say, I'm very much interested to hear more on what our female colleague, whatever the name is, was saying prior to so-and-so's comment. Could you please elaborate more on that? So when intervening, again, we have to remember, we have to use the words I heard, I sensed, I felt, because it's very important that we own our thoughts and emotions and express the same. This will then open the door for next steps, which could very well be educating the aggressor, if the environment and time is right, be supportive, or sometimes next steps may mean reaffirming boundaries with the aggressor. Or if the responses are defensive and not cooperative, turning to external allies who can be your mentors, who can be program directors, who can be the chairs of your department for additional intervention, or even the hospital diversity committees to get involved may become necessary. So what if I am the aggressor? So I'd like to share my experience, my own experience in this. During a group session, while discussing people of color and what's happening around in our institution and what we can improve upon, I happen to use a word, colored people, instead of people of color. So my ignorance about the racial verbiage was clear there. Another participant who is an African American corrected me and educated me about the difference between the two words and how colored as a word is not the right verbiage, and it can be perceived negatively by African Americans. I acknowledged my mistake and I appreciated the intervention, which helped me learn in the moment, but it didn't come naturally to me. It took a lot of courage. I had a lot of butterflies in my stomach. I felt my voice was cracking as I was apologizing. But the lessons I learned from that episode are: no one's perfect. It's okay to make a mistake and acknowledge it. Be open to accept this as a learning opportunity. Self-respect and self-critique is crucial in making that distinction about what is my intent in saying something and what actually was the emotion my comment had on the recipient. Again, not being defensive in my response, and not think whether I said it with a bad intention or not. That's not what's important. It's rather important for me to listen to the intervener, whether it's a recipient themselves or the bystanders or who are upstanders. It's important. It's important to listen to their perspective. And lastly, the more we educate ourselves, the less we are likely to commit them. With that, I would end there, and thank you.
Thank you, Dr. Kondanapini, for that excellent talk, as well as thank you, Dr. Robinson, Dr. Hayes, and Dr. Figoski for your wonderful presentations. They were outstanding. Unfortunately, we don't have time for question and answers verbally, but as a well-being effort, I still think that we do need to take a bio break, all of us. And so I would encourage anyone, if you have questions, to ask them in the chat box so that the four of our excellent speakers can address some of them. And I think, Mahi and Annabelle, perhaps for next year, we could consider more of a flipped classroom kind of concept, where we do, these presentations have been great, taped, people watch them ahead of time and do breakout groups, whether virtual or in person, may allow a little bit more action-oriented ways to interact. But thank you for these outstanding presentations. With that, I'll give the group a 10-minute break. So be back at 12:20 if it's Eastern Standard Time, 11:20 if it's Central Time. And for all of the speakers and moderators, if you could turn your cameras on real quick, we're going to take a quick picture of all of us. Round one pictures, I should say. Mahi, are you going to take those pictures, or?
I can take them. Autumn, are you able to, or I can take them too?
I see Tonia's ready with her camera too.
Okay, we can take a few maybe and probably pick the best. Right, 1, 2, 3. Get one more. Okay, 1, 2, 3. Got them. Thank you very much. Enjoy your break, and we'll see you back shortly. Thank you very much, Lakshmi.
Thanks, Mahi.
I know we are on a break, but if people want to hang out and chit chat or whatever, feel free to turn on your microphones and have a conversation.
You're so cute. You're just adorable.
Thank you. And I know a lot of these talks could be much longer. The conversations, the discussions about them, definitely could go on for much longer. So I appreciate everybody making their talks shorter. Hope we had more time to discuss them. But feel free to keep the conversations going on in the chat window.
And I've been posting on Twitter, so feel free to use Twitter. Also has a discussion platform with the speakers. I don't have everybody's Twitter handle, so I'm sorry if I've not included some people in there. But I'm using the hashtag ACCWIC. So if you just use the hashtag and follow that on Twitter, you will see what everybody's posting, and that could be also a place where you could conduct some discussion.
So I think the attendees are not able to turn on the microphones. If any of the attendees would like to, turn on the microphones and stuff, just send either me or Autumn a message, and we can kind of make you a panelist if you.
Mahi, great job organizing this. It really looks like a fantastic conference.
Thank you very much, Niti. Thank you for joining in.
Of course.
No, I think a lot of effort has been put in by the planning committee too. So Tonya, Annabelle, Lakshmi, and they were all pretty much holding my hand for a lot of time. And Autumn did a lot of work behind the scenes along with Aruj. So it's definitely not just me doing this. It's the whole group here. So, but I think this is a great conference and turned out really well. So.
I was thinking for one of our future conferences, we're going to have maybe Dr. Hayes do a workshop with us on how to deal with these, so we could have like more interaction. I think that maybe a couple of hours dedicated to maybe some role playing and suggestions and answering. And I think Dr. Hayes would be fantastic to lead it. So you all heard me here. So whenever we have that opportunity next, let's make sure we can get that on our books. To do that.
I kind of second that one, Tonya. I think with all the all the awareness that we're having about imposter syndrome and stuff, I think we're recognizing it more. But sexual harassment, sometimes I think we kind of tend to downplay ourselves a lot of it and try to slide it out. And whatever Sharon said is entirely true. I think most of us have experienced this, right? Whether it's a patient or the family or our colleagues. And again, I think we tend to suppress it. Actually, one of the speakers is Sharon Larson. Sharon is a CT surgeon here at the University of Iowa. So I think Sharon, she would probably share some of these views that are coming from the surgical standpoint too. So I'm sure she has probably experienced it more than we did. So.
Well, I think we've all experienced it. And I think for those of us who have been, who are more senior, I'll use that term, we're pretty much told and expected to suck it up, right? For many years. And I think that has led to a cynicism that nothing will be done or can be done. And I think reshaping that view, because there is now, and there's much more conversation, there's many more male allies. And I think teaching them, more importantly than women, teaching them what their role is, because sometimes they don't step in because one, they don't see it. Two, and this goes with microaggressions as well. Two, they worry that they're so appalled that they're caught flat-footed, so they don't do anything. And then they feel bad afterwards, right? Because they know they should have. Yeah. Or they are mad or afraid. And I think that's an elephant in the room that some of our colleagues have, is that this whole thing is a witch hunt, and that there's still a perception that there's a lot of women out there making false claims. And of course, there's the 1 in a million that does, which makes it more difficult. But by showing data, I mean, my experience at my own organization was moving people from grief. I'll say some senior men, grief that these new rules seemed like that's not the good old boys. I used to be able to hug a nurse because, she's been in my practice for 20 years. Like, I can't hug my nurse. I said, that is not what we're saying, right? you can hug that nurse because you may be the godfather of her children, but know that not every nurse wants to be hugged, right? I mean, there's things. And the other thing is, I've had men say, well, things have changed. And I say, yes, they have. Me Too has happened. And so what really was perhaps okay 10 or 15 years ago that even I thought maybe was okay, right? As a woman, that I would have been okay with, it is not okay. And then helping them come to terms with the sense of loss, perhaps. So I think there's the egregious, ugly stuff, like the first case. There's the other part that acknowledging people's feelings about and where they fit into a solution, or how to help them not be a problem, because there's far more people who want to make the place better, but they sit on the sidelines because they don't even know where to start, and they haven't been invited in by women. That's the other point I make a lot of times. You know, I think ACC WIC programs are amazing, and I think Jared is great to be here if he's still here. But one challenge we often have is some of our best he for she allies sit on the sidelines because they feel like they shouldn't insert themselves. Like they have this perception, you know, men have been stomping over what women say for so many years. I don't want to be that guy. And so those are the men that we need to bring in and say, we want you, we need you. And in fact, here's the specific thing that you can do. And they feel empowered and will do it. And so I think this whole discussion, I think because all of the topics were very interlinked, whether it's stereotype threat, which I think is a huge one and deserves a whole talk on itself. The reason by which is because as a leader or a mentor, there's actually action things you can do in the moment to help somebody else, but there's also things you can do for yourself. So it's a very action-oriented conversation. But I think it is nuanced, and if we're going to improve the climate of cardiology so that we all want to work here and we want the next generation of women and men to have a better experience, we all have to change and probably grieve some things and grieve some changes and losses that are for the better.
Sharon, I appreciate you also bringing up the point about patience, because I think that that's something that we've only recently started to discuss, because I think in the past, we kind of had this attitude that we're going to do whatever for our patients and it's our responsibility to take care of them, and really no effort being placed on the role of the patient with respect to the healthcare provider.
Yeah.
And so I think it's great that you brought that up, and perhaps Tanya, if you're thinking of workshops or something to maybe provide some help with us in how to deal with patients. Because I think that we all fear that patients are going to complain about us and that we're going to be reprimanded by not doing our job and taking care of our patients and blah, blah, blah. And, you know, we have to be treated with respect, and we have to teach our patients how to do that. But sometimes that's just as hard to do as it is to try to teach our colleagues to teach us with respect.
Well, I think the other thing, Vera, and I completely agree with you, and it's been a big it's been a big focus of my work at Mayo since 2016, 2017. We now have a policy and actually training and other things, and it really has shifted the culture, because our main value, it's like tattooed across our head, is the needs of the patient come first. Right. That's like a Mayo Brothers. And so it was really, we were giving so much grace and leeway to truly abusive behavior, not just sexual harassment, just and so changing that culture. And one of the actual structural things is, so we had, as all of your organizations likely do, have 10 or 20 policies to protect our patients from us, right? There are patient rights, there's all of this stuff. And there was not one policy or procedure as of 2017 to protect us from patients. So you couldn't even fall back on a policy or a procedure. And so when people did actually look for it, they felt like, well, my hands are tied. I guess we have to give in to the patient. So starting with recognizing that this doesn't come from HR, it's a practice issue. Because that was the other issue. As Director of Diversity and Inclusion, they kind of said, well, where should that new policy live? We're going to put it in diversity. I said, nope, This has to do solely with patients. The dean of practice, the head of the practice, should own this, and they do. And because it has nothing to do with the lab. You know, if you work in a lab, you're not going to have harassment from a patient. So I think it's so important, and it's become more important because what we noticed and why we took action is after 2016, there was a lot of divisiveness in this country, and we had a lot of folks that just felt like all that political correctness just had to go out the window, and so they just said what was on their mind to whoever they were seeing. And you know, nurses getting hit, and people of color being told to go back to where they came from when they were born in Chicago. I mean, it became such an ugly scene, and it doesn't mean that having a policy makes it go away, but knowing that we've got our employees back does make a big difference.
No, thank you for your efforts with that, and I think you know, I'm glad to see that there's momentum in place and recognition of this to support us, because we have a hard enough job as it is. And if you can't feel respected and safe from the people that you're trying to help and take care of, then it's very disheartening. So thanks for your efforts with that. And again, Tanya, if you're thinking of putting a workshop together, it may be a topic that is worth discussing, and perhaps providing some tips and guidelines for how to deal with these types of situations.
Yeah, thank you, Vera. I think that's very good. I'm just writing down notes. You know, when we do this, we can also then talk to our colleagues in other institutions who already have policies in place and see if they're willing to share them as best practices, so that we don't have to invent the wheel from scratch. And we can take that back to leadership at where we work and say, you know, the Mayo Clinic, which is fantastic place to be, has this in place for their people. Don't you want to be like the Mayo Clinic? So, I mean, just kind of, you know, working with people's reputations. Like you said, you know, if somebody knows someone, they have an impression of that, it gets past the first barrier a lot faster, like Dr. Robinson said in her talk. So I think that, you know, and this network is providing us with those resources that we can take back and serve all our colleagues with that. So thank you for bringing that up. So I think we will work on doing something like that here in the future. And obviously we'll be leaning on Dr. Hayes for our expertise on that. So we'll bring that up to the council and see what the best, and of course we always invite our male colleagues to all these talks. And I don't know how, maybe we need to label how we call these conferences. So when we call it a Women in Cardiology conference, we don't want men to be excluded. And I think that's maybe one other point we need to take back to our council to see how we can make it sound more inclusive. Because when we talk about this, we do actually, it is a conference that is open to all cardiologists. So I think we just
especially for the fellows.
Yeah, and so I think we just need to do a better job of advertising the fact that we really are inclusive. I mean, as women in cardiology, we are the most inclusive people. We don't want to exclude anybody. So I think we need to do some just thoughts on how to get there. So
Mahi, do we need to get restarted?
Yes, I think so, Annabelle. Thank you. But thank you very much, Veera, Sharon, and Tanya, for your input. So we will go ahead with the next session about the business of medicine. We will have our moderators, Denada Palm. I don't think Dr. Walsh is able to join us. She's at the HFSA. So I will let Denada take over. I think I saw her earlier, Denada. All right, she is probably coming back from her break. So I will move on to introducing the first speaker, and then we can go from there. The business of medicine, we're going to discuss about the various clinics that we can set up, not just for women, but for
kind of interesting. And this data.
And then see how to set them up. What is the point of having them? The first one is going to be, what is the Women's Heart Center? Where do we start and what is the value in it? And this is going to be presented by Dr. Niti Agarwal. Niti is from the Mayo Clinic, and she has done a lot of work in this area. She's very active with a variety of societies, including the Society of Cardiac MRI and the ACC. And she's a multimodality imager, and she's going to be talking about women's heart centers. Over to you, Niti.
Thank you, Mahi. Can you guys hear me and see my slides okay?
Yes.
Wonderful. So heart centers for women, the why, the what, and the how. We have a lot to cover, so we'll get started. Here's my disclosures. So we'll get started with the why do women's heart centers? And the short answer is because women are not little men. Every cell in our body differs. And this probably accounts for the different biological differences. When we look at just simple ischemic heart disease, we've got differences in risk factors. The traditional risk factors such as hypertension, diabetes, smoking, obesity, impart a differential risk of ischemic heart disease in women compared to men. And then on the right side of this image, the emerging risk factors such as rheumatologic disorders, autoimmune disorders, disorders of pregnancy, early menarche or menopause, presence of depression and anxiety, all of these things are either unique or more predominantly present in women. So again, there's a difference in risk factors between men and women. Beyond the risk factors, even the pathophysiology of ischemic heart disease varies between men and women. Men are more likely to present with obstructive atherosclerotic disease. In contrast, women are more likely to present with non-obstructive coronary artery disease, including spontaneous coronary artery dissection. They're also more likely to have functional coronary artery disease such as vasospasm, endothelial dysfunction, microvascular disorders, as well as disorders such as Takotsubo's cardiomyopathy, myocarditis, and embolic disorders. Beyond the pathophysiology, there are differences in presentation, management, and outcome. Amongst women that present with acute coronary syndromes, they have a delay in presentation, they get less pharmacotherapy, less revascularization, and less rehabilitation compared to men. Perhaps this is why they have more events and death. They're more likely to have anginal symptoms and ultimately have worse quality of life. Heart disease continues to impact nearly 9 million women. It is still the #1 killer of women. But yet, only 55% of the women surveyed by AHA were aware that cardiovascular disease was the leading cause of death. And this awareness was even lower in patients of ethnic and racial minority. This problem isn't just limited to the patients and the lay public. There's a problem even with the physician awareness. So while physicians or primary care providers did recognize cardiovascular disease as a top health concern in women, they prioritized weight-related health concerns and breast health over cardiovascular disease. 42% of cardiologists actually reported feeling that they had suboptimal training in assessing cardiovascular disease risks among women, highlighting the need for additional training both during fellowship as well as in CMEs. Women are also underrepresented in research. Although they comprise 50% of the population, they only make up 33% of the cardiovascular device trials and 38% of clinical trials. Cardiovascular research is traditionally done on men and data extrapolated to women. So the answer to the why is for patient awareness, for improved patient outcomes, for physician awareness, and for inclusion in trials and more research. Let's switch gears and talk about the what. And those 4 whys that I just talked about will now form our pillars of the Women's Heart Disease Centers, including the focus on clinical care, education, community and public awareness, and research. And we'll look at each one of those in just a few minutes. Here is an image from a white paper in circulation by Gina Lundberg and colleagues. I had the honor of being a co-author on this manuscript, and they identified the tenets of heart centers of women, including research, patient education, academic education, patient and community awareness, and patient care. Looking at specific areas, and I know we'll cover some of these in the upcoming talks, areas could include risk management, or risk assessment and education of women with high risk for CVD, managing the full spectrum of cardiovascular disease, and we kind of talked about some of those ischemic heart disease disorders, cardiorheumatology, cardio-OB with pregnancy, cardiovascular disease and menopause, cardio-oncology, and I know we'll be hearing from Tochi in just a little bit as well, assessing and managing transgender patients and their risks of heart disease, and then neurocognitive and geriatric care. Importantly, a women's heart center should really be a multidisciplinary location. We should have collaboration from our OBGYN colleagues, oncologists, neurologists, rheumatologists, and many more. As an example, here's a slide given to me by my friend and colleague, Dr. Annabelle Wogman, who established and runs the Rush Heart Center for Women. And she goes on to say that at the center, women with heart problems are diagnosed and treated with great sensitivity and innovation, i.e. an individualized approach. And there's a collaborative team of cardiologists, nurse practitioners, nurses, nutritionists, cardiothoracic surgeons, I know neurologists as part of our program. Looking at the next pillar of women's heart disease programs is education. Here's an image of Dr. Rekha Mankit at the Mayo Clinic. Each time I see her, she's always going around educating trainees about heart disease in women and sex differences. And many, many years ago, she was the one that introduced me to the concept of heart disease in women. Beyond just educating our trainees, this editorial by Dr. Jennifer Maraise says it all. Ischemic heart disease in women, there is a need for sex-specific diagnostic algorithms. We need to have guidelines, including we have one on stable ischemic heart disease in women. We've got one by Dr. Lakshmi Mehta on acute myocardial infarction in women. And then on breast cancer and how it interacts with heart disease. There's many more, but we still need more guidelines. Every guideline published, in my opinion, by AHA, ACC should really be encompassing both men and women and the differences. Looking at the next pillar, we need to be partnering with our community and using resources to help us there. So organizations like Women Heart have a lot of resources on their websites, and that can be a great venue to partner with our patients and community. As another example, this slide was given to me by my friend and colleague, Dr. Janet Way from the Cedars-Sinai, who runs the postpartum heart health program there. And they partner with organizations like CardioSmart to publish this beautiful brochure educating the public about gestational hypertension, preeclampsia, postpartum hypertension, and so forth. Other examples could include books written for patients, such as the Heart Smart by Dr. Jennifer Murray, Stacy Rosen, and then the Smart at Heart by Dr. Melissa Wood. One can also be giving talks and on news channels to increase awareness of women and heart disease. And finally, the last pillar of research. So as an example, as many of you know, Mayo Clinic has a big SCAD clinic, spontaneous coronary artery dissection clinic, and does a lot of research in that area. Dr. Marisha Tweet, as well as Dr. Sharon Hayes, who we just heard from, run the SCAD registry that currently includes 1,400 participants. This was designed to engage the trainees, collaborate with others, present research, publish, and ultimately improve patient outcomes. And here's an example, one of probably thousands of publications that have come out from this registry and have also helped form some of the guidelines. So to summarize, the Women's Heart Care team should really include sex-specific guidelines, diagnostic tools, technologies, medical education, including CME, support policies and mandates, improve public awareness, and sex-specific research. And then finally, in the last couple of minutes, we'll look at the how. So I'm going to borrow a slide from a talk I gave exactly last year at the ACC Midwest Women in Cardiology Conference, because nobody teaches us better than Master Yoda. And so some of the tenets he had used were, you must unlearn what you have learned, meaning put aside your biases, keep an open mind, collaborate. Size matters not. You can start small, start with just your own clinic and grow it up. Be mindful and be in the present Enjoy the journey. Don't just focus on this big center down the line. Believe in yourself. Always anticipate change. Always in motion is the future. Keep your trainees around. They will help spread your message and word. And don't do it for the wrong reasons. Don't do it for your personal promotion or title or the prestige or money. Do it instead for the right reasons, which is improving patient outcomes and moving the needle of heart disease in women. If you need additional resources, I'm going to put a shameless plug for my book that has a huge chapter on this, along with my co-editor, Dr. Melissa Wood, and then this other paper that I referred to, Heart Centers for Women. Both of these are really good resources if you're looking to build a women's heart program or clinic. I'd like to thank you for your attention. And if you're looking to build a program, good luck. May the force be with you. I'd be happy to take questions now or maybe later.
Thank you so much, Dr. Agarwal. Can everybody hear me, by the way? Can you hear me?
Yes.
I really appreciate it. It's a very informative talk and certainly very exciting. One question from a practical standpoint that I have, especially as a newly graduated fellow going out there in the community, what advice do you have for women who are not just joining these clinics in an academic centers, but also starting a clinic out there in the community? What are some of the resources they can utilize and some things that from your experience have worked well?
Great question, Dr. Palm. So I think number one, believe in yourself. You've been well trained. I think just go ahead and do it. Start a program. You can start small. It doesn't have to be, you don't even have to have a title up front, although it's nice to know that there's a title, but just start at a smaller level. Go give talks in the community, book clubs, I physically still hand out my card at every opportunity I get. And just introduce yourself, say I'm passionate about women's heart disease, or I'm a heart disease expert. You have a question, come on over, give your cards, collaborate with your other community, like healthcare providers. So your OBGYNs, go ahead and give talks to them, ask to present at their grand rounds. Your rheumatologists, oncologists, they will refer patients. And when you do a good job and you take care of one patient and they have a good outcome, they'll send you 2 more. It's word of mouth. It will grow. Start small and it will grow.
Okay, thank you so much. I don't know if anyone else has any questions before we go to the next talk.
Maybe we can finish the talks and open the panel, Danana.
Okay, that sounds good. Our next speaker is Dr. Tochi Okuosa. Dr. Tochi Okuosa is an associate professor of medicine and cardiology. She's a director of the cardio-oncology program at Rush University Medical Center, and she'll be talking to us about the value of cardio-oncology practice and where to start.
You muted.
Okay. Yeah, thank you so much for that kind introduction. For some reason, my PowerPoint presentation, each time I try to put it to play, it takes away the topic or the title of the presentation. So pardon me for that. But Dr. Agarwal, that was a great presentation and a hard act to follow, but I will try to impress upon everyone what it is like to build a cardio-oncology program. So as they already mentioned, the title of my topic is Cardio-oncology, Building a Cardio-oncology Practice. We will start. So we know that heart disease is the #1 cause of death in the United States, and cancer is a close second cause of death in the United States. Coming up from the 1950s, heart disease was a major leading cause of death in the US, but cancer has quickly caught up with it, or at least close. And the main reason is because of newer diagnosis, and people are living longer as well, which is increasing this risk of cancer that we're seeing. In more recent times, the risk of cancer and heart disease are improving, which is great. The risk of heart disease is actually improving very fast. And I think a lot of it is thanks to prevention, thanks to the things that we're doing for women and heart disease, and a lot of other cardiovascular progress that we've made that's improving heart disease. And it's projected that by the year 2030, cancer would have caught up to heart disease as the leading cause of death, and cancer might actually supersede heart disease as the leading cause of death. And to put things in perspective, these days, COVID is on everyone's lips. The reason why we're having a virtual conference right now instead of an in-person conference. And we can see going on from last year when COVID became an issue in March of last year up until now, even though COVID has caused a lot of death and mortality and of course significant morbidity in the United States, heart disease remains the leading cause of death for the most part, except when we have COVID surges, such as we saw earlier on this year and probably summer of this year as well. But as of the data that we have, heart disease overall still remains the leading cause of death, and cancer still remains a close second cause of death in the United States. And this is particularly relevant for COVID patients also, because I think a lot of people, at least in the beginning, were very concerned about coming into hospitals to take care of their hearts and their cancers and the rest of them. But since they're still the leading causes of death, these are things that we have to keep in mind working towards. So from the NCI, as of January 2019, that's the latest data that we have, it is estimated that there were about 17 million cancer survivors in the United States, which is 5% of the population. That's pretty significant. It is projected that by 2030, that number would have increased to 22 million, and that by 2040, that number would have increased to 26 million. And so we start to see, and a lot of this progress is thanks to a lot of the advances in cancer therapy, right? Immunotherapy being one of them, targeted therapies being the others. We still use chemotherapies and radiation therapy in patients, but cancer therapy has come a long way. And thanks to these advances, patients are living longer. Well, the thing is that as patients are living longer, heart disease is becoming a major problem for these patients. And a good example, when I was in medical school, melanoma was a death sentence. These days, melanoma is no longer a death sentence because of targeted therapies and immunotherapies that we have for these patients after genetic testing. I have a patient in my clinic who's lived with melanoma now for 7 years, metastatic melanoma. She's in her 80s and she's still alive. It was unheard of 15, 20 years ago. So this is very, very impressive. Lung cancer patients, including small cell lung cancer patients, are also living longer. Well, they get radiation therapy. So they don't die anymore from their lung cancer. And if they're getting chest radiation for their lung cancer, you can bet that heart disease is going to be a major problem in this population as they age. So again, this is a major thing that we need to think about in our patients. Many of our cancer survivors have had radiation, chemoimmunotherapy, stem cell transplant, CAR T cell therapy that then further increases the risk of cardiovascular toxicities, both short-term and long-term, and therefore attenuates clinical success of oncologic treatments that we've given these patients. And this is the reason why it's important to have this conversation. So what sorts of things do we see with cancer patients? And I want to put these slides up here just to kind of impress upon everyone that it's not just that we have a lot of cardiovascular consequences from cancer therapy, it's also the fact that there are a whole slew of agents that we need to think about. And the reason why building a cardio-oncology practice has to be very comprehensive and very collaborative, because no one is going to be able to, first of all, know all this and be the sole person taking care of these patients. So you have LV dysfunction, and you can see all the agents that cause LV dysfunction. There is problems with hypertension, and you can see all the agents that cause hypertension. Thromboembolism, agents involved in that. Myocardial infarction and ischemia, multiple agents. QT prolongation with risk of arrhythmias and torsades and ventricular tachycardias, multiple agents. Mediastinal radiation and all the problems associated with it. Immunotherapy, newest targeted therapies that we're using that's causing patients to live longer, but still do have cardiovascular consequences, including myocarditis, pericarditis, and some say coronary artery disease. CAR T cell therapy, stem cell transplant, and the list goes on. So it's very relevant that we discuss this. For the practices in cardio-oncology, There are many different reasons for referrals, right? Cardiac mass or tumor, pericardial disease, pre-op evaluation for cancer, surgical removal of cancer, cardiac amyloidosis, congestive heart failure and cardiomyopathy, evaluation prior to stem cell, valvular heart disease, vascular heart disease associated with treatment, ischemic heart disease, cardiovascular risks, treatment associated with hypertension, arrhythmias. And so there are multiple reasons for referrals for the reasons that we've mentioned. And we'd like to think about referrals to cardio-oncology clinic in 3 broad categories: before treatment, based on their baseline cardiovascular risk factors and cardiovascular problems that might exist, kind of tying that into whatever treatment they're going to be receiving. And if you feel that this is the sort of treatment that we anticipate could cause problems. During treatment or during therapy, if we feel that the therapy is going to be cardiotoxic to these particular people, or if they develop problems during treatment as they get in treatment, you know, for example, somebody who's receiving anti-HER2 therapy for breast cancer that ends up developing reduction in LV ejection fraction. This treatment is usually given to patients for a whole year. So if they develop a problem, then you would send them to an oncocardiologist. And then the other group of people are after treatment, those that are cancer survivors that have received high-dose anthracyclines, cisplatin therapy, radiation therapy, or a whole bunch of other therapies that may increase the risk of cardiotoxicity. In this study by Diego Sadler and his group, I was actually involved in this too. There was an interspecialty collaborative project that assessed awareness of various aspects of cardio-oncology. As you can see, they surveyed about 300 clinicians, both cardiologists and oncologists. And they found a couple of things I think I wanted to take away from this. One is that few people, about 14% of oncologists and 16% of cardiologists, felt comfortable treating cardio-oncology patients. So that basically tells us that not very many people feel comfortable taking care of these groups of patients, most likely because they're a complicated group of patients. And also they are typically on many therapies that could have cardiovascular consequences at the same time or in tandem. And then the other thing I wanted us to take away from this is how many would be willing to refer to cardio-oncology? 93% of people were willing. So very high number of people, very few people knew enough about cardio-oncology to manage them comfortably, and very many people were willing to refer. So this is a very necessary service to the country, to both academic centers and community centers within the country. And when asked, how would you rate knowledge in cardio-oncology, you can see that that number is pretty low, a little bit higher among cardiologists, but lower amongst oncologists, but just generally low. Very few people are very knowledgeable. And then when asked how many educational programs or teaching sessions have you attended in the previous 3 to 5 years in cardio-oncology, few people were likely to have attended 2 or more, which means that we need better education in this population. And so when we're looking at approaches to facilitate greater institutional support for cardio-oncology, it's important to get buy-in from our institutions because they're going to be the main people supporting us. Awareness is important, like I showed. So we need to educate the community, educate other academic centers that don't have cardio-oncology programs, educate our trainees, educate our nursing staff and advanced practice providers, educate all the people that are willing to learn. Because trust me, because cancer is usually a multidisciplinary disease, there are a good number of people that these cancer patients will pass through that need to be educated about this. So the programs have to be comprehensive because of that. And then we also need to, at the same time as we're building a cardio-oncology program, show evidence of growth, because that is part of what will make our academic centers be more supportive of the programs that we're building. When we show that there is a need for it, and when we show that with that need, that we are accommodating as many as possible, and that we are showing growth through the months and years, as well as outcome data. How well are patients doing compared with if they did not have a cardio-oncologist within that institution? That would also be very important. And then intra and inter-institutional collaborations to take the best care of patients, and also to improve research, because there are a lot of questions that are yet unanswered in cardio-oncology that we're still struggling to answer. in cardio-oncology. And so research is extremely important. And in fact, the American Heart Association has recently published an SFRN strategically focused research network for cardio-oncology. 4 institutions received these application awards for research, and we are looking forward to what we're going to find from these institutions. And this is multi-million-dollar awards. So this is very exciting times for cardio-oncology. Even in, so we were talking about academic centers to a certain extent, but also even in community centers, this particular community program published the list of the sorts of patients they're seeing, the sorts of treatments that their patients are receiving, and the sorts of referrals they're getting for both inpatient and outpatient cardio-oncology management. Some programs do just outpatient, but a good number of programs also have some inpatient capacity. In order to be able to do both outpatient and inpatient capacity cardio-oncology, it would be very important to have at least 2 or more clinicians, because one person doing both outpatients and inpatient is dragging them in all directions, and that would be a huge problem. So we do need more cardio-oncologists in the country to achieve this. And then when we're talking about the referral process in this particular community hospital, they talked about insurance authorization and review by a nurse. So you identify the patients, then after identifying the patients, you place a referral and make sure that all the necessary insurance authorization and everything that comes with it is in place. And then echo is always one of the most important upfront things that we need in these patients. And it's not just to assess ejection fraction. We're kind of getting away from that as a major modality or major source of assessment in cardio-oncology patients. But to assess LV strain, you want to make sure they don't have valvular heart disease, assess for things like pulmonary hypertension, assess for pericardial effusions, either as a result of treatment or as a result of the treatment that's planned. So it's important to look at a comprehensive view of the echocardiogram. Also, things like, if they have significant anemia can lead to high output heart failure. So there's a lot to look at. Also strain, global longitudinal strain in these patients have very excellent data in cardio-oncology for management. And then EKGs are important, as well as cardiac biomarkers. Troponins and BNPs or pro-BNPs are very important to have great data for outcome in this population as they're being evaluated by the cardio-oncologist. And so when we're thinking about the cardio-oncology care team model, it is a multidisciplinary care team model. So you have the oncocardiologist here in the middle. I was very fortunate to have led this paper. Oncocardiologist in the middle, and then you have the cardio-oncology team, the hematology oncology team that directly communicate with them. We need to have institutional buy-in. We need research and education as major aspects of cardio-oncology. And then it's evaluating the patients along with their risk factors. Then there's the hospital social services like social work and case management, and then things like physical therapy, occupational therapy, very important in managing these patients to keep them strong enough to continue treatment and to also continue with, to improve cardiovascular outcomes as they're undergoing treatment. Then of course, family and friends and social support are extremely important, because we do know that our cancer patients most of them have a long way to go. Most of them have a lot of social emotional problems associated with cancer treatment. And so because of that, they do need great support, which will also improve cardiovascular outcomes. And so what are some of the challenges that are faced by our population? Location of practice, whether you're doing academic or community practice is important, because a lot of that will determine the sort of patient referrals that you're going to be getting and the sort of communications and collaborations that you're going to be having. Priorities for patients, ancillary staff, cancer illness and cardio prevention. Then for more formalized training, we don't have enough of those, and that is some of what we're lacking in the field that need to be grown to cultivate this field. As well as lack of practice guidelines. And then there are difficulties with insurance coverage. You have to kind of know the nuances on the sorts of things to get insurances to bill for, so that you can get insurances to cover your cardio-oncology practice. And then complexities of research, because it's spanning 2 different fields. Getting funding can be a little bit difficult or challenging if the societies or the funding groups do not prioritize cardio-oncology as a specific need for funding. And then there's wide-ranging responsibilities associated with the new treatment modalities and the variations in treatment modalities and the evolving care plans for cancer patients, because it's not just one treatment fits all in this population. And so this is also a long list of all the different challenges that are faced in cardio-oncology. Not that they're undoable, they're definitely doable, just that it emphasizes the need to be collaborative and the need to be up to date on literature and to involve all the different multidisciplinary teams in cardio-oncology. And so priorities identified for advancing the field of cardio-oncology: role of cardioprotection, predictors of cardiotoxicity, personalized cardio-oncology. We know that there's the personalization of oncological treatments is part of what's progressing oncologic treatments these days and increasing cancer survivorship. We need more of those for identification of risk in cardio-oncology patients. Enhancing cancer survivorship care, building the community, improving cardiovascular outcomes, especially in stem cell transplant patients and those on immunotherapy, and then managing thromboembolic events and anticoagulation in our complicated patient population. And I always end most of my talks and my papers by mentioning that the aim of cardio-oncology is not to prevent cancer patients with cardiovascular disease and risk factors from receiving necessary life-saving cancer therapy, but to prevent and or treat cardiac disease as best as possible alongside their cancer therapy and care. So again, collaboration is key. Thank you so much. And I'll take questions if anyone has any.
Are we okay to do questions now, or should we wait to the end?
Can I just interrupt? Tochi, can you mention our symposium that we're doing on October 2nd?
Thank you very much. Yes, we do have, we will be running at, thank you very much, Dr. Goldman, Annabelle. So Annabelle and I are running a cardio-oncology symposium, biennial symposium. We do it every other year. That will be going on October 2nd. It will be, it's geared towards all clinicians that are not oncocardiologists, but are interested or have some say in taking care of cardio-oncology patients. So we're inviting everyone to attend: primary care providers, cardiologists, oncologists, advanced practice providers, and trainees, because we need to educate everyone in this important field because we don't have enough oncocardiologists to go around. So please attend. We've been tweeting it, so look out for our tweets and attend. We have a great, excellent group of people that will be presenting. Thank you.
All right, thank you so much, Dr. Okuosa, for that wonderful talk. We'll hold off on the questions until the very end. I'd like to introduce right now Dr. Marla Mendelson, who is the Director of Heart Disease and Pregnancy Program at Northwestern Adult Congenital Heart Center. And she'll be talking to us about the value of obstetrics practice and where to start.
Thank you. Good morning, and it's a pleasure for me to be here. And thank you, Dr. Ashworth and Dr. Khan, for inviting me to participate. I have a lot of formal information to give you as far as the whys and the wherefores of a cardio-obstetric program. And just briefly, and I'm sure many of you have heard me talk about this before, I started our program when I was a fellow over 30 years ago. And the reason I started it was because none of my male colleagues attendings wanted to see pregnant women, which is a pervasive problem in internal medicine. To this day, we have had fellows, medical students participate in some of our research projects, which is an important element of these programs, but I've yet to have a trainee come to clinic with me. So we still have an uphill battle as far as trying to get people interested in cardio-obstetrics, and this is a very important area, and we're going to talk about why in a second, as soon as I can advance my screen here.
Dr. Mendelson, very sorry to interrupt, but could you switch display settings from presenter view to viewer screen? It's at the top right, top left of the screen.
In the taskbar?
No, it says display settings right next to the taskbar.
Change, is that it? Oh,
yes.
Here we go. Oh, I see. Swap. This one? Is that better?
Yes.
Okay, great. I have nothing to disclose. So the problem is that we're doing an abysmal job in maternal mortality in the developed countries. So we have an increase. This is a lot of statistics came from the UK originally. We have a lot of deaths, a lot of it's due to cardiovascular disease. 51% of maternal deaths in the UK were associated with substandard care, which goes to access to care. But also in the US, we had a 30% higher mortality compared to developed nations. This is unforgivable and unnecessary. Our mortality was 1.7%, and 40% of that was cardiovascular disease. So that's kind of our problem. The problem with pregnancy in general is that there's no randomized control trials for intervention. Everything you read is a case report or an expanded case report, and I am guilty for contributing to that, but we learn through expert opinion and experience. We started this clinic, I was all by myself as a fellow, and I had Ket Euland's book in my hand, and now 4,000 patients later, we've seen everything in pregnancy, and it's just a matter of getting experience and applying good cardiac practice. But you can't do this alone, and that's what we're going to talk about today as far as formalizing a program. Most things that we read are by survey, and so there's a limited applicability from these larger observational studies. Basically, we've got US and European guidelines, which are very helpful, but they're based on expert consensus, and we have a lack of formalized training. As everyone on this call knows, that maternal risks of pregnancy as far as cardiovascular are myriad, with arrhythmias occurring for the first time, cardiac dysfunction occurring because of pregnancy and after, hypertension, which has gotten a lot of focus recently. A woman who's pregnant is hypercoagulable, so she's risk of thromboembolic events, worsening or undetected pulmonary hypertension, aortic dilatation, the issue of medications, when in the past the answer was just stop the medication, she's pregnant. That's not necessarily the right answer. And infection risk. These problems often come in because of the expected hemodynamic changes of pregnancy, with things like cardiac output challenging an already impaired heart, increasing heart rate and distinguishing that from arrhythmias. So we have to deal with these changes, and knowing these changes, I think we can anticipate certain problems in our patients with underlying heart disease, such as aortic stenosis. She's not going to do great necessarily with increased cardiac output and increased blood volume, in addition to increases in her heart rate. So this is truly a multi-specialty event, pregnancy. And this is a wonderful Korean painting from the 19th century where you have the pregnant woman there in the middle, and there's her obstetrician, and you've got anesthesiology and cardiology, and we're literally all in the same boat caring for this woman. And that's why it's important to get everyone involved. So who do you need? Of course, you need maternal fetal medicine, and you need general obstetricians. There have been many patients whose only problem has been heart disease that we've managed with general obstetricians, and women develop a relationship with them, and we want to foster that. OB anesthesia is key. There are cardiology subspecialties that you have to have around: electrophysiology, heart failure. Your interventionalists who aren't afraid to do what needs to be done when a woman's having an infarct during the course of a pregnancy. Pulmonary hypertension experts and cardiovascular surgery, which has been done, which is not, we don't like to do it, but if it needs to be done, we need to preserve the mother's health to maintain the baby's development. There are medical subspecialties that get involved: hematology, pulmonology, renal, oncology, and of course the pediatric cardiologist, and more on that later. So this is a very helpful way of looking and qualifying risk. This is probably the best and most complete risk assessment tool, and this is the WHO modified criteria. And I'm just giving you a flavor of what's included in the lower risk group, which would be mild disease or repaired shunt lesions. As you get a little more complicated, unrepaired shunt lesions, repaired tetralogy, arrhythmias, Turner's with aortic dilatation, moving on to a higher acuity, women with EFs that are less than perfect but greater than 45%, hypertrophic cardiomyopathy, the Marfan patient without aortic dilatation, a bicuspid valve patient with an aorta less than 45 millimeters, repaired coarctation, AV septal defects, and then the class 3. These are high-risk women with mechanical valves, previous peripartum cardiomyopathy with residual impairment, the Fontan patient, unrepaired cyanotic disease. These are high-risk pregnancies, and we'll talk about what that means. And then this list of the highest risk are often include women who are contraindicated for pregnancy. Pulmonary hypertension of all sorts, severe aortic stenosis, severe aortic dilatation, especially in the Marfan patient or the Ehlers-Danlos patient with vascular type syndrome, and the Fontan patient who's had complications. So what they did that is so useful is they broke this down, and I've given you some clinical examples of increasing severity and what kind of maternal cardiac event rates. And event rates are usually arrhythmia or heart failure that we can expect in these patients, and how we're going to manage them, how often they need to be managed. Digging a little deeper, this shows as far as counseling, really talking about preconception counseling in this population, if you have that luxury, hospital care, where they should be cared for, especially the high-risk patients should be in an expert center where you have everybody around, follow-up during pregnancy, and where they should be delivered. So this is a very helpful issue because these are the things that can occur in the management of pregnancy. You want to risk stratify them. You look for cardiac risk that you're anticipating, early signs of heart failure, tachycardia, following serial BMPs. So BMP may be elevated in pregnancy. You can follow it serially, adjusting medications and not being afraid to use medications if they're clinically indicated. This is a picture of a fetal echo, which needs to be performed in our women with congenital heart disease and the partners of our men with congenital heart disease. And this is performed by a pediatric cardiologist at approximately 22 weeks. Labor and delivery is of course challenging, but you want to be prepared for it because these are some of the issues that can come up. We want to continue medications on schedule. Some women may need SBE prophylaxis. That's a little controversial. I'm very careful about informing them to be watch how much salt is in the IVs because there's some standard OB practices that may be a problem for our patients. Participation in the second stage of labor, which to us as cardiologists means a prolonged Valsalva. So you can imagine certain patients for whom this would be problematic. We want to monitor for symptoms. We want to decide who's going to be on telemetry and who needs to be on telemetry and how long do they need to be on telemetry and where is the best place for them to continue after delivery. So for us as cardiologists, we can get people through pregnancy, labor, delivery, but it's the postpartum period that is really challenging because that's when they have to redistribute all that extra fluid. So we want to be very careful. Women of the high-risk group who needed to have hemodynamic monitoring during pregnancy, that should be extended for about 24 hours, and that needs probably best done in a CCU setting. Now at our place, our apprentice, the maternity hospital, is about a block and a half, 2 blocks from our intensive care unit. So it's all connected by bridges. Nobody has to go outside, but it presents a logistical problem sometimes because we have to separate the mom and baby, which is not optimal. We've actually been able to talk our MFM colleagues and the labor and delivery nurses to monitoring some of our patients for 24 hours in the labor delivery area. So we have the benefit of maternal fetal medicine, the OB anesthesiologist to monitor the patient where she may be at the highest risk. And then there's follow-up. And this is part of the problem with that has been shown with hypertension. And a lot of gestational hypertension actually occurs after the pregnancy. So it's important for women who have high blood pressure during pregnancy to have a mechanism for follow-up. And continued follow-up. And so that is very important because again, those first 3 to 6 months can be an issue because it may take a full 3 months for the hemodynamic changes of pregnancy to subside. So what do we do in a practical setting? We have a conference. We do educational programs at our institution for medical students, residents, fellows, I've had OB anesthesia fellows in clinic with me. I've had maternal fetal medicine fellows in clinic with me. And so when we get together, we conference several times a year to the attendings from MFM and the fellows, OB anesthesia, their attendings and fellows, our labor and delivery nurses to come up with the plan, cardio obstetrics, which is basically me, and the case-specific subspecialists. So if we need to enlist the critical care folks, the pulmonary folks for our highest risk patient, we make sure they're there. This is the form we use, and this was developed by the maternal fetal medicine fellows, and it's very, very useful. And what happens is once we agree on all the elements of this, and so everybody weighs in and everybody has their input with some of the basic data there and what the plan is going to be, labor, delivery, postpartum, that goes into the chart under their cardiac diagnosis. So it is in Epic and everybody can see it. This has been huge because everyone knows what they're supposed to do, if they're supposed to call the pacemaker people, who needs to get involved and when. And I think this really has helped just codify it and make everyone comfortable that they know what to do. And then the most important thing that we've developed over the years, so we saw all these women initially, they presented at 24 weeks and we got them through pregnancy because we had to. And then we realized that we need to start seeing these women ahead of time and we need to do preconception consultation. And these are the cardiac elements of preconception consultation, but it is really important to involve everybody. And I usually insist that in maternal fetal medicine, if I think they're going to be a high-risk pregnancy, that they weigh in as well. So we want to get all this information before, because many of these women, especially women with congenital heart disease, may have been lost to follow-up for some time. And their pulmonary valve may have deteriorated, and they do much better with a new pulmonary valve before they embark on a pregnancy. We have found women incidentally who had very large atrial septal defects who do better, who came for preconception evaluation. They had a big right ventricle. We closed the atrial septal defect. The right ventricle went down, and they were a much better candidate for multiple pregnancies. So we've got many, many stories and cases of patients who have benefited from preconception evaluation. And we feel that that's an important also part of the of what we do in our program. And then we need to not just talk about the maternal risk, but what about the fetal risks? Is there a risk for congenital heart disease? We need to talk about genetic risks and get the geneticists involved before the pregnancy. And we have to lay all this out because it really isn't our risk to take, it's the patient. And part of this preconception evaluation should be a contraceptive discussion because it may not be the right time now, but we need to talk about cardiac safe contraception so that we can have a well-planned delivery. Pregnancy and future cardiovascular risk has gotten a lot of attention. And looking at postpartum and women who've had problems during the pregnancy and being able to, that's one of our recent initiatives is to be able to keep an eye on women who have hypertension soon after pregnancy. Their internists are not often ready to take over their care, but this is a service that I think is very important because if we drill down on that cardiovascular disease risk, most of that risk comes in with hypertension. In conclusion, this is a multidisciplinary undertaking. It is gratifying. It is intellectually stimulating. I'm trying to induce the trainees to get involved with this. It requires a lot of expertise, and basically we want a safe pregnancy for both mother and baby. And of course, this is our goal. This is a woman who ran the Chicago Marathon and then just went to deliver. So our goal is to have a safe pregnancy for everybody with very careful planning and expertise. Thank you so much for your attention.
Thank you, Dr. Mendelsohn. Excellent talk. And I don't really see any questions right now, but I did have a question listening to these wonderful talks and sort of drawing from personal experiences, the limited exposure that we have, whether it is to women's heart health or cardio-oncology or pregnancy and cardiac disease. So what are some of the things that from at your institutions that, if this is an open question, that you've done to maybe increase the exposure and also push for perhaps some formal training in this?
Well, we've been trying to get people involved with our program. We provide opportunities for research, and that's one way to get people interested. I have actually many years ago I started with a medical student. I started a heart disease and a women in heart disease rotation. And what's been very interesting is we get people in this rotation. It's a month-long rotation. They get to see a lot of women in cardiovascular disease, a lot of pregnant patients, and they get very interested in the topic. And many of the people who I've worked with have gone on not just to be chief residents in our program at Northwestern, but they've gone on to cardiology. So I think there's no place where we can't intervene. Even we did a program with high school and college women, getting them involved in women's cardiovascular health. And so again, then they start seeing opportunities and things like that. So we really need to and we lecture and we do some formal lecturing. I think it's important to engage wherever we can, men and women trainees, to give them the experience they need.
Yeah, for us in cardio oncology, one of the things that we've done in Chicago is that we formed the Chicago Cardio Oncology Consortium, which involves the cardio oncologists for each of the major academic centers in Chicago. There's 8 of us. And we have this every 2 to 3 month rounds. We call it cardio oncology rounds. And it's actually presented by a trainee, either a cardiology fellow, an oncology fellow, or a resident. And it's moderated by one of us, depending on the institution that's presenting. And we discuss cases in cardio oncology, usually about 2 cases in depth with an oncologist involved, a cardiologist involved, and usually has over 100 attendees for each of these. So that's one way that we're generating trainee interest overall in the Chicago area. And then institutionally, just like Dr. Mendelson was pointing out, is involving trainees in clinic and getting them interested in learning more about cardio-oncology in clinic, and also CHIMO boards as well, attending CHIMO boards and having direct conversations with the oncologists and discussing cases and having direct relationship with the oncologists by email or by conversations, depending on the patients that we're seeing. So I think that there are many ways to do this in a collaborative way, in such a way that we can generate trainee interest. But these are just some of the things that we've done. It's more comprehensive than that, though.
And I would echo everything the prior 2 panelists have said. For me, my introduction to heart disease in women came in 2nd-year residency when I met Dr. Rekha Mankad. And I think one principle I imbibe by is practice what you preach. And when fellows and trainees see you do that, their interest peaks. So even though I may not be scheduled in the women's heart disease program, even if I'm, say, on CCU wards, I still talk about sex differences and why a woman is presenting a little differently than men and so forth. And that way, the male trainees that often do not choose to rotate through the women's heart disease program hopefully get a little glimpse of what this is about. And I've had some people come back and shadow me and learn more.
Thank you all very much for the educational information on business of medicine. I think this is very important. It's important to know the awareness about these programs, important to consider how to start them, how to grow them. So really appreciate all the input and interaction you have given here. And thank you very much, Dinada. Dinada is just finished her fellowship. She's starting a new job. She has a baby, so she has to play full right now. So thank you. Conference. So we'll move on to the next session. We have 3 case discussions. This is probably the last session about science in this meeting for today. The first one is going to be cardio-oncology, and it's going to be a case by Aruj Khan or FIT. And she's going to be supervised by Dr. Sherian Brown.
Thank you very much, Dr. Ashwath. Are my slides visible?
Yes, go ahead.
All right. So we will be presenting today a case of a 57-year-old female who was referred to our clinic for evaluation for cardiac resynchronization therapy due to persistent heart failure with reduced ejection fraction, EF of less than 20%, and left bundle branch block. Her QRS duration, as you can see, is almost 150 milliseconds. Patient's past medical history was significant for left-sided breast cancer in 2012. She was status post chemo and radiation therapy, which was completed in 2013. She also had a history of heart failure with reduced ejection fraction, which was diagnosed in 2016, and type 2 diabetes. Of note, prior to starting chemotherapy, her ejection fraction was 58%. And she did well initially after completing chemotherapy till 2016, when she was first referred to a cardiologist for exertional dyspnea, chest pain, and palpitations. She got an echocardiogram, which showed an ejection fraction of 35 to 40% with diffuse hypokinesis, moderate MR, and mild TR. As part of workup, coronary angiogram showed minimal diffuse coronary artery disease. She was started on guideline-directed medical therapy with slight improvement in EF to 45 to 50% and mild MR seen on a follow-up echo about 7 months later. And she continued to have good functional capacity till 2020. In March of 2021, she reported NYHA class 3B symptoms. A repeat echo at that time showed worsening LVEF to less than 20%. After 3 months of persistently low ejection fraction on guideline-directed medical therapy, she was referred to our institute for CRTD therapy. So she was initially seen in the EP clinic, but due to persistent NYHA class 3B symptoms, she was directly admitted for heart failure optimization prior to any device implant. When she was admitted, her blood pressure was borderline low, 90/64. She was tachycardic with a heart rate of 113 beats per minute. Her NT-proBNP was elevated at 20,000, lactic acid was 4.2, and creatinine was elevated at 1.8 from a baseline of less than 1. She was started on 2.5 mics of dobutamine and referred for right heart catheterization. Essentially, all her home medications were held. She was on a pretty good medication regimen, including Entresto, metoprolol, spironolactone, and empagliflozin. Right heart catheterization showed elevated left and right-sided filling pressures, low cardiac output and index on 2.5 mics of dobutamine. Her echo essentially showed enlarged LV, severely decreased LV systolic function, global hypokinesis, and somewhat of an enlarged RV with decreased RV systolic function as well. And as you can see, biatrial enlargement. So after those numbers, after the initial testing was done, those numbers on the right heart catheterization were obtained. She was started on afterload reduction with sodium nitroprusside, received IV diuretics because of the very elevated wedge. However, because she was still maintained on dobutamine as well, she had worsening sinus tachycardia with heart rate up to 150s and frequent non-sustained VT. And unfortunately, stopping dobutamine resulted in decline in her PA saturations down to the low 30s. Given her fragile hemodynamics, she was switched over to milrinone 0.125, which was essentially the highest dose she tolerated without any further non-sustained VT or worsening tachycardia. But her hemodynamics remained pretty tenuous, and she got an intra-aortic balloon pump placed and underwent an expedited transplant workup. As part of transplant evaluation, we revisited her prior breast cancer history. So in 2012, she was diagnosed with stage 2B left breast invasive ductal carcinoma, which was hormone receptor positive, and she went through 6 cycles of anthracycline-based combination chemotherapy, followed by whole breast radiation. She was cancer-free since 2013, and since then she had been maintained on long-term hormone suppression. And as part of transplant evaluation, one of the questions we asked our oncology colleagues was whether after cardiac transplantation, immunosuppression would increase her risk of recurrence of breast cancer, or whether that would decrease her mortality long-term. And essentially, the oncology team said that her risk of disease recurrence was less than 7 to 10%, including the contralateral breast. And oddly, they felt that there was no further increase in risk with immunosuppression from heart transplant. And then we also did discuss with our radiation oncology colleagues about what implications left breast radiation would have for sternal access. And essentially the radiation oncology team felt that just left-sided radiation, breast radiation to the chest would not would not cause issues with sternal access or sternotomy during transplant surgery. So the patient was listed as status 2 for heart transplant. However, her calculated panel reactive antibody level was 70%. She'd had prior 3 childbirths, and she'd been transfused blood in the past. So her CPRA was pretty high. And unfortunately, because of that, there were no suitable transplant offers over the next 3 weeks, but her hemodynamics continued to remain very tenuous. And with declining hemodynamics, she actually was upgraded to an Impella 5.5. And then after Impella placement, her CPRA rose to 92%. Given the very high CPRA and the low likelihood for a suitable transplant offer and her persistently poor hemodynamics, the decision was made to pursue a left ventricular assist device. And she underwent successful LVAD implant on the 18th of August. Immediately post-operatively, she did have some issues with hemodynamics and required high doses of inotropes and vasopressors, but was slowly weaned off and has continued to recover. So in summary, we wanted to discuss this case of chemotherapy-induced cardiomyopathy with progression to advanced heart failure requiring mechanical circulatory support. I'm going to hand over to Dr. Sherry-Ann Brown for leading the discussion. Dr. Sherry-Ann Brown, I just want to give a quick introduction for her. She's the Director of Cardio-Oncology at the Medical College of Wisconsin-Milwaukee. She's also a research collaborator with the Mayo Clinic, and she's the ACC National WIC Leadership Council and Innovation Section Head. So Dr. Brown, I'm going to hand over to you from now.
Thank you, Dr. Khan, for a great presentation. And it fits nicely coming after the session with Dr. Okoso as well. So many of you who are on today are my friends and mentors, and so it's great to see many of you. It's also wonderful to be on the ACC WIC Leadership Council as a member, and similarly for the innovation section being a member as well. So we know that chemotherapy-induced cardiomyopathy can have many forms, and unfortunately, for some of these individuals, they can need escalating cardiovascular management and sometimes end up needing LVAD or transplant. You can see some of the numbers on the screen, and the general sense that we've seen over time is that there's really no safe dose of anthracycline therapy, and the higher the cumulative dose, the higher the incidence of heart failure. And you can see also the fact that, generally speaking, anthracycline-induced cardiomyopathy tends to be irreversible, although many individuals can have recovery of the ejection fraction with medication treatment. And we don't like to use the term normal because the heart never really goes back to normal, but the EF can recover. Next slide. And we think about the exact contribution of this kind of cardiomyopathy to individuals with advanced heart failure in the United States. And many years ago, even though there have been studies looking at similar questions, there's no exact number for this. But we do see this from time to time. And so it's very important for us to collaborate very closely with our colleagues in advanced heart failure and transplant. And that's one of the things that's fantastic in cardio-oncology. And you also saw a bit of this in cardio-obstetrics as well. The fact that we need a variety of subspecialties in cardiology and across medical oncology, hematology, surgical oncology, general surgery, and so on, to be a part of the comprehensive team for these patients. Next slide. And We often think in cardio oncology about the fact that we're not only managing, but also focusing on prevention. And so for individuals who have not yet developed cardiomyopathy from cancer therapies, we know that, for example, with anthracyclines, there are a number of different guidelines that can be looked at or even harmonized. And once a patient has had 200 to 250 milligrams per meter squared of doxorubicin, we want to ensure that they're having frequent surveillance. But it's important to recognize that not only the dose of doxorubicin or other anthracyclines, and not only the EF determines whether a patient is high risk, there are other factors too, such as have they had prior chemotherapy? Have they had prior radiation? Are they having concurrent chemotherapy and radiation? Are they over 60 years old? Do they have hypertension, diabetes, and so on? So it's important to think about the patient factors as well as the treatment factors, in addition to considering what is the EF at the time of treatment and what doses they're getting of anthracycline therapy. And so frequently we will have closer monitoring for those who are considered to be higher risk, with echoes after every cycle or every other cycle of anthracycline therapy. Next slide. And although we know that we tend to see cardiac dysfunction in these individuals often within the first year of treatment, we all know that many of us were first introduced to cardio-oncology when we were on a rotation, when we saw a woman who was being treated with heart failure that was thought to be due to anthracycline therapy 10 years before. And so it's important for us to recognize that not only should we be looking for cardiac dysfunction within that first year, but having individuals know that there's long-term effect of anthracyclines on the heart. And so different guidelines have been thinking about the long-term surveillance for patients. Is it 1 year out? Is it 5 years out? Is it 10 years out? And so it's important to be aware of the various guidelines and options. For example, those we're showing on this slide, to recognize that we can look at 1 year, 5 years, 10 years. And it also has to be, according to what's been mentioned before in some of the talks, individualization. And so if someone has higher risk than others, or if they've already had a drop in ejection fraction, then they will need closer surveillance. Next slide. And so to summarize, again, Dr. Khan has done a really nice job presenting this case so that we can think about anthracycline-induced cardiomyopathy, not only in the short term, not only for those who recover, but also for those who don't recover the ejection fraction. And thinking about the role of Impella, the role of the balloon pump, the role of LVAD, and recognizing, as has been stated before, the super importance of having multidisciplinary teams. And so as we think about this, one of the things I'd like to share with us is one of the poems from a book called Your Heart and Cancer. It's my book, and it's very thin. And the reason I like writing poetry about this sort of thing is because I find my way of processing what we do with and for our patients through poetry to be very helpful for me. And I find it meaningful when some of you also can see yourselves in the poetry, and then the effect it also has on our patients and their families who read the poetry as well. This one is very short. I'll read it for you from page 13. It's called Protecting You. Protecting you is what I do. I give myself that you might live. Let me shield you and use my sword. In the end, we will yield the victory. It's not over till we say it's over. Let the arrows come, and I will raise the wall and repel them all. Some might make it through, but we will make it still. Hand in hand we fight. We will make it through the night. And that's one of the ways in which I think about what we do with and for our patients as we work in these multidisciplinary teams to walk alongside our patients in their cancer journey. Again, great case, Dr. Khan.
Thank you very much, Dr. Brown. And I think I've already thanked you multiple times, but I want to formally thank you again for your guidance in helping direct the course of this discussion and also helping me to organize my case and my case presentation. So thank you again.
Fantastic work. Thanks for having me.
Thank you.
Sharian and Aru. On to Jin and Anu. They're going to be discussing a SCAD case. Jin is a cardiology fellow at the University of Iowa, and Dr. Tunagapla is an interventional cardiologist in Nebraska.
Thank you so much, Dr. Ash.
Jin, you're muted.
Sorry. Yeah. Thank you so much for the introduction, Dr. Ashwath. Today, I will be presenting a case of a SCAD with Dr. Tanu Gantala. So I will start with a case presentation. So this is a case of a peripartum spontaneous coronary artery dissection. I have no disclosure. So this is a 27-year-old African-American female, G3P2 at a 33-week, 5 days gestation, presented with a chest pain which woke her up from sleep. She does not have any significant pathognomonic history, and then her family history is a non-contributory, and so her social history is also unremarkable. This is her EKG on presentation. At the other hospital, you can see clearly ST elevation in the lateral leads as well as anterior leads with reciprocal change in ST depression in inferior leads. So initial workup at the other hospital showed troponin, initial troponin I was 0.12, increased to 15.5. Triple rule out CTA chest showed no aortic dissection, no PE, and no aneurysm. At the other hospital ED, she was loaded with aspirin, started heparin bolus and a drip, as well as nitroglycerin drip. And then she was transferred to our facility for emergent coronary angiogram. So this is her films. You can clearly see this is a left coronary artery system. You can see the dissection of went from osteo left main to distal left main to the proximal LED, as well as proximal left circumflex. And then this is a spider view of left coronary system. Again, see dissection in the left main, extending all the way to proximal left LED, as well as proximal circumflex. Her right system is clear, is normal RCA. So, and intra-aortic balloon pump was implanted. So at this point, multidisciplinary discussion regarding timing of the delivery was held between among high-risk OB team, cardiothoracic surgery team, as well as interventional cardiology. So high-risk OB team recommended C-section prior cabbage for fetal and potential maternal benefit. Their plan is to control hemostasis with the closure of hysterotomy, uterotonics, leave the abdomen packed and open. However, on the other hand, cardiothoracic surgery thinks bleeding risk from a hysterotomy is too high with anticoagulation and could dramatically compromise maternal cabbage and decrease likelihood of maternal survival. So the final decision was proceed with the cabbage, plan to deliver the baby in case of a cardiac arrest only to aid in maternal resuscitation. So the patient underwent cabbage on the same day of the presentation. Intraoperatively, the dissection of the left main, left circ, and LED was visible. And she underwent 2 vessel cabbage with a vein graft to LED, vein graft to OM, remain on balloon pump 1-to-1 support. So this is her intra-op TEE, which shows severely decreased LVEF of about 15-20% with hypokinesis to akinesis of anterior inferior anterolateral wall. RV function is slightly reduced. So also her intra-op TEE shows dissection of left main. So in this view, you see the dissection flap, And then here it's cross-section view, better view of the dissection flap in the left domain, so as did this view. So post-CABG, she was admitted to a CVICU. She was starting on CRT for AKI from ATN. She remains on inotropic support with dobutamine, afterload reduction with hydroxyzine, and I-10 platelet with aspirin. She remains intubated. At this point, aortic balloon pump was went off. Post-CABG, she was closely followed by high-risk OB team. They did brief fetal monitoring by ultrasound on a daily basis. Goal is to maintain maternal hemodynamic stability for support of the fetus. In case of a maternal arrest, resuscitative hysterotomy and delivery within 5 minutes of arrest. At the same time, newborn warmer, forceps, and C-section tray remain in the room in case she needs emergency section. Post-CABG day 6, at 34 weeks, 2-day gestation, fetal monitoring showed minimal variability, decelerations were noted. And her LVF at this point improved to 40%, her dobutamine reduced to 2.5 mg per kg per minute. After extensive discussion among cardiothoracic surgery team, advanced heart failure team, and as well as high-risk OB team, the plan was proceed with a C-section. So epidural was placed, and she was given slow bolus. She delivered a male infant with a body weight of 1.9 kilogram, Apgar score 6 at 1 minute and 7 at 5 minutes, and he was admitted to NICU immediately after delivery. The patient was doing very well, remained stable without any increase in inotropic pressure support. EBL 400 cc, and then she was given same amount of IV fluid. So this is her echo on the day of C-section. You can see the LVF significantly improved to about 40%, still has same hypokinesis. Post-CABG day 8 to 9, she was weaned off dobutamine, she was off CRT. Post-CABG day 12, her EF improved to 50 to 60%, still has some hypokinesis in the anteroseptal wall. Post-CABG day 18, she was discharged home with her new baby, and as well as guideline-directed microtherapy with the lisinopril, carvedilol, and Lasix, and dual antiplatelet therapy with aspirin and Plavix. So that's about the case. I will hand over to Dr. Tanu Gantula for further discussion about SCAD. Thank you.
That's a fantastic presentation, Jen. Thank you. In the next 5 minutes, I'll just briefly talk a little bit about SCAD. Can everyone see my slides?
Yes.
Okay, fantastic. Okay, so I don't have any disclosures relevant to this talk.
Anu, can you hit the slides? Yes, perfect.
Okay, thank you. So spontaneous coronary artery dissection is a non-atherosclerotic, non-traumatic, non-iatrogenic cause of acute coronary syndrome and sudden cardiac death. So there are 3 types of SCAD. Type 1 is actually not the most common one. And in this, you see the classic dissection. This is the case that Jin presented. And you see multiple radiolucent opacities on the angiogram. And if you image these patients, you can see dissection flap. Type 2 is more smooth, diffuse disease. And type 3 is focal narrowing, which mimics atherosclerosis. Some of the inciting factors that cause SCAD is intense exercise and emotional stress, and also Valsalva straining. Some of the risk factors associated are pregnancy, fibromuscular dysplasia. These are associated conditions. Connective tissue disorders, arteriopathies. There's also a growing interest in the genetic component. So there are 2 mechanisms. One hypothesis, which is the more common one, is medial hematoma. And this can expand and compromise the lumen and cause ischemia, as well as shock and very severe presentations. The other hypothesis is inside out, where there's an intimal tear, and this can cause blood pooling within the media, and there's separation of the intima and the media. So this is the less frequent form. This is the case that Jen presented. So women comprise actually the majority of the patients of SCAD, up to 95%, and the mean age of presentation is 44 to 53 years of age. And although the traditional risk factors are quite infrequent, hypertension, hyperlipidemia is similar to age and sex-matched populations. So pregnancy-associated SCAD occurs anytime during pregnancy. However, the majority occur postpartum, and most of them within a week. Compared to those patients with SCAD who are not pregnant, the ones who are pregnant have more severe clinical presentations, impaired LV systolic function, shock, multi-vessel, left main dissection, and pregnancy-associated SCAD is seen in about 10% of the SCAD population and about up to 50% of pregnancy-associated acute myocardial infarction. So women with pregnancy SCAD compared with those who are non-pregnant tend to be older at the first childbirth as well as multigravidas. All SCAD patients are more often multiparous as well as higher prevalence of prior infertility treatment and preeclampsia. So approach to the pregnant patient with prior SCAD, the preconceptual planning is extremely important. Counseling is important, maternal fetal specialists, cardiologists, the multidisciplinary team aspect, assessing their current cardiovascular risk status, LVEF, symptoms, functional capacity, and consider stress testing in these patients. Certain medications like aspirin, clopidogrel, and beta blockers, there's no teratogenic risk. However, with beta blockers, it is noted that fetal growth restriction later in gestation is seen, and it's okay to continue them if clinically indicated. Again, this can cause, the bradycardia in the fetus, so that's important to monitor. However, stop statins, ACE inhibitors, ARBs prior to conception, or if you know they're pregnant. Special considerations beyond the routine prenatal care is early ultrasound, 7 to 8 weeks to determine the viability of the fetus, number, gestational age. Cardiac eval as well as maternal echoes at every stage of their trimester is important. Also consulting with anesthesia, about 32 to 34 weeks, and the multidisciplinary team review at 34 weeks to discuss the timing, location, and method of delivery. Discontinue clopidogrel to facilitate neuraxial anesthesia. So this is the last slide. I'll just go briefly through the management of acute SCAD. So clinically, if the patient is stable, there's no high risk anatomy, walk away from doing any intervention because the technical failure with PCI as well as complications is extremely high. So even if they have chest pain, you might be better off just treating them medically. So conservative therapy. And it's also important to note that these patients have complications. So extended monitoring inpatient for at least 5 days is very important. So now if they're clinically stable, however, they have high risk anatomy, left main, severe proximal two vessel disease, like the case Jin just showed, those cases, if they're unstable or again, they're supplying a significant amount of myocardium, considering CABG is important. And when you do CABG, actually doing vein grafts might facilitate doing a quicker procedure. And most of these patients, actually 90% of them will heal. The hematoma heals and the arteries become essentially normal, even as quickly as 30 days. So even if you just put vein grafts to get through the acute situation, in the long run, these patients do fine. So they have an ongoing ischemia, shock, they're hemodynamically unstable, then you want to consider either PCI or urgent CABG, depending on the local expertise. Thank you for your attention. Any questions?
Annabelle has a comment about we really need to emphasize the point not to intervene with the artery if there's no high risk anatomy intervention.
Yes, that is correct. I mean, I think you end up doing a disservice to these patients. Yes, so thank you, Annabelle. It's extremely important to try to refrain from making a stable situation actually unstable by propagating the dissection, acute closure, technical failure, late stent malapposition. So yes, treat these patients medically if you can.
Awesome. Thank you very much, Anu, and thank you very much, Jen, for that excellent discussion and presentation.
Thank you. Thank you, Dr. Thanagothalan. Thank you, Jen. I want to introduce our next case presentation on myocardial infarction with non-obstructive coronary artery disease by Dr. Sepide Darbandi, who is a second-year cardiology fellow at Mercy One North Iowa Medical Center. And she's presenting along with Dr. Ashwath, who is our very own Iowa ACC president. So I'll hand it over to you, Sepide.
Hello, everyone. Thanks, Aruj, for that kind introduction. As she mentioned, I'm a second-year general cardiology fellow. Today, with the time I have, we'll be talking about myocardial infarction with non-obstructive coronary artery disease, also abbreviated as MINOCA. For the sake of time, I'll just refer to MINOCA from here on out. Let me, I guess, go to, okay, so now my slides are showing, right? Is that correct?
Yes, they are.
Okay, perfect. So I have no disclosures to report. The objectives of today's case, we'll start off with a brief case, then sort of dig deeper into the definition, pathophysiology of MINOCA, and then talk about the management a bit. And then towards the end, we'll touch base a little bit about the literature review that's available right now, and also the future directions of this condition. So our case is a 64-year-old female with no prior cardiac history. She presented to the emergency department with intermittent chest pain for 4 hours. She really didn't have any similar pain in the past like this. She said it suddenly came on. However, on examination in the ED, the pain had already resolved. As far as her vital signs, it was only remarkable for high blood pressure. Her blood pressure was 189/111. But otherwise her pulse was in the 60s and sinus rhythm. I only included the pertinent physical examination. Her cardiac exam was unremarkable, regular, really no JD or lower extremity edema. As far as her labs, her troponin level was 39. It did elevate to 200. And her LDL was 140, but otherwise no remarkable laboratory values. As far as her diagnostics, her chest X-ray was unremarkable. I'm trying to advance to the next slide here, sorry. Okay. All right, there we go. Her admission EKG showed sinus bradycardia, no acute ischemic changes on the EKG. So there was some non-specific T wave changes, but otherwise not really anything that would suggest an acute ischemic process from what we could find. Further workup, her echocardiogram showed preserved ejection fraction. She did have regional wall motion abnormalities in the anterolateral segment. Thus far with this clinical picture, we had a female in her 60s, her risk factors for heart disease being gender, age, and hypertension, history of hypertension. With her putting together with her laboratory work with the elevated troponin level and also the non-specific EKG changes, we really suspected an ACS presentation. So she was treated as such with aspirin and Plavix load and also further medications for that. Within the next 24 hours, she was scheduled for a coronary angiogram. Here on the left, you can see the right coronary system, really no perfusion defects that was noted. Her left coronary system, also same thing, no obstructive disease or any perfusion defects that were noted. So from here, so she basically, okay, there we go. So she basically presented with an MI picture, but then on the other hand, we were dealing with the angiogram images of non-obstructive disease. So we, the working diagnosis that we had suspected from there was either plaque rupture or coronary spasm, given her risk factors. For the remaining of her clinical course, it's of significance. Her troponin did peak at 9,000. After her angiogram, she really didn't have significant any more chest pain or such. So she was conservatively managed pharmacologically with medications. Due to the concerns of a plaque rupture or so, she was discharged on dual antiplatelet therapy and statin and IMDR. So based on this case right now, whoops, sorry, I clicked on the wrong one. So based on this case right now, we really concluded that this could be Menoka. So the goal of today is to further discuss what exactly Menoka is and further talk about it. So the definition of Menoka, really, we need to think about three pillars of this condition. The first being acute MI criteria, non-obstructive coronaries, and also no clinically overt cause for other causes for the ACS presentation. So non-cardiac causes need to be ruled out. So to basically emphasize that the definition of Menoka really falls on these three highlights highlighted in the yellow color. So I won't go into the details, but the acute MI criteria, basically, as we all know, it's defined as increase in cardiac biomarkers, and also one of the clinical markers, which can include regional wall motion abnormality on imaging, ischemic symptoms, or new changes on EKG. Non-obstructive coronaries defined as less than 50% obstruction. So that is a number to know, and also, like we said, to rule out other causes that could contribute to an ACS presentation. So these are some highlights from. These are some highlights about Menoka, meaning that Menoka is a distinct clinical syndrome. So it's not a final diagnosis. It's rather a working diagnosis that should prompt further evaluation regarding the underlying mechanism. It is seen more commonly in women and young patients. Unfortunately, the current literature, most of the information we have on Menoka, the information is extrapolated from actually studies that have enrolled actually men mostly, but so the literature in looking specifically at females are rather limited at this time. Before labeling a patient as having Menoka, we need to exclude three things. We need to exclude other causes for elevated troponin, like we said. That could include non-cardiac causes like hemorrhage or respiratory failure or anything rather. And we also need to reconsider overlooked obstructive coronary disease, meaning that, for example, on angiogram, if there's any kind of distal stenosis or small branches that that we can basically look again on the angiogram images to see if that could be a like obstructive MI kind of presentation. We need to make sure that we exclude that. And also non-ischemic causes for myocyte injuries such as myocarditis needs to be also considered in evaluation. Of all the patients who present with acute MI of obstructive disease MI, up to 15% are actually Menoka. And at a large scale, when we look at that, that's actually quite a fair number of patients that present at any time to us, and it's actually Menoka. I wanted to just emphasize that there's similar 1 month and 1 year mortality rates with comparable quality of life measures in patients with Menoka comparing to patients with obstruction disease, coronary artery disease. So in evaluating the underlying cause for Menoka, it largely divides into two groups: atherosclerotic causes and non-atherosclerotic causes. Atherosclerotic causes, basically we're talking about epicardial coronary artery disorders. So any kind of plaque disruption, such as plaque rupture, ulceration, erosion, coronary dissection. Actually, up to in Menoka patients, up to 40% of these patients, plaque rupture is the main etiology for this. So that just emphasizes the importance of further investigating the cause of Menoka, such as if there's intracoronary imaging, such as IBIS or optical coherence tomography, OCT. Those are the modalities that should be considered to evaluate for plaque rupture. As far as non-atherosclerotic causes, we can think about coronary artery spasm, microvascular dysfunction, like we talked about SCAD, and coronary thrombosis. These are all non-atherosclerotic causes of MINOCA. Coronary artery spasm is a common, and actually it's an essential pathogenesis of MINOCA. So that should be strongly considered in these patients. In determining the cause, as we haven't said it enough already, we need to establish the specific cause for MINOCA in these patients. So in determining the cause, this is a rather stepwise picture of what can be considered. After the first level diagnostic investigations, such as your history and physical, EKG, or laboratory work, these patients, since they present like a since they present as a ACS process, as a heart attack, they routinely go under a coronary angiogram, and based on that, we can decide on what is the best next step in evaluating the cause for MINOCA. So basically, based on our clinical suspicion, that would determine what other diagnostic modality to use. So for example, for suspected plaque rupture, like we talked about, intracoronary imaging such as IVUS and OCT are routinely performed. For coronary spasm, we do provocative testing such as acetylcholine testing in the cath lab. For myocarditis, cardiac MRI. And so these, like I said, based on the clinical suspicion, the next diagnostic imaging modality would be decided on. Now, I just wanted to emphasize that cardiac MRI in establishing the specific cause for MINOCA has evolved as actually the gold standard for non-invasive assessment. Because it's rather safe, it has intra-observer consistency, and also it's able to characterize the myocardium. So I just wanted to really emphasize the role of cardiac MRI that has now it's part of the guidelines, and on ACC, it's basically written everywhere about cardiac MRI and the importance of it in establishing a cause for MINOCA. This is a picture. This is not the case, a picture of our case, but I wanted to include it as a. Oh well, I guess I have 1 minute left, so I'm going to sort of breeze through here. So IVUS is important in. IVUS is important in establishing the role if we're suspecting plaque rupture or so. Basically, intracoronary imaging would be something that needs to be considered. This is a cardiac MRI, again, not from our patient, but basically it's showing hyperintensity signaling in the area that was suspected to have some perfusion defect. There was only 40% lesion in the area on the angiogram, but as you can see on the MRI, from the base to the apex, there's hyperintensity signaling, which could basically, it just reemphasizes the importance of cardiac MRI in establishing the etiology of MINOCA. Management is specific to the underlying cause. I just want to, in the limited time that I have right now, I just wanted to mention that the role of ACE inhibitors, and beta blockers have been investigated thoroughly through literature. ACE inhibitors and stent therapy have been found to be beneficial in reducing cardiovascular adverse events in the future in MINOCA patients. Antiplatelet therapy and beta blockers actually are still under investigation. Their roles actually are not very clear at the moment, but ACE and ARB and stent therapy are the main main medications that have been proven to reduce MACE in the future. This was a pooled 28 publication that showed the overall prevalence of MINOCA to be 7%. And like I said, in a large scale, that's quite a number of patients that have MINOCA among cardiac patients. This is a slide going over the risk factors comparing patients with MINOCA and patients with obstructive MI, coronary artery disease. So as you can see, the risk factors for MINOCA are fairly comparable to patients that have obstructive disease. I would like to just mention that I would just like to, well, I would just like to mention that in patients with Minoka, actually it has been found that Minoka can be associated with anxiety, depression, and disproportionately it affects women. So it's a very important condition to consider in females. So just as the future direction, I'm just going to mention this one study. We have talked about the importance of cardiac MRI and intracoronary imaging, such as OCT, in assessing the mechanism of Minoka. In this study, which was an all-women study, it was found that multimodality imaging actually was abnormal in 85% of women with Minoka. So these two studies, whether in combination or independently, they provide useful diagnostic information.
So Peter, in the interest of time, we thank you.
And these are my conclusions. Should I stop there, or I think I'll just stop.
Yes, go ahead.
So conclusions, Minoka is a group of heterogeneous diseases. It arises from a variety of causes. It is not a benign process. It should be taken seriously. And also, like we talked about, there's diagnostic tools to evaluate the mechanism of Minoka. And identifying the etiology is critical in treatment and prognosis.
Mr. Peter, for that amazing presentation and discussion. She was doing such a great job, so I just let her do the whole thing here. So,
so yeah, it's hard. The structure of it. I of course the multiple sessions and also the guidance that I got from Dr. Ashwas for this presentation. I really do appreciate it, and I want to formally put it out there.
Awesome, thank you, very good. So I don't see any specific questions, and in the interest of time, I think we will move on. Before the lunch break, I just wanted to say a couple of things. Most of the moderators and speakers should have got these cups. I don't know if the cup is showing or not, but should have got this Iowa ACC cups. The Iowa chapter folks, you'll be getting it from Aruj. She was supposed to pick up a couple of days ago, but then I got sick, so I asked her to hold off until I get better. So she will be passing them on to the Iowa City people. I hope the others got them. If you didn't, awesome, Tanya. If you didn't, and if you sent your addresses, Autumn is taking care of those. Thank you, Autumn, for doing that. I would also like to mention one of our fifth, Shubhadeep Roy, who is our social media representative. And he is the one who's behind 90% of the tweets coming out from the Iowa chapter of the ACC, because I'm so Twitter naive and ignorant. So he's compensating very well for this. He has attended the conference last year and this year too. So thank you again, Roy, for everything you do for this conference and for the chapter. We're going to take a break and we will reconvene at 1:30. We are essentially done with our science topics. So we really only have two sessions with soft topics, one with a discussion about books, and then another one with family and finances, both of which should be very fun. So I look forward to seeing you all back at 1:30. Enjoy your lunch. And if somebody wants to hang out and have a chat, please feel free to do so.
Looking forward to your book, Sharon.
Oh, thank you. It was such a great read. I've been wanting to read this book for such a long time. So it's nice to have the assignment to finally get it done.
Awesome.
So I hope to continue. The rest of the list looks so fascinating. I can't wait to hear the presentations and hopefully get to some more reading myself, in all our free time that we've got.
Yes, that's true. Good job.
Forced you to read this book, huh, Sharon?
Well, I've actually had it on my shelf since it was recommended to me for a very long time, and life happens and you don't get around to reading it. So it was nice to have the extra motivation.
That's awesome. Tanya, I don't know if you know Sharon. Sharon is one of our CT surgeons, and Tonya is a cardiologist, and she's actually the WIC chair.
Yes, great.
Yeah, yep. And I love to read, so I'm always looking for any suggestions and listening to more books, book reviews or anything. So that's my favorite thing. So I'm so glad we're doing this.
Yeah, Tonya is actually, I think she's leading her group, and I'm sure has enough things, but she still keeps things. She handles so many things. I don't know how she does it. It's pretty amazing, I think so.
I let other people do lots of things. I just do the things I like.
Delegation is a great mark of good leadership. So it's very important.
And Isabella, thank you for joining in. Isabella is our Vice Chair of Clinical Research in Cardiology, Tanya. So she is very active, I think, with the AHA more than the ABC, but also oncology and stuff. So there's a lot of radiation oncology research, and so I think we can go ahead and get started. Maybe it's 1:32 in the interest of the people who are here. The next session, Books That Inspire, and it'll be moderated by me along with Jen Streeter. Jen Streeter is a cardiology associate at the University of Iowa. She recently graduated from her fellowship in July. So congratulations, Jen, and I'll let you take over.
Great. So in the interest of time for talks and discussion, I won't be sharing the entire bio for each speaker, but I encourage everyone to visit iowaacc.org to see the full bios of all these amazing women. To start our session, I'm pleased to introduce Dr. Sharon Beth Larson. She's a clinical assistant professor in the Department of Surgery and Division of Cardiothoracic Surgery, and is the surgical director of the ECMO program here at the University of Iowa. She will be discussing our first book by one of my favorite authors, Malcolm Gladwell. The book is Blink, The Power of Thinking Without Thinking. Dr. Larson, the mic is yours.
Well, thank you very much, Jennifer, for that introduction. And I'll get my screen up here. Maybe. There we go. Okay, I don't have two screens, so is everyone able to see the slides okay? Terrific. So thank you so much for the honor of joining this incredible group today. I'm going to be presenting on Blink, the Power of Thinking Without Thinking by Malcolm Gladwell. And I have no disclosures. And so the three tasks of this book were to, number one, convince the reader that decisions made very quickly can be every bit as good as decisions made cautiously and deliberately. To answer the question, when should we trust our instincts and when should we be wary of them? And to convince the reader that snap decisions and first impressions can be educated and controlled. And it deals with this idea of thin slicing, which is the ability of the unconscious to find patterns in situations and behavior based on very narrow slices of experience. And snap judgments are enormously quick and rely on the thinner slices of experience, but they are also unconscious. So we need to respect the fact that it is possible to know without knowing why we know and accept that we're better off that way, which is contrary to a lot of what we do in medicine. And it deals with the idea of priming, that what goes on behind that locked door of our unconsciousness. So what we think of as free will is largely an illusion, and much of the time we are simply operating on automatic pilot, and the way we think and act and how well we think and act on the spur of the moment, and especially under stress, are a lot more susceptible to outside influences than we realize. So there is this dark side of thin slicing and rapid cognition. What makes thin slicing possible is our ability to very quickly to get below the surface of a situation. But what happens if that rapid chain of thinking gets interrupted somehow? What if we reach a snap judgment without ever getting below the surface? So part of what it means to take thin slicing and first impressions seriously is accepting the fact that sometimes we can know more about someone or something in the blink of an eye than we can after months of study. But we also have to acknowledge and understand those circumstances when cognition can lead us astray. And one of those ways that cognition can lead us astray is through implicit or unconscious associations that play a role in our beliefs and behavior. We make connections much more quickly between pairs of ideas that are already related in our minds than we do between pairs of ideas that are unfamiliar to us. And this is shown through the implicit association test. Our attitudes towards things like race or gender operate on two levels when these implicit associations are tested. So we have conscious attitudes. This is what we choose to believe. These are stated values which we use to direct our behavior deliberately. But the implicit association test measures something completely different. It measures our second level of attitude on an unconscious level. We don't deliberately choose our unconscious attitudes. We may not even be aware of them. So that giant computer that is our unconscious silently crunches all the data it can from the experiences we've had, and it forms an opinion. So that's what's coming out in the implicit association test. The disturbing thing about the test is that it shows that our unconscious attitudes may be utterly incompatible with what we state as our conscious values. Now, when it comes to our first impressions, these are generated by our experiences and our environment, which means that we can change our first impressions. We can alter the way we thin slice by changing the experiences that comprise those impressions. So if we're going to take rapid cognition seriously by acknowledging the incredible power for good and ill that first impressions play in our lives, it requires that we take active steps to manage and control those impressions. So spontaneity isn't random. How good decisions are under the fast-moving, high-stress conditions of rapid cognition is a function of training and rules and rehearsal, something we see every day as physicians. So those applications we take for this decision-making process as doctors, it means that truly successful decision-making relies on a balance between deliberate and instinctive thinking. So deliberate thinking is a wonderful tool to have when we have the luxury of time, which we never do as doctors, the help of a computer, and a clearly defined task. And the fruits of that type of analysis can set the stage for rapid cognition. But in good decision-making, frugality matters. So taking a complex problem and reducing it to its simplest element shows that even the most complicated situation can have an identifiable underlying pattern. And overloading the decision maker with information makes picking up that signature harder, not easier. So to be a successful decision maker, we have to edit. We can't be buried by piles of information. Now, facial expression becomes very important in when we make these first impressions. So perhaps the most common and the most important forms of rapid cognition are the judgments we make and the impressions we form of other people. Every waking minute that we are in the presence of someone, we come up with a constant stream of predictions and inferences about what that person is thinking and feeling. So we can easily parse complex distinctions simply in facial expression. It's a lot harder to do that when we all have masks on all the time now. This practice of inferring the motivations and intentions of others is classic thin slicing. So we can carry that further into the arena of mind reading. So that the theory of mind reading is based on a taxonomy of facial expressions, based on action units, every distinct muscular movement that the face could make. And these are numbered. So distress could be 1 and joy could be 29. The face is an enormously rich source of information about emotion. And central to understanding how mind reading works is the information on our face is not just a signal of what is going on in our mind, but in a certain sense, it is what is going on inside our mind. This is a challenge when it comes to cases of autism. So the classic model for understanding what it means to lose the ability to mind read is the condition of autism. People with autism find it difficult, if not impossible, to do things that have been described as natural and automatic human processes. They have difficulty interpreting nonverbal clues such as gestures and facial expressions, or putting themselves inside someone else's head, or drawing understanding from anything other than the literal meaning of words. So their first impression apparatus is fundamentally disabled, and the way that people with autism see the world gives us a very good sense of what happens when our mind reading faculties fail. In anything less than a perfectly literal environment, the autistic person is lost. And on the most basic neurological level, for someone with autism, a face is just another object, like a light switch they use in the book. Now, those first impressions have come into play in a lot of recent events, including police shootings. So in interviews with police officers who have been involved with shootings, the same details appear again and again. They seem to have extreme visual clarity, tunnel vision, diminished sound, and the sense that time is slowing down. This is how the human body reacts to extreme stress. Our mind, faced with a life-threatening situation, drastically limits the range and amount of information that we have to deal with. So sound and memory and broader social understanding are sacrificed in favor of a heightened awareness of a perceived threat directly in front of us. But what happens when that stress response is taken to an extreme? Well, in the optimal state of arousal, the range in which stress improves performance is when our heart rate is between 115 and 145 beats per minute. Most of us under pressure get too aroused, and past a certain point, our bodies begin shutting down. So after 145 beats per minute, bad things begin to happen. Complex motor skills start to break down, the forebrain shuts down, and the microbrain reaches up and hijacks the forebrain. Vision becomes even more restricted and behavior becomes inappropriately aggressive. So arousal, in a sense, leaves us mind blind. In addition, no time can lead us to that mind blindness. When you remove time, you are subject to the lowest quality intuitive reaction. When we make a split-second decision, we are really vulnerable to be guided by our stereotypes and prejudices, even ones we may not necessarily endorse or believe. So our powers of thin slicing and snap judgments are extraordinary, but even the giant computer in our conscious needs a moment to do its work. This is where training and spirit and experience become invaluable. Our unconscious thinking is no different from our conscious thinking, and both we are able to develop our rapid decision-making with training and experience. It's the gift of training and experience, the ability to extract an enormous amount of meaningful information from the very thinnest slices of experience. We are often careless with our powers of rapid cognition. We don't know where our first impressions come from or precisely what they mean. So we don't always appreciate their fragility. Taking our powers of rapid cognition seriously means that we have to acknowledge the subtle influences that can alter or undermine or bias the products of our unconscious. And this is where that training and experience leads to judgment. So being able to act intelligently and instinctively in the moment is possible only after a long and rigorous course of education and experience. It's that kind of wisdom that someone acquires after a lifetime of learning and watching and doing. And from experience, we gain that powerful gift, the ability to act instinctively in the moment, but it isn't easy to disrupt this gift. So understanding the true nature of instinctive decision-making requires us to be forgiving of those people trapped in circumstances where good judgment is imperiled. We have come to confuse information with understanding. The key to good decision-making is not knowledge, it is understanding. When should we trust our instincts and when should we consciously think things through? Well, success is found when one understands how to combine rational analysis with instinctive judgment. And sometimes we can make better judgments with less information. So after we finish this book, what are we going to take away? Well, it is not enough simply to explore the hidden recesses of our unconscious. And once we know about how the mind works and about the strengths and weaknesses of human judgment, it is our responsibility to act. I want to thank you for the great honor of sharing this time with you today. Diversity is being invited to the party and inclusion is being asked to dance. So thank you, Dr. Ashwath, for the great honor of the invitation and including me to be part of this great dance. Thank you so much.
You, Dr. Larson, for sharing your thoughts on that very inspiring, enlightening book. We, as time constraints, are going to move on to our next speaker. It's Dr. Annabelle Volkman. She's the co-founder and medical director of the Rush Heart Center for Women, the first heart program in Chicago devoted exclusively to women that opened in 2003. She's the McMillan Ivell Endowed Chair for Excellence and Clinical Cardiology Professor of Medicine at Rush College of Medicine and a nationally recognized leader in cardiology care and research. She will be discussing Lean In, Women, Work, and the Will to Lead. Dr. Volkman, the mic is yours.
I think you're muted, Annabelle. Still muted.
Can you hear me?
Yes.
Okay. Thank you so much for that introduction. Let me just go back to my first slide. Well, it won't go. I can't move my slides for some reason. Can you guys hear me?
Yes.
Okay. Let me see if I can move my slides. Well, you're certainly getting a lot of time reading my disclosures.
I had success, Dr. Volkman, just tapping on the mouse, right-clicking on my mouse rather than the arrows to advance.
Okay. Okay. I will just right-click then. Okay, so I was asked to review the book. Hold on for a second. I'm sorry, I am not doing well here. Can you guys see my slides?
Yes.
Yes.
You might have to give the slideshow again.
Okay.
Yes, go ahead.
All right. Let me see if I can.
I'm
I'm still getting
an
an echo. Okay, can you hear me now?
Yes, we can hear you.
Okay, I'm still getting an echo, but if it's okay with you guys, I'll just continue.
I would just check to make sure nobody else is on, everybody else is on mute. And if sometimes you turn your volume down just a little bit on the computer, that echo goes away too.
I think you're muted, Annabelle.
Okay. Now can you hear me?
Yes, there's a re-sound, but we can hear you.
Okay. Okay, is that better? Can you guys hear me?
Yes, we can hear you.
Okay. So this is a book that was written by, all right, you know what? I'm just gonna turn off my phone.
Would you rather Tanya take over and do her talk? And
So
then
Lean In was a book that was written by Sheryl Sandberg in 2015. She is still the chief operating officer of Facebook, and she started a movement that emphasized the importance for women to work together to achieve their goals and to increase leadership. There was some controversial advice, so we'll talk about that. And let me just see, I forgot, I have to forward it this way now. So there are differences in men and women and how they succeed in the workplace. Women are usually seen as, in her book, she says that women are usually seen as aggressive and not a team player when they want to succeed. And this kind of behavior is actually seen in men as being successful, respected, and powerful. It's hard for women to take credit for their own accomplishments, and women are less likely to negotiate. Just wanted to point out that women and men also differ in what their perception of what their priorities are when it comes to a work-life balance. As you can see here, in the men, promotion is number one in their priorities, wages and power, and then family comes next. But in women, I guess they think that work condition is more important, and I can completely understand the family life. And then they think about promotion, but power is way down here. So women don't really work to gain power. I think they really like the idea of being able to work and being able to balance their family lives with their work. They also put a lot of priority to making sure that the job is meaningful to them. And wage, which is number 5 for women, is number 2 in men. So, and we'll talk about finances in just a few minutes. She also said, Sheryl Sandberg also said that it's a jungle gym, not a ladder. We need to concentrate on making a bigger impact by growing faster in a company or in a venture that we decide to take on. She also suggested that we should make a long-term dream. And I also completely agree with this. You need to have a dream in order to work for that dream to come true. And I think Dr. Riglin had also mentioned that you should have a 5-year plan. Sheryl Sandberg's timeline is a little shorter, 18-month plan, and you can make some changes in that. I think you can have both. You can have a 18-month plan and 1-year plan, but just make sure that you have these goals that you want to achieve so that you are focusing on that goal so that you can make some progress in your success in your career. And I think we know this already. Men tend to apply for jobs when they reach 60% of the qualifications, and women are much more careful. They feel like even if they have 100% of the qualifications, they don't feel qualified. It's that imposter syndrome that we need to get rid of, right, Susie? I think Susie's doing a much better job with her imposter syndrome, so I'm so happy for her. Sometimes advocating for oneself is necessary, and that's not always the case. So we need to help each other, advocate for each other. I just wanted to point this out in terms of finances, and I know we're going to talk about finances later, so I'm so glad that we are. But you can see the huge differences in the way women and men look at the finances. Most women don't have any idea of what their investments are allocated are. I asked so many of my female fellows and junior attendings, if they know what they're investing their 401k, and they have no idea. I think they just let Fidelity, which is what we use at Rush, to make a decision for themselves. I say, make sure you know what you're investing in. And a lot of those investments that if you allow other people to do it, are very, very conservative, and you may not meet your goal of retirement funds even after 30 years of working. So make sure you know what your money is going into. So you really need to, we all need to learn more about finances. She also talked about having mentors, and I liked her advice. She says that do not just ask if a person can be your mentor when you meet them. You need to make sure that that mentorship is reciprocal for both the mentor and mentee. And we've done some webinars on this mentorship and sponsorship, which I think I gave last year. I think you need both a mentor and a sponsor. This is some of her controversial comments, and I really think that it's great. I don't think it's controversial at all. What she says, this is a picture of Sheryl Sandberg and her first husband, Dave Goldberg, who unfortunately passed away while working out in a treadmill and due to a heart attack. So, you know, heart disease definitely affects life. Dark period for a long time. That was 5 years ago or more. What she says is that women need to lean in at work more and men need to lean in at home more. And I love that idea. I think that we should all follow that advice. And we need to work with our partners, our husbands or spouses or our life partner to make sure that we have equal say in how much work we do for the children, how much work we do for the home. I think that's really great advice. Partners need to seem like they're doing their part and not their partner a favor. So I think we're all guilty of this sometimes. Need to keep our relationship in balance, because if it's off balance, it's going to be even worse when there's children involved. So this is a picture of her now. She just got engaged to another wonderful man who is a CEO of a marketing company. So after 5 or 6 years of mourning, I think that she has been able to rise and be resilient. And now she is going to marry somebody who also has children. So it's going to be like the Brady Bunch. And I love the fact that she is able to move on and has made herself happy again. So I like this advice that both men and women need to work together to see if we are to see equal opportunities for everyone. We need to be cooperating and not competing with each other. And when you're with your spouses or with your colleagues, it's not good to go through the journey alone, but rather to go through the journey together. She also says that, you know, I'm not sure she really believes this herself, because I think that Sheryl is a perfectionist. She says that done is better than perfect. And I think a lot of us, since we're all type A, to go into cardiology, you have to be a little bit more of a type A than a type B person. Sometimes you can't get things done because it's not perfect. And we just have to feel uncomfortable sometimes and let other people help you. When you're writing a paper and you feel like you can't perfect it, you got to give yourself some deadlines so that you can get it done, because it is impossible to control all those variables. There's always another paper that's coming out, for that review. It's like, I need to add that paper in. So we need to take hold of making sure that we have limits so that we're not, going on that wheel like a little hamster and never finishing the work. And women try to fight the perception of being less dedicated to work by working too much. We really need to stop that behavior so that we don't drive ourselves crazy and burn out, and then we have to quit. And then the F word is the new F word, is being a feminist. Feminism is believing in social, political, economic equality of the sexes. This I totally believe in. I think that we can't be happy unless there's equality between the two genders. Be prepared to sacrifice, but not unnecessary sacrifice. I love this. Talking can transform minds. So talk to people about why you are a feminist, which can transform behaviors, because the person you're talking to can change their minds if you convince them, and you need to be committed to that. And these minds can transform institutions. As you can see, we went from not being able to vote to now having a female, ethnic female, as our vice president in the United States. So there is hope. Just to show you, I actually wrote a review of this back in 2015. And what I did say was that I didn't really think that this was a great example for us, because she was mostly speaking to the business world about what her book was. Obviously, she had many very valuable advice, but I thought that they were very anecdotal and geared for the business life, business world. But I did say that we should look up to our leaders, Athena and now Dipti, Dr. Wenger, Dr. Douglas, Dr. Walsh, and dear friend, Dr. Sandy Lewis, who just started the Sandy Lewis midlife career sponsorship, which is going to be amazing. So for that will, I think, change the lives of a lot of women in cardiology. Some of these women were at an ACC 2015 in San Diego. This was, I guess, and as I already mentioned, this was written in 2015, so it was very fresh in my mind. That one of the pearls that I learned from the luminaries, it was called Lessons from the Luminaries of Women in Cardiology, was that the leaders, such as Dr. Robinson, they needed to acquire skills beyond being a cardiologist. If you want to do a leadership role, you need to learn and understand the business of politics of healthcare and help the people we are leading to be successful. And now that's leaning in. Thank you very much.
Thank you so much, Dr. Wolfman. I did get a question sent to me through the chat from Dr.
Okay.
And her question was, when she was reading the book.
Jennifer, I think you're muted.
Jennifer, I think you're very soft. Can you try speaking up maybe?
Is that better?
Yes.
Okay. So the question from Dr. Khan was, when she was reading the book, it suggested women should not aggressively approach people to seek mentorship. And while mentorship is important, it should be spontaneous. What is your opinion on that?
Annabelle, you're muted, I think.
I'm sorry, Jennifer, can you please repeat that question? I couldn't hear you.
Ask the question, Jen. Was it Rabia?
Mahi, were you able to hear the question?
It was very soft. So Aruchi, did you ask the question?
Yes. So when Dr. Wolfman, when I was reading the book, one of the chapters was on mentorship. And it suggested that women are very aggressive in seeking out mentors, and very often they approach the wrong people because they end up approaching strangers. And mentorship is important, but it should be more spontaneous. And that kind of had me a little confused as to how aggressive one should be about seeking mentorship. I was wondering what your opinion is about that.
That's a great question. I think that you need to be mindful about who you're asking to be your mentor, because like she said, and like we always say, it's a two-way street. You can't just keep asking that mentor to do things for you. They have to be able to gain something from it too. I gain a lot of satisfaction from mentoring young women, but they have to do most of the work. If they want me to help them with their careers, they need to be forthcoming with their CV, making sure that I know what they want to do. You can't just go to somebody and say, mentor me, please. You have to have specific questions and specific asks. And I think we've said already, you can have different mentors because not one mentor can do all the things that you need to be successful. So be careful in who you ask and be mindful in how you ask. A lot of people ask me to be their mentees, but then they don't really follow up. So I think if you do that too many times, that you may not get good mentorship. I hope that helped you.
It did. Thank you very much.
That was a great book and a great review, Annabelle. Thank you very much.
Thank you, Mahi.
All right. Are people able to hear me better now?
Yes, that's better. Go ahead, Jen.
All right, great. So our next speaker is Dr. Tanya Singh. She is an invasive cardiologist and managing partner of St. Louis Heart and Vascular. And among her many accomplishments, she is the chair of the National Women in Cardiology Council, the founder of Women in Cardiology regional meetings, a member of the National ACC Task Force for Diversity, Equity, and Inclusion. And I found out she has her own TED Talk about gender stereotypes. It's very entertaining and provocative. And she'll be discussing crucial conversations, tools for talking when stakes are high. Dr. Singh, the mic is yours.
Thank you so much. I hope you can hear me fine. Is that good? Okay, excellent. So, all the books we've heard about so far kind of lead us to conversations. We have to have conversations with people. We have to have conversations with people in our lives, at work, with our patients. And so, I think this is an excellent book that if you have not read, I would put it on your reading list to read at some point. And we always want to define what we are talking about. So what is a crucial conversation? A crucial conversation is a conversation where people have opposing opinions, strong emotions, and high stakes. And unfortunately, that seems to be a lot of conversations we are having every day in our lives now, whether it is talking about vaccination with our patients, whether it's talking to our colleagues about how the business of cardiology is being conducted, or whether we are talking at home about how we are managing our lives in terms of work-life balance and sharing work with our partners. So I think this is an important discussion to have, is how do we proceed through these crucial conversations? First of all, how do you recognize a crucial conversation? So a crucial conversation is a conversation we have often. We have it over and over. It's difficult. We try to avoid it. And we have feelings of fear and anxiety and judgment, and just it's an icky feeling. And we don't really like how we feel when we have this conversation. So when you start feeling uncomfortable about a conversation, that's a good thought to have, that this might be an important conversation and you have to pay more attention to it. So what are the core principles of having a crucial conversation? And I'll go through all of these principles separately. And the book does a great job of giving lots of examples. Since we have just 10 minutes and the book is 300 pages long, we'll just go over the broad ideas, but I would encourage you to read the examples of these. So the first thing is to start with heart. Learn to look and see how people in that conversation are responding. Make the conversation safe so that people are willing to talk. Master your own emotions and your own story, and see what you're bringing to this conversation. And state your path. But before you can do that, you need to know yourself what your path is. But then also encourage others when they get emotional to kind of get back to the conversation and get back to the facts, so that then once all of that is done, we can actually move towards some sort of action. So what do you mean by start with heart? Starting with heart is really being honest with yourself. What do you want for yourself? What is this conversation going to achieve for me? And what do I want for others? And what will this do for your relationship, whether it's a relationship at home or a relationship at work or a relationship with your patient. So really having some clarity on the purpose of the conversation, what you're looking for to achieve, and then try not to fall for what the book calls the sucker's choice, that there's either one, there's only two options. It's either this or that. There are many options, but just making sure that you are coming to the conversation with an open mind and not just with the either or option. Like you either listen to me or you're out of here, option, which is the sucker's choice for the book. And then learn to look and learn to see when you're losing someone. So when you're in a conversation with people, and people tend, when they get defensive, they tend to go to two extremes of behavior. One is silence, and where they just don't speak at all, or they may start masking with sarcasm, they sugarcoat statements, they avoid the discussion, they change the subject, they make the discussion about something other than themselves, or they kind of just disengage and put themselves on mute and don't contribute to the conversation for the rest of the period. Or they may go to violence, where they feel threatened and they start labeling and attacking and belittling people in that conversation. So when that starts happening, you're losing that person. You are not any longer at a point where you're going to try to be able to achieve something. Sometimes you're trying so hard to get your own point across that you don't realize that the other person is checked out. So when you start seeing behavior like this in the people involved in the conversation, it's time to step back and get to a point where you can re-engage people in conversation. And you have to make it safe. And how do you make a conversation safe? You make it safe by recognizing that the conversation has gone off the rails. And you do that by apologizing, by stopping and saying, but being sincere in your apology, by saying that, we have lost the focus of our discussion. I am sorry that we are all being so emotional. Can we, I want to acknowledge any harm that I have caused to you by this conversation. That was not my purpose. And so, be sincere. Of course, only if you feel sincere, but try to be as sincere, because obviously if you're having a crucial conversation, this is a conversation that is important to you and the other person. And contrast to repair any misunderstanding, saying, like, it was never my intention to cause you harm, or to say that your work was not great, or that you haven't done a lot for an organization. Instead, we were discussing X topic. So, to take it back away from just a broad, like, you never agree with anything I say, or you always complain about me, to like a specific topic. Then use the CRIB tool. The CRIB tool is a acronym for commit to find mutual purpose. So what is our shared goal? Recognize the purpose behind the strategy. Why are we working towards the shared goal? For example, if you're trying to get a patient to get a vaccine, our shared goal is for the patient to be healthy, and the patient's goal is of course to be healthy too. So that is what we are working towards. So that is our mutual purpose. And then we can talk about how we can get towards that shared goal, rather than saying, you should get the vaccine. The patient says, I'm not going to get the vaccine. And then both of you are at loggerheads and say, okay, I'm never going to see you again as a patient. You can sleep. I mean, so that just kind of defeats the entire purpose of that crucial conversation, which would have gone very differently if we didn't let our emotions take control of that. And if we didn't go to the either or strategy, which I like that word, the sucker's choice. So the first thing is, master your own story. You have to kind of master your story in your head. When you bring up a crucial conversation, are you bringing it up as you're making the other person a villain? Are you making yourself a victim? Are you making yourself feel somebody who's helpless in what happens in this? So kind of understanding what your own issues are prior to creating that story in the head, because we can create any story about any circumstance. So like working through your own story is extremely important. And really trying to take away our emotions when we have a crucial discussion, because anytime we become emotional about a discussion or about a story, we kind of lose control, because our brain really goes to that fight or flight response. And so therefore, thinking about your story in advance, practicing your story. I know some of our speakers spoke earlier about having an important conversation, have it with a mirror, have it with a friend, have it with someone you trust, who you're not going to get emotional with if they give you a response that is not what you want to hear. So going through all of those exercises in advance of a prepared, crucial conversation where you're going in to ask for something or promotion or negotiation, practicing that in advance really helps kind of calm down that fight and flight response and helps you kind of prepare better for that discussion. And even ask that person that you're talking to, who's your trusted individual, to ask you the difficult questions and ask you why, so that you can get those emotions out of your system before you actually go into the major conversation that you're going to have. It's really important to approach and share your views effectively. So you want to share your views with confidence. So be confident that your ideas are worth contributing. And so, and they're really contributing the shared pool of meaning that you're working on. Be humble enough to realize that other people have great ideas too, and they may have a valid point, and be open to listening to that. And then practice the skill. Practice the skill of being willing to listen, not just hear, but listen and internalize. Many people say we only hear to respond. We really need to hear to listen and understand. And effective communication. What are the what's in the house? So there's like a little graphic that you can use. So whenever you're having a conversation, the what part of the conversation is the what skills. The what skills are share your facts, start with what has been said and done, tell your story, talk about your conclusion, consider adding some contrasting, and ask for others' paths, say, encourage others to express their facts and stories. So everybody gets a chance to actually contribute to the conversation rather than one person just leading the conversation single-handedly. And the how skills are talk tentatively and say, perhaps you were unaware, or in my opinion, or I'm beginning to wonder if, or sometimes you could just play the devil's advocate and say, does anybody think differently than I do? Or what if we did the exact opposite? What would you think? So giving people a chance to what they call stay in dialogue. And then explore other people's path by inviting them to share their paths to action. So listen to them, tell a story, feel what they have to say, and then act. So don't just see and hear and act. Don't skip the other important factors of interpretation, emotion, analysis before we act. There is so you can do this by asking to get things rolling. You should mirror people's, if they're comfortable. I find this sometimes hard to do, is like, it feels like you're copying somebody's expressions. But again, it's not meant to be like copying somebody's expressions, but just to, if they feel upset, to understand that they're feeling upset and ask them about it. And paraphrase to acknowledge the story, so that shows them that you were actually listening. And then ask them questions, by meaning that prime when you get nowhere is asking questions when you feel like you're in a stuck conversation. So agree when you can, build on what you can agree on, and then compare and contrast to move forward. And move to action. So the move to action is decide how you are going to finally move forward with this discussion and what your path is going to be, and then document those decisions and follow up. So the key points are, the ability to have difficult conversations is the key to building a healthy environment and healthy relationships. If we all have friends that will not be able to have a difficult conversation with because they get upset or angry or accusatory. So in order to have a healthy relationship, it is really important to learn these skills. You need to keep people talking, because as long as they're talking, they can move forward. Check yourself before leaping to conclusions without enough information, and then work on adding to the shared pool of meaning. So this is just a big path, like just a broad guideline. So again, I think for me, the biggest takeaway from this book was work on me first, because everything that we do from there on is better if we have already worked on our own thoughts and emotions first, and have been through the ability to practice our thoughts and emotions a little bit better before we plunge into these conversations. Obviously, there are some times when we have crucial conversations without any preparation. And so just remembering this, and as Dr. Larson said in her book, Blink, judgment is really impacted by experience, and experience is impacted by education. So again, going back to working on yourself first, getting yourself unstuck, starting with heart, with having real analysis of what your plan is, and mastering your own story and the emotions that go with that story. And then you state your path, and then make it safe so that other people want to stay in dialogue with you, and then move to action. And when you see people going to either silence or violence, try to bring them back by acknowledging the fact that they may be upset. So in the end, as is one of my favorite sayings now, it says, I was clever, so I wanted to change the world, and today I'm wise, so I'm changing myself. So thank you for your attention, and please read the book.
Great, thank you so much for that important lesson in emotional intelligence. That was really great. We do have time for a question or two.
Sure.
Great review, Tanya. Thank you very much for going over this. I think it's just not even just related to work, right? Just to life in general and for everything. There's just so many lessons that you have conveyed in the talk. So thank you very much. And I really like the summary that you put up about if there is silence, then that's a concern. Or if there's violence, there's a concern. So I think probably a lot of times we ourselves kind of end up in one of those zones. And I think it was helpful to realize that, so we kind of remind ourselves, be mindful about our own reactions and emotions and pull ourselves back. So thank you for doing that.
Is there a time after you read this book that you found yourself using these techniques?
Yeah, I would say, just sharing, my husband and I have a fight about just one thing in our lives, and we've been married forever. And one thing that always gets me upset is his timeline, his analysis of like real time and his time is usually off by an hour. And it has really not changed in all these years. And for years, I would get so upset. He'd be like, okay, I'll be home at 7. And, we had all these strategies when my kids were young. Well, tell dad the thing starts at 6. So then it actually starts at 7. And then I would get so angry. And for so many years, I was just so angry. And then finally I had to sit down and say, why am I so angry? I mean, this is his responsibility. Why am I making this my responsibility and getting angry and getting upset with him every time? So we had a really good conversation. I said, you know what? I'm not going to even ask what time you're coming or going. I'm just going to tell you what we are doing and what time it's going to happen. And I'm just going to go on my own. I'm not going to be sitting around waiting for you to be home to do this, but I will. And it was really shocking because from that time on, he actually did much better about being wherever. I mean, even if it was late, it was like, again, these are his children, my children. I'm here and he'll be here whenever he can get here. And I cannot be responsible for him. And he felt like really attacked every time I did that. And he felt like I was attacking in front of the children. It was not good. And, it was good to listen to his aspect of it. For years, I had not, because years it was all about my thoughts, my ideas, what I think was right. So I think that this really actually helps smooth out that one real challenging part of our relationship, which affected our daily lives. So I think, when you find something that's really a squeaky wheel that really irritates you about somebody, you really need to stop and it has made things so much better. So I think you really need to stop and see, why is that such an irritant? Why is that such a trigger? And what can you do about having an honest conversation with the other person to see so that it stops being troublesome for both of you?
That's great. The funny thing is, after reading this book, I also had a very good conversation with my husband about it. It worked for us too. So thank you for that. And next, it's my pleasure to introduce our next speaker, Dr. Isabella Grumbach. She's a professor of internal medicine, cardiovascular medicine at the University of Iowa. She's the vice chair for research in the Department of Internal Medicine and a very successful physician scientist who's been an outstanding model for many years here at the University of Iowa. And she will be discussing winning at the game of business. Dr. Grumbach.
Yes, so I may be a successful physician scientist, but I just realized that I have a new laptop and I cannot share my screen because I haven't set my preferences yet. So I truly apologize for this. And while I'm trying to bring up my slides on a different laptop, maybe I should just go ahead. And since we have 7 minutes left, I will tell you about this book without being able to share those slides. But I don't think this is going to be actually this is really absolutely necessary to understand the basic premise of this book. So I would like to speak about another classic in the literature on women and careers, and this is called Hardball for Women, Winning at the Game of Business. I read this book a few years ago. It's been on the market for 25 years, so it truly is a classic. It's now in its third edition. So I was initially kind of put off by this title. I didn't really know what it meant. But here's just a story I would like to share with you. A few months ago, I had dinner with two amazing women from Iowa, one a PhD scientist who was recently asked to apply for deanships, and a clinician who is the deputy chief of a clinical service who is thinking about applying for a leadership position. And the course of a discussion was about like this. Well, so one was saying to the other, yes, I would be interested in applying, but I also realized that if I take the leadership position one up, I will have to be more aggressive and behave more like the male people in the leadership roles. And I'm not really sure I want to do this. So the basic premise of Hardball for Women is that women still are in a double bind. They cannot be too stereotypically feminine because they'll be judged as too weak. And they cannot be too stereotypically male in their pathway because they will not be well received either. So women are in this double bind. And while women are overall well represented in the workforce, maybe not in cardiology, but certainly in other areas of academic medicine and hospital leadership, there still is a great dearth of women in top executive positions. So the basic idea behind Hardball for Women is that men and women are nurtured differently. They learn vastly different ways of living and working, and this starts early on. And the male way is by far more likely to getting you into an executive position at this time, simply because there are so many more women around in the C-suite. So when you begin a career, and you're an assistant professor, you will get hired based on your technical skills, your ability to manage an LVET or read a TE. But the higher up you get in your career, the more important it is that you understand that you will advance based on your interpersonal skills. And here, the nuances between male and female behavior in leadership positions becomes more relevant. So the proposed solution of the book is to understand the predominant male culture at the workplace so that you can use it to your advantage and use the male style slightly adapted to your needs when needed, but revert to your natural style when you're leading groups of women or when you're not in full competition mode. The book really starts out with describing how boys and girls play. And you may or may not agree completely with how the authors present their findings, but there certainly is some truth in how they present the problem. So they start out by stating that boys play to reach a goal. They play in teams, one against the other, and by doing so, boys learn to engage in conflicts head-on. And when the game is over, well, then it's over. So teams are fluid and they can change. And therefore, men will also learn to develop functional relationships in service to their goal. One day they may be the team captain, the other time they may have a different position. So overall, men prioritize winning and competing in order to reach a goal. On the other hand, girls often play to strengthen their relationships. Conflicts are not very common and they're often regarded as dangerous to the relationships. And therefore, women learn to avoid conflict and they also take conflict more personally. So overall, In female groups, popularity and intimacy are signs of status and power. In male groups, success, victory, and achievements are signs of status and power. So overall, this encourages men to be more aggressive and be more go-getters, which tends to prepare them better for competition in the world of business or in academic medicine or hospital leadership. So when it comes to managing direct reports, women tend to lead by building relationships and connections, whereas men are more likely to lead and relate for aggressiveness and competition. But truly, the leadership styles need to be adapted to the expectation of the reports. So when women are leading groups of women, the capacity to care and relate would be an advantage. However, when women have to lead groups of men, they may have to adapt their style to exhibit their strength, to really cater to the expectation that the boss is the team leader. And so this also relates to managing up. So when you are managing or your relationship for your boss, it's important to understand that while women look at structures within an organization as something which is flat and fluid, men are more likely to actually see a strong hierarchy with a boss on top. And one mistake that women may be more likely to make is to, for example, discuss a boss's order, wanting to understand why or potentially tell him why a particular task doesn't make any sense. So to a woman, this is about reaching a best decision in a flat hierarchy, whereas to the male leader, it may look like insubordination or challenge to his authority. So one of the recommendations that we authors give is to shy away from actually saying a clear no to your boss. Also, when it comes to dealing with conflict, since women prioritize relationship, they may prefer to avoid losers and make everyone a winner. They may have somewhat different styles of managing a conflict. For example, apply avoidance, accommodation, or look for a compromise. Whereas a man may be more likely to try direct competition to settle a dispute. And while neither strategy is necessarily right or wrong, sometimes it may just be better to go for a direct confrontation, even if that's uncomfortable. So the most common stumbling blocks that women may encounter is that they get lost in the detail, and they often also take responsibilities for tasks that nobody else wants to do. And they also tend to be too available at the detriment of their own tasks. The advice from Hardcore for women is that men prefer a leader who has power, so therefore display yours when you have to. A meeting doesn't happen in the meeting, it often gets arranged for or decided on before the meeting. So get your ducks in a row before the meeting. When you're interrupted in a meeting, just keep talking. And if you don't know the answer, give it your best shot and take criticism for what it's worth and just move on. And also tend to say, I'm sorry less commonly. Only take responsibility for what really went wrong because you did it. And choose a good boss over a good job. And when another woman wins accolades, do support her. So this is a really eye-opening, true classic book worth the $15. If you want to understand general power dynamics in a workplace, you will learn hugely. And the book is very open and clear at acknowledging the double standard for women in high leadership positions. And with this, I apologize for not having my slides up, but the time is up anyway. And I thank you very much for your attention.
That was awesome, Isabella. I think there's one question from Rabia, who said, these are very interesting points. I would hope that this will improve over time with more successful women in the workplace, but I do worry that the stereotypes still persist and influence behaviors in children. Were there any comments on how we can help our daughters overcome these challenges and stereotypes?
Yes, there was some references to this in the book, yeah. And I think this is an excellent point. I think that some of the issues will eventually take care of themselves as more and more women move up into leadership positions.
Awesome. Thank you very much, Isabella. Even without slides, that was an amazing presentation. So thank you very much for the review. Thank you, Annabelle, Tanya, Sharon, everybody. That was, great review of amazing. Thank you for the moderating. Going to move on to the next session of family and finances. And this is going to be moderated by Rabia Khan. Rabia Khan is actually a pediatric cardiologist at the University of Iowa. And Rachel Saxena, she is the incoming governor of Minnesota ACC. Rabia, you want to unmute yourself? I think you're muted. Yes.
Yeah, absolutely. I'm so happy to be here to moderate this important session. And I feel that some of these books that we just discussed actually are a good lead-in for this session as well. So without further ado, I will introduce our first speaker. So that is Dr. Elisa Bradley. She is an associate professor of medicine, director of the Adult Congenital Heart Disease Program, and director of translational research at Penn State Health Vascular Institute. And her topic that she'll be speaking on is financial planning.
Thank you for the introduction. You have my slides, right? Okay, hopefully everyone can see this. So again, thank you to the committee for inviting me to present. This is an area that's very near and dear to my heart. And I think as women, we don't talk about this enough, but it's really important, particularly for our wellness, which I'll discuss a little bit here. So I titled this Financial Planning, Why and Where to Start. I do have some disclosures related to some private financial consulting I do at this address. So I started with why, and I think that in the last year and a half, we don't even really need to look very far to understand why finance is important to us as women physicians. We learned this past year that our jobs may not be as stable as we once thought. And I think not only that, but we may have realized that, we're not happy with the way that our job looks or our career looks. And, do we have the freedom to change that? And finance, whether you understand that or not, does actually have a fairly big role in making some of those decisions. So I reflect on this, which is a quote by my favorite financial writer, J.L. Collins, and he says, "Freedom to me is the single most valuable thing money can buy." And it really is around that concept of freedom. Being financially well allows you to make choices about career and the life that you want, which for many people is often one of the few controllable things for their own personal wellness. So in a limited amount of time, I had to think about what would I tell you, because I think there's a lot of things we could go over, but I sort of selected what I felt were the top 3 things that you need to know to begin your financial journey. And if you manage all of your own finances, this will be very basic for you. But if you're somebody who maybe has hired someone else to do that for you, but you want to understand a little bit more, it will give you a little bit of the some baseline information to begin that process. So the first thing that we'll go over is how to understand how much you would need to retire, which is really the basis for all of financial planning, knowing what that goal is. Number 2 is this concept of compound interest, or understand how you build what I'll call a money-making machine, which is what a lot of people refer to this as. And then number 3, how to identify what accounts are available to you. So sort of the first steps to put some of this into action as you start to look at savings goals. So the first one, how much do you need to retire? There's a couple of definitions here to start with. You'll hear a term called financial independence, and really what that refers to is the idea that you have enough income coming in to pay for your living expenses for the rest of your life without having to work or be employed. So it's where your assets generate enough income to cover all of your expenses. And from that comes something called the 4% rule. And this was based off of studies over several decades that culminated in a publication in the late 1990s, where they looked at withdrawal rates and they looked at the market over time and found that you could withdraw 4% from your portfolio every year and sustain yourself for at least 30 years through retirement. And so the backwards math of that is that you really need 25 times your annual expenses to sort of be the number that's safe for you to retire with, at least by the data from this study. Subsequent studies have shown very similar numbers to this. So you still may ask, how much do I need? And the reality is it depends. It depends on how much you spend each year. And so just for some examples, if you plan in retirement to spend $120,000 a year, then 25x is 3 million. $200,000 a year is 5 million, and 300,000 is 7.5 million. But remember, it's at a point in time when perhaps kids are through college and you don't have a house payment anymore. And so a lot of the financial strain that you have earlier in life, you may not necessarily have at the time that you're considering retiring. I do remind people, don't forget taxes, because many of these are held in pre-tax accounts. And so you have to pay taxes when they're distributed. So for someone, for instance, that wants to live on $200,000 a year, who's planning on only needing 5 million, because you'll fall in the 24% tax bracket. And of course, that's in 2021 numbers, that's an extra 36,000 a year. And you really need closer to 5.9 million. So it's just something to not forget about as you're calculating some of these numbers. So moving on to number 2 and talking about compound interest. And again, going back to some definitions, you'll hear both of these terms interchangeably, the compound annual growth rate and compound interest. For all practical purposes, when you're talking about your retirement accounts and your portfolio, they're basically the same thing. And really what this is referring to is the idea that you put in a principal sum of money and you invest that. And of course, you generate interest off of it. But at each point that the interest spins off of it, you will begin in subsequent years to earn interest on the interest. So this is that idea of making some type of a machine that continues to add interest, and then you're generating more income from it. Now, from that comes something called the rule of 72. This is the number of years that's required to double the invested money at any given annual rate of return. So if you look at it as an equation, it is years required to double investment is 72 divided by whatever the annual interest rate is. So we can look at an example and say, if the average market returns 8%, how long does it take for your original investment to double? And so 72 divided by 8 would be 9 years. And so if you look at pretty standard market returns, here I show you between 7 and 10%, the amount of years that it takes to double your investment is somewhere between 7 to 10 years. So you can take that and then you can plug it into any of these online calculators, these compound interest calculators, to figure out what's going to happen to your investment. And what you're going to notice is that the more time that your money has in the market, the better this interest machine works for you. So in this example, I took someone who was a physician that started at a salary of $300,000, and I said, this person's going to contribute 20% to retirement accounts. I said they started with having $100,000 that they had invested, and then on a monthly basis put in $5,000, and we looked at 10 years at a market at a percent return of 8% per year. So in blue, you see the original $100,000 over the 10 years. In the orangish yellow color, you see all of the deposits over the 10 years. And then in green, you see the interest that was generated. So in 10 years, this person has $1.1 million, but really only paid in $600,000. A little over $400,000 was acquired in interest. This is another example. If you come out and you have a salary that's $500,000 and you contribute 30% per year, same numbers on the left-hand side, with the exception that the deposit monthly is now $12,500, but still looking at 10 years at a rate of return of 8%. What you see after 10 years is that the final balance is $2.5 million, and about $1 million of that was generated in interest. Now, the cool thing is, if you look 5 years beyond that, if you look 15 years, which is the bottom panel, what you'll see is that now there's close to 5 million there, and about 2.5 million was generated in interest. So again, the longer the amount of time that this money stays put, the higher percentage that interest makes up of the entire portfolio, which is why it's important to have some time there. So number 3 is to just really quickly look at retirement accounts that are available, because everyone kind of gets excited about the first 2 and they say, okay, well, how do I start and how do I get, kind of going on this? And it can be a little bit confusing. And I like this picture. This is a truck and it's got some coins in it. And I like to think of it as your retirement vehicles are all those accounts that you think of at work, like the 401k, or you've heard of IRAs or Roths. And then the assets, the mutual funds, stocks, bonds, are the coins that go into that vehicle. And I like to split these up into 3 kind of broad categories. The first is government sponsored. So these are either traditional IRA or Roth IRA, and there's some permutations, but those are the big 2. There's the employer sponsored accounts, which are like your 401k or a 403b or 457b. And then there's your standard investment account where you take post-tax dollars and you just buy stocks and bonds and mutual funds in the market. So by the current IRS designations, you can right now put in $6,000 per year per person, meaning like a spouse, like a couple, into an IRA. So either traditional or Roth. Most cardiologists will get no tax benefit from this, and most of you would have to put the $6,000 into a traditional IRA, and then you may convert it by the back door to a Roth, but that's your yearly limit. And then for the employer-sponsored plans, for most of these plans, as an employee, you can put $19,500 a year into the account, and then the employer can choose to match a percentage or a specific amount up to a total cap of $58,000 per year. 58.5, I actually think I have that wrong, 58,500. Remember, these are pre-tax, so you will still pay taxes on them at distribution. And usually only one of these plans is offered, with the exception of the 457B. So some hospitals you'll be allowed to have like a 401k and a 457B, and they do not coordinate through IRS rules. So you can actually contribute the $19,500 to both of those. And then of course your standard brokerage account has no limit because it's post-tax dollars that you invest there. So I'll finish with an example that I took Anna Academic, who's on the left, and Penny Private Practice, who's on the right. And you can see their salaries are $300,000 and $500,000. Both of these women can put into a traditional IRA $6,000 a year. The academic side, Anna has a 403B, which she can put $19,500 in. And let's just say her employer gives her 6%, that's $18,000. Penny Private Practice can also put in the $19,500, but 6% of her higher salary is $30,000. The difference here being that on the academic side, Anna has access to a 457B, so she can put in another $19,500. So you can see their overall contributions are fairly similar, 63 overall versus 55,000. But I will give you another example simply because I think with academics especially, you can have all kinds of permutations, and certainly you can with private practice too, especially when it comes to profit sharing. But with these retirement counts specifically in academics, they can get really tricky. Here's another scenario. There's 13 states where if your institution is state funded, you don't have to pay Social Security. And so they can do a 401A. So all of the numbers here are the same, except now Anna can put into a 401A. And the employer actually raises the percent that they contribute because they don't have to do Social Security. So she gets a little bit of a bigger bump through her employer. And this account does not coordinate with a 403B, so she can put another $19,500 in that, and she still has a 457B that she can put $19,500 in. And I show this example because sometimes you'll hear of some academic positions where you can put away somewhere around $100,000 a year that you can shelter from taxes and save toward retirement. And this would be the kind of scenario where that would happen. And so the important thing just to know is that one is not better than the other, but if you were penny private in this case, you want to just make sure that if you wanted to contribute a similar amount, you'd have to do it in post-tax brokerage accounts. So this would just be an example of Anna Academic on top and Penny Private on the bottom, looking over 10 years at 8% return just with what they put into their employer account. So for the academic position, Anna ends up with 1.6 million, and about 600 of that came from interest. And on the bottom, Penny Private Practice ends up with about $1 million, and about 400,000 came from interest. So she just needs to really make sure she's contributing to post-tax accounts. Remember, though, I gave you this example earlier, which was just that time in the market is the most important thing. So putting in a good percentage of money and then letting it sit. This was that example from someone who had a salary of 500,000 and invested 30%. But that's really the best way to get yourself to those numbers you need for retirement. So just to review, so we looked at how to understand how much you need for retirement. We talked about the 4% rule and how your number is based on how much you're going to spend. Then we looked at how this concept of compound interest and you understand the rule of 72, which tells you how long it takes for your money to double. And then finally, we sort of ended with looking at the different retirement options that you have in terms of accounts to put money into. And I'm just going to end with this quote again, because I love it. Remember, it's important to think about these things. You also have to take care of yourself and your family. You're often starting late, and thinking about your finances is really going to buy you freedom that you need to make decisions for your career and for your own wellness.
Thank you very much, Alyssa. That was an awesome presentation. For the sake of the fellows and stuff, I just wanted to add one more thing. And the summary of the retirements, I don't think I could match it. I think that was awesome. The only other thing is, I think it's a good idea to get a book like I started with an investment book for dummies, like a 101 kind of a basic book, which tells you about just opening up an account and Fidelity and kind of start playing with a small amount of money, investing it yourself. I mean, you can put it in index funds. To track the market or something. There is no fees anymore by a lot of these companies like Fidelity for transaction, even a small amount. So that's probably something I would encourage the fellows to kind of look at. Yes, Jen is asking, do you recommend index funds? Yes, Jen, I would be happy to have a conversation with you about it. But if you look at most investors, they will tell you it's very hard to beat the market. So unless you buy, $1 million of Tesla and become a billionaire, it's not going to happen. So for the most part, index funds, like just something which tracks the Dow or whatever, those are really good funds. And again, happy to have a conversation. But, it's a good idea for the younger generation here to, get like a dummies book for investment and take a look at it. And like, Annabelle and Tanya pointed out in their books, women are kind of a little behind in financial education and stuff like that. So you really want to put that step in the right direction to kind of educate yourself. So sorry, Lisa, just wanted to add that in.
Thank you. Absolutely. You're right on.
There were a couple more questions that were sent to me. So from Dr. Aruj Khan, she was asking for a fellow in training, what is the most cost-effective way to pay financial planners? And then I think this might be related, fixed monthly salary or percentage or profits?
Most people would tell you to use a fee-only planner. However, as a fellow, I think it behooves you to learn just a very little bit, because they're going to give you such little information as a fellow. And it's really just one of two ways. If you are not going to go after PSLF, it probably makes sense to put whatever money you can into a Roth IRA. If you are going to be doing some form of PSLF or some income-based repayment, then perhaps if your company has like a 403B or 401k, you'll get the tax benefit of that and your payments will be lower toward loans. That's the basics of it. Someone pointed out White Coat Investor is a good place to start. I also like J.L. Collins' book, The Simple Path to Wealth, as a good starting point, but I probably would not hire someone in fellowship. I think you could figure that small thing out without a planner.
All right. I have one more quick thing about saving for education for children. I feel like that's something that so far we haven't prioritized so much as an early career physician. There's so many other things to think about, but do you have any thoughts on kind of when to start thinking about that and how to go about that?
You can borrow for college. You cannot borrow for retirement. It is one of the last things to be funded, even if it's late. And some people will just cash flow it when it becomes time for college. You're already starting late for your own retirement. So getting that time in the market is very important.
All right. Thank you very much. All right. So for our next topic, I am pleased to introduce once again Dr. Tonya Singh. I know that Dr. Streeter already gave a pretty detailed introduction, so I'll just remind you of a couple of things. She's the managing partner at St. Louis Heart and Vascular and the chair of the National Women in Cardiology Council in the American College of Cardiology, and she will be discussing contract negotiation.
All right, so thank you, and I'm sorry to be speaking again, but this is a topic that's really close to my heart. There is an urban myth, and I think most of us actually believe that contracts can't be read because they are just too complicated. And just like this cartoon says, we feel like they are written so that nobody can understand them. And in full disclosure, I signed my initial contract with my practice 18 years ago without actually reading it myself and just handing it over to a lawyer. And I also signed my partnership contract 3 years after I joined the practice. So that was 15 years ago without reading it and giving it to the lawyer, barely understanding any aspects of it and believing in goodwill. And so since then, when I became a managing partner at my practice about 5 years ago, I have read about over 100 contracts of all kinds, including employment contracts, business contracts. And what I've realized is most contracts are actually written in a very similar manner, and they are not that hard to understand. You're all very, very smart people, so you can totally understand a contract. So I'm going to start out with the anatomy of a contract, and then we'll discuss about how to get past to discussing it. So in order to discuss anything, first you must understand it. So usually all contracts, they have a few funny words in them, but once you see those words, you will understand them. I would encourage everyone who has a contract at home to open it up, take a yellow marker, and kind of just try to read through it. So the first topic in there every time is the terms of employment. It says X person is employing you to do X job, and these are your responsibilities, and these are your performance expectations, and these are the requirements. And then it goes into a next paragraph of what your benefits and premiums will be, which was all the discuss that Dr. Bradley, things that Dr. Bradley just brought up, all those 401ks and retirement plans, etc. And then it talks about whether you can be missing or not, how much vacation you can take, what if you don't get along with your employer, what is your choices in getting over a dispute, whether you have to go to an ombudsman or whether you have to go to find a lawyer. There is a non-disclosure agreement in most contracts, which basically states that you can't tell anybody about their business secrets. And then in some states, there is a non-compete clause. And here a lawyer is useful because the non-compete clauses are different in every state. So I know from talking to Dr. Tarenkla, she said that Nebraska doesn't have a non-compete clause. Missouri, where I practice, has a very, very minimal non-compete clause. But many other states actually have non-compete clauses that are very strong. So understanding that is important, but it'll tell you if you have a non-compete clause or not. It talks about ownership agreements when you become a partner, about what percentage ownership you have in a practice. It talks about employment opportunity, and what that means is it tells you whether you can moonlight at other places or not. It talks about termination clauses. Almost every contract in medicine has a 90-day no-cause termination. So just because you've been there somewhere, anywhere for 20 or 30 years doesn't mean they can't terminate you for no cause. They just have to give you a 90-day notice. So be aware of that when you're looking at your contract. It also talks about severance terms. So it says that when we do actually give you a reason to leave or ask you to leave, these are the terms of severance. You get 1 or 3 months of salary. You get whatever is due to you in terms of your RVUs or whatever production you've done, what the time period for that would be. And then there also brings up reasons why they can terminate you for cause, which is like losing your license, being in a DUI, not showing up for work, not being able to see Medicare patients for fraud reasons. So those are all usually listed, and they're pretty standard. So can a legal contract be unfair? Sure it can. You know, just because a contract is legal and your lawyer read it over, it doesn't actually mean it's a fair contract. And the reason why I bring that up is in the recent 3 years since I've been doing this gig as Women in Cardiology chair, I've actually had the opportunity to read many contracts that people have sent me from across the country. And in full disclosure, I only read them to help understand if it's a fair or sensible contract and not, of course, to get into the legality of it. So I would strongly encourage you to show your contract to a lawyer, but also show your contract to someone who is familiar with looking at the work that the contract requires. So I'll give you a couple of examples. First one was, I saw a contract for a young woman who was going to be starting a new service line in a university hospital that did not have that service line. So it was a line to start a structural heart disease program. But while starting that new program, this young woman was not given any admin support. She was expected to produce 75% of the RVUs, which I can give a whole talk on a different day, that the other people were doing. And there was no explanation of where her patients would come from, what her clinic support would be, how many weeks of hospital work she would do. So where would she generate these RVUs that were supposed to be generated when she's starting a brand new service line? And it also said in her contract that she was expected to go see people in multiple areas, build the business, get the business plan done. So it just seemed like it was a setup to fail. So if a lawyer read that contract is absolutely legal. There is nothing illegal about the contract. But when you read that contract, you know that this person is not going to be able to achieve the parameters set for that person. And so, you know, I was able to counsel her, and she was able to go back and renegotiate a contract so that she had a two-year window where she wasn't expected to produce a certain number of RVUs till she was able to get up to speed, and she was able to get some administrative support. So that would actually help the university and her both be successful. So I think it's really important to look at contracts in terms of just what is the work that is required to you, where is that work going to come from, how are you going to fit into the particular paradigm that already exists in that practice, and are you being set up to succeed, are you being set up to fail? So people ask me, like, when I go to an interview, what should I ask first? Well, I would always say that avoid making salary your first question. This is like, I don't like to use the word dating, but it's like, you know, you're signing up for a long-term relationship with these people. So the first step always is, don't start out by talking about how much salary you require. And, you know, you should just defer it in the first 2 or 3 meetings. That is not the most important thing at that point. And don't take me wrong, I think money is important, and I think you should negotiate for the highest salary, but I just don't think that is the first question when you join a job. If you're really curious, you could inquire what the range is. Or if they ask you, you could reveal what range you're looking for. But again, let's not make salary your first question. And how do you nail your salary negotiation? So, you know, you need to understand that people need to like you. Because if you're not likable, not in the sense of likable as a man liking a woman, but like somebody who's seen as a team player, somebody who's seen as a good fit, somebody who would fit into the culture of the practice, none of the other discussion is going to take place. And then as long as people feel you'd be a good fit, again, it's a crucial conversation. They're much more likely to give you what you want if they feel like you're a good fit for this place. So you can help them understand why you deserve what you're requesting. So you can show them research about salaries, you can show them talk about your skill set. And you can say that, you know, you're willing to stay on the table. You should not be delivering any ultimatums. You should try to stay excited about the position. And then you should also understand that the person who's offering you a job has certain degrees of constraints. So how do you know your values? You can do some research, kind of know what you would like to accept before starting the negotiation. So it's like when you sell your house, you know kind of what is your lowest minimum that you would accept for selling your house because you're looking to move to a nicer, different location. So, you know, when you're looking for a job, you have to accept some trade-offs because if you're looking for a job in a very popular urban location where there are a lot of people applying for jobs, you may not be able to get the salary you want. If you're looking for a job in a rural area where nobody's looking for a job and they want someone to come, you may have a lot more leverage. You can consult recent salary guides like the MGMA, salary1.com, Medscape, and Medaxiom. Remember that salaries for the same exact job are very different in different geographical locations. So salaries in urban centers tend to be lower than salaries in rural centers. Also, salaries at private practice sometimes can be higher than in academia. Sometimes salaries in independent private practice can be lower than hospital employed private practice. So kind of understanding who your employer is can help you understand what kind of salary you might expect. And again, like I said, when you make, there are trade-offs for the kind of institution you pick, because like Dr. Bradley brought up, somebody who's in private practice may not have access to certain vehicles to save money pre-tax that others might. So keep that in your equation as well. Timing is important. So, you know, it's good to negotiate once you get a formal offer from the employer. It's good to tell them what salary you're looking for once you have a discussion about a formal employment. And you know, or if the employer wants you to write it down. But no matter what you are offered, it is always okay to say you need time to consider to make an informed decision. So you never, ever, ever have to give an answer right then. You'll say, thank you, I'm really excited. I'm going to take this back and review it, and I will get back with you with my thoughts, because this way you don't have to make a decision right then. You don't have to go back and forth. You take the contract, you go home. Now you're all going to remember, read your contracts. It's usually only 5 or 6 pages long, and we've all read through stuff that's much more longer and much more boring in our lives. So take time to read it. If you don't understand it, call me, I will help you understand it. And then take time to consider what are all the things that are being offered in that contract. So fully understand what their requirements and expectations are. You know, I had someone call me and said, you know, she was recruited to be reading MRIs in this hospital that already had one person who read MRIs. And then once she got there, they were not that busy, and the practice decided to hire a third person to read MRIs. And she was concerned that the first person there was already established, and she was kind of building her practice, and this having a third person there is going to take away from her numbers. But if she had read her contract, there was nowhere in her contract that she was guaranteed reading rights. So, you know, just being aware of those things is important. Develop your own list of must-haves and nice-to-haves. So a must-have might be you want half a day off during the week, or you might want, you know, certain holidays off, or you might want administrative time, or you might want research time. And nice-to-haves might be, you know, CME budget that's higher than normal. Also, when you read through the contract, make sure that there's no confusion about the skills that are required. So, you know, your skills that might be required is that you're board certified in X, Y, or Z, and make sure that you actually meet that requirement, and they're just not assuming that you meet the requirement. And remember that all negotiations require trade-offs. So this is every negotiation is a conversation. It is not a confrontation. So it's really important when you go in for these discussions, remember our whole discussion about crucial conversation. This is a very crucial conversation. Work on your emotions, practice your speech, think about what your response might be to the to's and fro's, but remain flexible. And remember that employers really are not, it takes a lot of effort for them to come and recruit people too. So the employer may be just as nervous as you, thinking that you have multiple offers on the table and you may not take their offer. You know, so if you are deciding between two offers, try to be transparent with your employer. I don't think it's nice to leave people hanging while you're trying to manage 3 different employees and trying to play a game about getting the best salary. Be honest and say what you like about one practice or not about the other, and what's swaying your decision. And that might help that particular person to nudge your salary up or offer you those benefits that you like. And finally, remember, it's a crucial conversation. Money is important, but like Dr. Bradley reminded us, we pay about 50% of our salary in taxes. So when you're looking at your salary, you also want to look at your benefits and see what kind of benefits are being offered. Like flex time, protected time, health insurance, retirement, student loan payments, vacations, CME budget. So take all of that into account and not just the total number of the salary. And just as important as the salary is also the culture of the place and your colleagues, because remember, you will be spending a lot of time with these people. And it's really important to be happy in your job, because if you can be happy and work with a good group of people, you will be productive, you will be enjoying your work, and you will end up making more money. So keeping those in mind, I'm happy to answer any questions. This is my email and this is my Twitter account. If you ever want me to read your contract, you can email it to me, or you can send me a direct message and we can connect, and I would be happy to give you my 2 cents. Thanks for your attention. And I'm happy to take any questions.
Well, can everybody hear me okay? Yeah. Dr. Singh, thank you so much. I don't see any questions right now in the chat, but why don't we keep moving with our afternoon? I have the opportunity to introduce Dr. Denise Zingman. She is professor of internal medicine and cardiovascular medicine. She's the clinical cardiac EP fellowship training director at the University of Iowa. And she is going to talk to us probably about the most difficult thing that I've found as being a cardiologist, which is how to balance family and career in cardiology. Dr. Zingman?
Great, thank you for the very nice introduction. I hope that my screen is going to be shared here. One second. All right, are you able to see my slides okay?
Yes, Denise, looks good.
Okay, wonderful. So this is a topic that has received a lot of attention, and there are many perspectives on this. And so the direction that I wanted to take was, addressing really, sometimes I think that when you hear the term work-life balance, that it appears to be, a categorization or a compartmentalization of different parts of your existence, essentially. My disclosure is nothing to disclose here. So this slide kind of sums up that idea that a lot of times this topic is framed as, you have your work identity, your work tasks, and then on the other side, you have other things that round out your existence. You have family, hobbies, health, your spiritual life, outside interests, volunteer work, etc., and that these two are somehow in competition. And many of the advice sources that you may see or read about on work-life balance often present things in this way. How to compartmentalize well, how to shut off your work mindset and focus, and instead switch over to your hobbies, your family, or etc. And I rather have a different perspective that I think also you can find when reading some of the literature and well-studied experts who speak on this point, which is that work-life balance doesn't necessarily mean compartmentalization. And one example I give of that is particularly in the healthcare field. I think a lot of us really feel that our nature or our work as a physician and also as nurses and nurse practitioners is not just a job that we go to, but is actually an identity. So it's not something that we turn off when we're in another location or another part of our life. It's not just something we go and do and then don't really feel that we're a doctor or healthcare worker when we're doing other things. So I do think that in particular, and I'm sure there are other fields as well, but I think in medicine in particular, a lot of us see our role as a doctor, nurse practitioner, et cetera, as an identity. And so there may actually be some harm in compartmentalizing. The other issue, I think, that when it comes to this being your identity is that, women in medicine still are, in many cases and in many fields, the exception, not the rule. And in broader society, I think that when we are not with our white coat in the hospital doing patient care sorts of tasks or medical administrative tasks and such, we don't necessarily look like doctors in the sense that, that we don't fit the stereotype. And I remember Mahi very nicely came out with the masks that say, she looks like a cardiologist, which is fantastic. So people don't necessarily know you're a cardiologist when you're out in real life, but I think it is very valuable for people to know that nice lady, walking through the supermarket, is a professional who, who is, contributing a very, valuable role to society. I think it's really important with one's children, for instance. And so when I think about work-life balance, I reject the idea that I should check my physicianhood at the hospital door and not bring it home with me, because I think it's very important that my children, who are both sons, by the way, see that their mother is passionate about her work, very good at her job, and is an involved physician. I think obviously if you have daughters as well, that's also very important, but I think it is important, for everybody's children, for mentorship, and for society at large to not shed that identity at the hospital or clinic door, but rather bring that into other aspects of your life. So instead of this compartmentalization, here's the model that I like to use. Okay, it's not the best picture, but you get the idea. It's harmony without compartmentalization. And you can put your peas and carrots in one little pile on one part of your plate and your meat on another, or you can make a delicious curry where everything is contributing to the deliciousness of the meal, but without actually being compartmentalized. But still having, character of its own. And so, as I wrote on the top of the slide, you can tell it's in harmony because it feels good or it tastes good. It doesn't necessarily need to all be separated. So another point that I have come to appreciate in with the concept of work-life balance is illustrated here with these mountain goats. And the idea here with the mountain goats is that they're doing a pretty difficult task, right? They're living on the edge, literally, but they're successful because they are supported by multiple points of stability. And the better footing you have, the more successful you'll be in both your work and your non-work endeavors. And so, what are these feet that are, allowing these goats to do these amazing things? You can think of those feet as being your social supports. And that could include friends who support your aspirations and your dreams. It can be mentors, and should be mentors. Having a mentor or multiple mentors is extremely valuable. And I think it's something that sometimes doesn't get the attention that it deserves. Having a supported significant other is extremely important. And on the other hand, having a non-supportive one can be very difficult on both your career and your family. Having parents or other family that are there for you. And the other one is household employees. I think for me anyway, and maybe a lot of other people, I grew up in a lower middle income family, and the concept of having household employees was just, that was something that I remember the Brady Bunch had a cook in the house, and I thought that was pretty, highfalutin, when I was a little kid. But when you're trying to do difficult things at work and, with long hours, and you want to have time, quality time with your family, hiring household employees is a fantastic way to manage some of those tasks that otherwise can't get done, whether that be a nanny, a cook, a cleaner, a gardener, or landscaper, etc. That can be very valuable and well worth the cost. Other things that can act as supports or stability for doing amazing things are the the non-human resources. And that could include things like your health, having good health, getting good sleep, good diet, etc. It can be where you live in terms of access to grocery store without having to drive long distances. It can be solid finances, as we just heard about, feeling that you're financially secure and you're not having that stress to manage. Basic things like having a good, reliable car that's not going to break down on you and make you late, or whatever other transportation. Reliable transportation is key. And then, having a stable living situation overall. So those are different things that, are the billy goat legs here. And of course, life is chaotic. And at some point, one of your legs is going to give out. But if your other legs are on solid footing, so to speak, you're much likely to be able to maintain your progress and build on that than if you have, kind of shaky footing to start with. So I think this is very important to having, optimal work-life balances to, as much as possible, keep these supports in place. Even if you feel like, well, you don't really need this or that right now, I think that having those things there optimized as much as possible can catch you when you do have an unexpected sort of a challenge come up. And so here are a couple of takeaway points from what I've been discussing. The one, of course, is that work is part of our identity to many people, and that the work-life balance shouldn't necessarily mean compartmentalization or a dichotomy where the two do not cross. Language frames thought. And so sometimes, if you think balance means oppositional and harmony means more, things cooperating with each other, I tend more towards the philosophy of the second, where it's work-life harmony that we're trying to reach, not necessarily one balanced against the other. And there's a lot of value in bringing your work into your non-work life, so to speak, and vice versa. And again, doing amazing things in all aspects, whether it's at home with our family, with our hobbies, in our work life, is important. But it's also really nice to be seen and understood to be doing those sorts of things, because it is a mentorship opportunity for our own children and other people in our life to kind of change the view of society and women in it and women in the workplace. And so, women are often breaking molds and setting new standards. But I think we need to be seen doing this. And I think that'll be good for everyone. And again, building strong relationships and networks, having that strong footing, both at home and at work, will help when things inevitably, a new challenge pops up. And with that, I close. If I'm happy to answer any questions.
Can you hear me okay?
Mm-hmm. Yes, I can.
See, I'm looking at the question answer and the chat. Are there any questions for Dr. Zingman?
I don't see any specific questions, but I think that was a great review, Denise. I think you kind of laid it out very clearly how it's very hard to separate our profession from our personal life, right? I mean, it's kind of part of who we are every day, in and out. So I completely agree with you. I think you laid it out very nicely. That probably brings it out a little more important in making sure we kind of carve a little time for ourselves in the middle of this busyness or busy schedule, and where everything else is a priority, but ourselves, we just have to make sure at least sometime we make sure we are the priority for ourselves too. So we take care of ourselves. But, I think that was a great review. Thank you.
Dr. Zingman, if I might ask, you did a great job of how we can impart our professional lives more into our personal lives. I'm very curious about the successful strategies you've used to exercise your personal priorities in the professional realm. So when there are family obligations, family priorities, how have you negotiated that or navigated that situation in the workplace?
That's a really great question. And it's a tough one too, because I think I have personally felt worried because I'm, as I believe you are too, the only female in my specialty. And so I often feel a little bit nervous when people bring up, oh, you probably need to leave early because, we understand you need time to take care of your kids. And, I think my male colleagues probably would like to have time to take care of their children, to be, with them as well. But I'm sensitive about that because I don't want to be perceived professionally as you know, the mom first and the electrophysiologist second, because they're both important to me, and I think they're probably both to all my colleagues too. So I think that's a really challenging question. I do like to talk about, you know, my kids and their achievements and, you know, what I do with them. But it's a fine line to balance. I'd be curious to hear if you have any suggestions on that front.
Well, I have no family life to speak of, so I'm working on it. But I find there are more assumptions made about my lack of reproduction in my life, that I don't have other personal priorities, and so it's an interesting change. And like you said, it's a reflection of me being the singular female within my division and now department, that when it comes to call schedules or holidays away, well, that's when my kids are off. I have to be off. Like, I need every Christmas off. Well, I've got a family too. I just didn't create it from my womb, that I want to spend with as well. And so it has been a exceptionally challenging landscape to navigate when you do need to introduce your personal priorities without compromising the seriousness with which you're taken professionally.
I can speak to that a little bit. I work with 14 guys, and when I joined my practice 18 years ago, I had a 2- and 5-year-old, and everybody and my husband's a physician. So everybody in my practice, when I was looking for jobs, assumed I was looking for a part-time job, and everybody assumed that I would always want to be running off at 4 o'clock because, I have young children. And I really spoke up and said, I'm an equal part. I mean, especially when I became a partner, I'm an equal partner. If we want to do things differently and I want to take more time off, then either I'll take a pay cut or I'll get a pay increase for the people who stay. So I think you need to really bring it back to the professionalism of the job, to your productivity, and and the other thing that I have done less of, which I used to do more of in the past, is I don't necessarily talk about my personal life. And so people know that I have children, they know I'm married, but I don't necessarily, all my conversations with my partners are not necessarily about my children. They're often about how we are running the practice. I'm a managing partner for the last 5 years, so you just have to change the conversation and then say, if you want me to take extra call, then I would like to be compensated for the extra call because so-and-so is not taking extra call. So you need to turn it into a business and a professional discussion and take it away from the private discussion. I have also found that with my younger partners, they're just as interested in spending time with their children compared to my older partners. And so that conversation is becoming less and less of an issue. I am often offering to take call for them so they can go, be a coach at their kids' hockey team because my kids are in college. So,
right.
So it's kind of flipped in my practice now, which is kind of interesting. But I just feel like one thing that really helped me was speaking less about my personal life and whatever I was doing in my personal life. And secondly, also bringing all discussions back to professionalism, the work, and the sharing of work, and how the sharing of work is being compensated. So people who want to take more time off need to be compensated less than people who are taking less time off for whatever reason they're doing it. So making it professional and career, and then what you do in your free time is totally, your own business. It really is nobody else's business.
Thank you. That's terrific advice. Thank you both.
And to echo that, Dr. Singh, I would absolutely agree with you. I think that what I've seen, I'm solidly mid career in a 70 some odd cardiology group in the Midwest, where there are 5 women in the group. And what I have seen though, is that as individuals are transitioning, what a great segue, from fit to early career, whether they be men or women, but my younger male partners, they are taking more time away to spend time with their young kids. And I think acknowledging that it's not just a female issue, but both parent issue is also important. And I think one of our participants on our chat had mentioned that. So what a great discussion. Thank you so much, Dr. Zingman. I'm gonna roll ahead and introduce Dr. Poonam
Velikabuti, sorry, who is going to speak to us about transitioning from fit to early career. She's a structural interventional cardiologist and an assistant professor of medicine and the associate program director for cardiovascular medicine at the University of Nebraska. Dr. Velikabuti. I think you're muted. Poonam.
So there we go.
There
Sorry
you go.
about that. Let's switch this. Can you all see my screen?
Yes, that's perfect, Poonam. Go ahead.
Yeah, thank you so much for the introduction, Dr. Saxena. Again, my name is Poonam Velikabuti. I'm a early career interventional cardiologist at the University of Nebraska. This is my 4th year out of training. So I just wanted to, since this is an ACC event, I just wanted to go through my few years that I've spent with ACC as a fellow and as an early career and show you how, how things started and how I'm able to remain involved as an early career. So my fellowship was 5 years because I did 3 years of cardiology, a year of interventional, and a year of structural heart disease. So when I started my fellowship, it was in at the University of Missouri in Columbia, where I really didn't know anybody at the ACC or at the time, social media. I wasn't on social media very much, and I really, connecting wasn't that easy at the time. It was only in 2013 or so, but I really wasn't into social media, so it felt very lonely. You couldn't, I really didn't know very many people. So the first advice I got was, I had attended a lot of talks by Dr. Melissa Wood, Dr. Sandy Lewis, and many week leaders. And the first thing was to just get involved, participate in these fellow events or things like that. And so my first participation was in Fits on the Go. And surprisingly, my first interviewee was Dr. Eugene Braunwald. I was, dumbstruck. I didn't know what to say, but anyway, that was my first participation with the fellows events. And then going from there, in my first year of fellowship, I had an amazing case that I had submitted to the ACC, and luckily I was selected. It was, I had a chance to work with the National Fit Council members to work on my case and present to an amazing group of faculty. And then following that, I represented the Missouri chapter at Ledge Conference and so on and so forth. And I was selected to the Missouri chapter council as the FIT representative. And since then, I've been, I attended the meetings, participated and organized, Fit Jeopardy. And, Dr. Tonya Singh was also an active member who had, I think, I met through the Missouri ACC. And then one thing led to another, and I was, with the support of Dr. Eddie Cates, I was selected to the National Fit section. And believe me, I'd applied to that before, but then I hadn't been selected. But after being a part of the Missouri ACC Fit Council and getting to know folks and doing stuff, I finally was selected. And from there, we had the opportunity to participate in a leadership forum that happens every year. To help new members and new council folks and everyone to just get, become a better leader. And so this was another place where I could really meet people and learn a lot. And then from there, you have a lot of opportunities as a fellow. I attended the Teaching Tomorrow's Teachers Conference, which was an amazing group of folks where we learned how to make presentations and etc. I was the editor for the FIT newsletter, hosted, wrote questions and hosted some sessions for Fit, Jeopardy, and then participated in the pre-ledge Women in Cardiology conferences. This was one of the best things I think I've done. And I never miss this conference, and I really attend this every year where we really get to go, network and meet, women leaders across the country. At this time, I moved to Rhode Island, Brown University for a fellow, for my interventional fellowship, and continued to be active. Dr. Rick Chazell, the president at the time, was our speaker, and so got a chance to meet him. And then I was selected to the ACC Axel editorial board. And this was one of, I think, a very good segue to get into meeting trialists and understanding trials, because we were asked to interview in all these big trialists during national meetings. And so I think this was a very good opportunity to learn and grow as in an editorial way. Following all this, I was elected to be chair of the FIT section. I would say selected. We organized a pre-leg FIT meeting for the first time. And then we had a very big social media group that was so active, and every member of that group is a leader now, either completing their training or just an early career, doing great things. We included 10 fellows in the annual session program planning committee with Dr. Mina Walsh. She was wonderful in letting us do that. I participated on the interventional council pathway and helped organize some sessions. And then that was the, once I finished, I was a past chair. That was my segue into the early career section. So one of the proud moments in my career, I would say, was to get this FACC. And, one of the best ceremonies, and I really urge all early careers and graduating FITs to apply timely and get this as soon as you can, because it's a great way to network, connect. And then once in the early career section, we organized a pre-leg early career meeting as well. And then, with everything, I was selected to the Leadership Academy, a 2-year program with a capstone project. And, a lot of non-clinical skills were taught during these 2 years. And really, my focus was burnout, and I was able to join a work group with Dr. Lakshmi Mehta and leaders of the college, and created a toolkit for early career wellness. And with that, I was selected to be chair of the early career section. And I started my role early because Dr. Sandy Lewis wanted me to do so. So this is my Leadership Academy cohort, an amazing group that we learn from each other, and we meet during meetings and conferences. So this is another program that the ACC offers that is just amazing, and a lot of learning outside of the clinical duties. And this is our early career section that we have the chance to work together for a couple of years. Amazing leaders across the country. So out of all this, what came out of all this was that when I started my job as a structural interventional cardiologist, it was not just clinical. There were a lot of other things that I never knew how all these non-clinical skills and all these things would pan out or help me. But they did, because I concentrate on coronary and structural work. I'm passionate about high-risk coronary work, and I'm also building the mitral valve program. So you give a lot of talks. So, we've done so many presentations, Stump the Professor, Teaching Tomorrow's Teachers. So it was just making a presentation and giving talks was something that I had learned during my fellowship and the transitions. I'm very interested in being a part of clinical trials. So I enrolled for a lot of multi-center trials, and I'm passionate about enrolling women in clinical trials. So, this is communication. How do you communicate to the patient? How do you get them interested in these trials and keep these going? So a lot of non-clinical skills do come into the picture. And then as an associate program director for the cardiology fellowship, I do mentor a lot of fellows and other house staff who are interested. It's just a great way to give back, and learning through the hoops of the fellowship. And then as an early career, I've been through so many different programs and met so many people and learned so much that all this helps me when I work with them. And at the same time, I do work with mentors for myself as well. who are not just at my institution, but at multiple institutions. And then I keep myself active with the ACC, which is my primary home as a cardiologist. And also I'm an interventional cardiologist. So I work with the SCI and I'm active there as well. With journals, I review a lot of journals, but I have not taken on much because I want to concentrate on one or two things. And so I really do social media work for cardiovascular interventions, which is my focus. And I'm an associate editor for European Heart Journal case reports. So again, the writing and all this is really helpful when you're mentoring fellows and stuff. And then family and self. My husband's a busy electrophysiologist, and we both share responsibilities equally. And sometimes maybe my husband may want to do more even when I'm busy, and the other way around. So we really work around our schedules, and there's no complaining or like who's doing what kind of thing. We do keep ourselves very busy. We travel, we participate in sports, we exercise, and as a family, we do trips frequently to keep us away. And when we're away, we're completely away, which I've just learned to do. So I want to talk about the opportunities, just 3 important things when we talk about this transition from fit to early career. As a fit, you have a lot of opportunities. People want you to take on stuff and things like that. But as an early career, you feel like sometimes you're lost and you're in silo, and you are maybe have to run after an opportunity. So there's free membership to societies, there's awards that are available, multiple FIT activities, writing and presentation opportunities from your faculty, and access to a lot of mentors at your institution. But when you're in an early career, you start to pay membership fees. You have to think, which societies do I want to pick? You just can't pick all these societies. So you have to pick and choose where you want to be active, what you want to get out of the society, because you're paying membership dues. Awards are fewer, but they are available, and you have to keep an eye out. You have less time because now there's no duty hours, there's no protected time, nothing. And opportunities may seem fewer than when you were a fellow, and you have this decreased access to mentors. Of course, now you're at just one institution, and you may be at a private practice in a remote place where really you may not have access to the kind of mentor that you like. Everybody's busy in their work. So as an FIT, I would say we use all these opportunities, but also important to start planning early for your early career. For example, if you're writing a grant as a 3rd-year fellow, write something that may span 2 years or may lay the foundation for what you want to do as an early career. When you find a mentor, maybe find a mentor who can also mentor you as an early career. This way you may not have to switch your mentor over and over again. So it's important as an early career to look for opportunities, and when they don't exist, create them for yourself, because you know what your skill set is. Let's say you can build a women's program in your institution. There's so many opportunities that you can build for yourself based on the deficiencies that exist. And then you have to be selective. You cannot take every opportunity, and you have to say no when you can do something, because your goals or what you do have to align with your long-term goals. And then you can reach out to mentors. Believe me, now with social media and various other ways to reach out, it's much more easier than it's been many years ago. So make use of that and reach out to your mentors, to folks outside your institution. And then keep networking, because as a fellow, you go to conferences, you meet people, but as an early career, maybe it decreases a little bit. But remember, networking, and you don't know what opportunity may be and who may help you in what way. There's a lot of fellows who Dr. Singh has helped with contract negotiation. They're not her fellows, and she's in a private practice, but all these fellows come and tell me, Dr. Singh's looked at our contract and helped us. So this is what networking is about, right? So I think as an early career, you can reach out, be a part of women in cardiology groups, and you get to help one another. And remember, everything is interlinked, and one thing leads to another. So don't feel sad that something didn't go through or something worked out, but there's nothing come out of it, because everything you put in will definitely have results at a later date. Let's talk a little bit about responsibilities. As a fit, you're always, you're not the most responsible. There's an attending above you. Then if you're a junior fellow, there's senior fellows about you, and you're always protected, and there's many leadership opportunities. Whereas as an early career, you're probably, once you start your job, people are looking up to you as a specialist. You're the cardiologist. So not only are you responsible for yourself, but if you're in a teaching institution, you have a team, you're also responsible for them. And there's no duty or rules. Believe me, that there's just not going to be enough time for everything. And many a times we have this imposter syndrome. So it's really, really important to keep ourselves up to date. Attend CME conferences when we can. Now it's, you have the access to virtual conferences, and then a lot of online tools like ACC, UpToDate, etc. And the most important thing is ask for help. It's not a weakness to ask for help. It is a strength. And take on responsibilities which align with your long-term goals. And then importantly, if you want to do some leadership courses, they are available, like the ACC Leadership Academy or some other leadership courses across various society, or even your institutions, or Women in Cardiology has